Good morning, everyone. Am I audible?
Yes, you are audible and visible.
Yes. Thank you, sir. Welcome you, sir, and welcome everyone uh, for this Semicon 2022. And
Virtual.
yes, a virtual conference. Yes, we initially planned for a physical one, but yes, because of the COVID scenario, we are not able to do it. So hence, we are planning to go ahead with the virtual concept only. So our first speaker is Dr. Chetan. Dr. Dr. Chetan.
Good morning. I'm Dr. Chetan. Thank you, the host, for the wonderful efforts to host a virtual conference in a real COVID time. So, shall I start?
Yes, Dr. Chetan. Uh, would like you to start the session.
Yes. Good morning. I'm Dr. Chetan. I'm a anesthetist by profession and a critical care specialist. I would be speaking on the topic anaphylaxis. So I'll be starting covering the topic with the headings of definition, etiology, pathological mechanism, what are the symptoms and signs with the patient, and how we can help the patient, what is the treatment modalities. So coming to the word anaphylaxis, it is without, ana is without and phylaxis is protection. So apparently the individual is having no protection for the trigger. Systemic hypersensitivity with multi-system involvement. It's acute on onset within 5 to 30 minutes. The patient can have a life-threatening airway or breathing problem. It can be a biphasic reaction. The diagnosis is usually clinical. One out of 1400 population can have a lifetime one-time experience of anaphylaxis in some point of their life, and up to 1000 cases can out of 1 lakh people can visit ED for the same type of problems like anaphylaxis. And mortality is also well known, although because of respiratory who have lot comorbids like elderly patients or newborns. This illness is not without any history. Egyptians have notified the said thing in the past 2641 BC, and although the history does not uh, support, but it is definitely a well-known thing. And the two French physiologists, Charles Richet and Paul Potier, have worked significantly on the anaphylaxis, and even Richet has won the Nobel Prize in medicine for work on the anaphylaxis. There are few criteria of diagnosis, which includes acute onset, involvement of multi-organ, respiratory compromise, and blood pressure. So we have to see the criteria to diagnose a anaphylaxis, which is usually clinical. Coming to etiology, idiopathic takes the larger chunk, then comes the food, then comes the drugs, then latex, hormones, insect bites, and then comes the exercise. Out of pharmacological agents, antibiotic takes the biggest chunk, then comes the NSAIDs or IV contrast agents. Insect bites are not uncommon. Even foods like seafood, peanuts, wheat can have anaphylactic reactions to the people who are sensitive to it. Then latex, we can have anaphylaxis from any type point of contact, skin contact, ingestion, or inhalation. It is manifested by allergic uh, response of the body with IgE mediated or maybe non-IgE mediated. Then we can have non-allergic mediation of anaphylaxis with the disturbance of arachidonic acid metabolism, like with the drugs of aspirin, or we can have non-allergic manifestation with the release of mast cells or basophils, like opioids, exercise, or some dialysis membrane or contrast. Coming to sign and symptoms, the patient usually has skin manifestations that come form of itching, flushing, swelling. Eyes have swelling around the eyes, tearing, redness, itching. Nose has a running nose. Patient has a swelling of the tongue, nasal congestion. In the throat, the patient can have coughing, chest tightness, sensation of choking, change in voice. In the cardiovascular, the patient can have low blood pressure, dizziness, weakness, fainting, or irregular pulse. Then the patient can have nausea, vomiting, or even diarrhea can be the manifestation. Patient can have anxiety or feeling of impending doom in the signs to the central nervous system. So apparently all the organs of the body are involved when the patient has an anaphylactic reaction. It has to be very smartly differentiated with between the other things like asthma, severe sepsis, or embolism, which have a little bit of different treatment modalities as compared to anaphylaxis. So the diagnosis is based upon the symptoms that occur suddenly after being exposed to a potential trigger. We have to smartly rule out the other differential diagnosis. There is a possibility of increase of histamine in the blood, which rises within the 5 to 10 minutes of the response, and it remains elevated up to 60 minutes. But urinary histamine metabolites can be elevated for the longer period of time, although we cannot use much in the clinical practice. Then there is a role of serum tryptases, which also rises in the serum in 90 minutes and can persist for some time up to 6 hours. So coming to the management, we have to smartly follow the ABCDE pattern. Look for the onset of illness, look for the threatened airway and breathing or circulation, and if required, call for help. Let the patient lie on the flat, raise the legs, give epinephrine. Epinephrine is the gold standard to manage an anaphylactic reaction, which is intramuscular. I will discuss in the doses shortly. So coming to management wise, we have to establish the airway, give the patient oxygen, give fluid, monitor pulse, ECG, and blood pressure. So we have to place the patient in the tenderloin position with the supine torso and the legs up. Try to establish and maintain airway, give oxygen. If there is a possibility of set sting or injection site, we have to place a tourniquet so that the circulation remains confined. We have to give epinephrine, which can be given intramuscularly or at the antigen injection site. The dose of epinephrine is 0.01 milligram per kg up to 0.5 milligram intramuscularly, although it can be given subcutaneous as well. Intravenously has been used in the cases of anaphylactic septic shocks. Anaphylactic shocks, epinephrine has been even given by the endotracheal tube. Comparing intramuscular and subcutaneous, intramuscular is definitely better than subcutaneous, and anterolateral thigh is the better thing than arm intramuscular injection. So we have option of IM epinephrine. We have ampule which we can load, or we have EpiPens. EpiPens comes in the two strengths, and we can use which are ready-made epinephrine pre-filled syringes which can be given intramuscularly. Now coming to the controversial part of the talk, role of corticosteroids. There is no clinical evidence to support the role of steroids in the acute management of anaphylaxis. Although if we look at the literature, use of corticosteroids is more prevalent use of IM epinephrine in anaphylaxis. But there is no role for steroids, not even for the anaphylaxis. We can repeat the epinephrine if symptoms are persisting. We have to observe the patient for 4 hours. If there is a biphasic reaction, which is common up to 20% of patients, we have to monitor the patient for the longer interval. And the gold standard treatment here again is intramuscular epinephrine. What do we do further? If the patient is elderly or children, we must admit them and observe. If the patient is having unresolved symptoms, we should observe them by hospitalization. if there is a delay in epinephrine treatment, we must observe them. So we have to observe few patients by admitting if the patients are having persistent symptoms. Definitely, we should try to refer a patient to immunologist or allergy specialist if the patient is more prone to this type of problems. How can we prevent it? If we know the allergen, we should try to avoid to take it. Keep a EpiPen at hand all times. Wear medic alert bracelets if we know what we are allergic to. There is a Venom immunotherapy, which is very effective in protecting insect allergic individuals. So this is how we give IM epinephrine. To summarize, it's a acute onset multi-organ insult. Previous reaction does not predict the severity of the next time. We have to have a strong suspicion. Epinephrine is the drug of choice for anaphylaxis, which is intramuscularly. Early IM epinephrine reduces the risk of biphasic reaction. Patient should be discharged home with EpiPen and education and allergist referral. Thank you very much. I'm open to questions.
Thank you, Dr. Goel.
Thank you very much, sir.
Yeah, it was a wonderful talk. Now, may I welcome Dr. Kishalay Datto, a very respected doctor. Sir belongs to Max Hospital, Shalimar Bagh. He is director and HOD of emergency medicine there. Sir, over to you, sir.
Thank you, Dr. Goel. Your presentation was excellent. A lot of our doctors use a lot of steroids till now. We had a vision on that steroid use. Thank you for excellent presentation. At the end of the session, we'll all discuss together. So we have time. Now, as we are on short time, we should go to our next presentation.
Okay, thank you, sir.
Thank you. Thank you so much. Our next presenter will be Dr. Pranab Barua. He will be teaching us how to read an ECG.
Sir, excuse me, sir. Dr. Pranab is down with dengue, down with COVID. So I have been asked.
Oh, he's down with COVID. So next will be Dr. Kamal.
Yes, sir. Actually, many of our consultants are already down with COVID, but we are very thankful with them that, even if with COVID and in difficult scenario, they are with us, they are helping and guiding. Dr. Pranab is very kind. He has sent his PPT for the students, so that we are going to upload after the whole day. Now, actually, Dr. Kamal will be taking over his session.
So this presentation will be done by Dr. Kamal. Kamal will be talking on ABG, a simple approach. The Kamal, I had worked already with Dr. Kamal. He is working with us in Max Healthcare. So he has done his MRChem and he has done his MEM from Max Healthcare only, and he is the head of Max Smart Hospital. He will be taking us on this journey of how to interpret ABG in a very simple way. Over to you, Kamal.
Thank you, sir. Good morning, everyone. If you are working in emergency department, so ABG is a must-have tool in your hands, like other point of care testing, like ECG. We do ECG to find out if there is a STEMI. So we do ABG to find out if there is a sepsis or other metabolic acidosis or any other thing is going on. So it's very helpful tool in your hands to identify sick patients very quickly in ABD. Be it DK, be it sepsis, be it respiratory acidosis. So we will be learning about some basic mantra of ABG in a very simple way. So information is available on internet, all you can read. But how to read ABG, we will discuss today. So we will going stepwise approach. So there are 6 mantra to read ABG. So first of all, always check pH. Okay, always check pH. Find out if there is acidemia or alkalemia. Fine. We will discuss about it later. So then find out that what type of primary disorder is present. Metabolic acidosis, alkalosis, respiratory acidosis, alkalosis, acute or chronic. Then third step is to find out if adequate compensation is present or not. Okay. So we will discuss about it. What is adequate compensation? So if respiratory compensation is present, we have to find out, is it acute or chronic? And if there is a metabolic acidosis, we have to check anion gap. Okay, to find out it is high anion gap, normal anion gap, metabolic acidosis. So if there is a high anion gap metabolic acidosis, we have to check a delta gap to find out if there is a concomitant, any other metabolic disorder is going on or lurking behind the metabolic acidosis. Maybe some non-gap metabolic acidosis is also associated with high gap metabolic acidosis. You have to find with delta gap. And at the last, we will see some examples of every acid-base disorder. So first of all, what are the normals? So pH should be between 7.35 to 7.45. PCO2 should be between 35 to 45. Bicarb 22 to 26. Anion gap should be between 10 to 14. So this is the first step. Check pH. So if pH is less than 7.35, is acidemia. More than 7.45, it's alkalemia. But what is acidosis? It's different than acidemia. Acidosis is pathological process that lowers or raises partial pressure of carbon dioxide. And alkalosis is pathological process that raises or lowers partial pressure of carbon dioxide. So let's practice one ABG. So she's a 58-year-old female with CKD, nausea, diarrhea, and acute respiratory distress. ABG shows 7.3 pH, 7.23 pH. PCO2 is 17, PO2 is 235, sodium is 123, chloride 97, bicarb 7, BUN 119, creatinine is 5.1. Is it acidemia or alkalemia? As we discussed, pH should be less than 7.35 is acidemia. So it is acidemia. Yes. So now we have to find out what type of primary disorder is present. Yes, now we have established that patient is having acidemia. Now second step is find out what type of primary disorder is present. So basically we have four main disorders like metabolic acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis. So if you want to remember, whenever there is a metabolic disorder, so primary pH, bicarb and compensatory response, that is PCO2, will be in the same direction. If acidosis, pH will be lower, bicarb will be lower, and PCO2 will be lower. Same goes for metabolic acidosis. Metabolic alkalosis, pH will be higher, bicarb will be higher, and PCO2 will be higher. This is how you remember. And when there is a respiratory acidosis, pH lower, we already discussed, PCO2 will be higher, and compensatory response will be metabolic alkalosis, that is high bicarb. In respiratory alkalosis, pH will be higher, PCO2 will be lower, and bicarb will be lower. So let's find out what is in our case. So this is the ABG. I won't repeat it. So we can find out pH is low, yes, and bicarb is low. So pH and bicarb are going in same direction. Then it's not likely primary metabolic disorder, but we have to check if there is a mixed disorder or not. Okay. Mixed disorder can be respiratory. Compensation is respiratory alkalosis, but there can be a mixed disorder like metabolic acidosis with respiratory alkalosis. We have to find out there is an adequate compensation or not. So how to find out compensation? So in case of metabolic acidosis, you have to apply formula, that is Venter's formula, that is PCO2 is equal to 1.5 into bicarb plus 8 plus minus 2. In metabolic alkalosis, for every one increase in bicarb, there is a 0.6 increase in PCO2. If in case of respiratory, we have to find out acute or chronic. In acute, in a respiratory acidosis, if acute, for every 10, 1 will rise. Every 10 PCO2, 1 bicarb will rise. Respiratory acidosis, every 10 PCO2, 3.5 will rise. For respiratory alkalosis, 10:2, and for chronic respiratory alkalosis, 10:5. So I have given you a mnemonic. You make a table like this: respiratory acidosis in one side and respiratory alkalosis in other side, and just write 10:1, 10:2, 10:3, 10:4, and write acute and chronic. And you don't have to remember this chart. Remember this. Just draw this chart, and you will find out what is the compensation going. So this is our ABG again. So we established that we have a primary disorder is metabolic acidosis. So we will apply Venter's formula. Yes, after applying Venter's formula, it came out to be 18.5. Or if we see our PCO2 is 17, so plus minus 2, so 19. So it will be 15 to 19. It will be normal. Okay, so adequate compensation is present. So there is no other disorder, respiratory disorder is going on, but it's purely compensatory response. So there is no mixed disorder, but only primary metabolic acidosis. So if there is a metabolic acidosis, we have to check anion gap. What is anion gap? If any acid is added to the body, the HN increases and bicarb decreases. Okay. In addition, the concentration of the anion which is associated with the acid increases. Okay. So whenever there is a acid, if the anion of the acid added is a chloride, the anion gap will be normal, that is hypovolemic acidosis. If the anion of the acid is not chloride, that is lactate or beta hydroxybutyrate, the anion gap will rise, that is high anion gap acidosis. Let's find out. Let's calculate anion gap. So this is the formula for anion gap: sodium minus chloride plus bicarb. So in our case, it's 19 and albumin is 4. So no need to correct for albumin. Okay, for hypoalbuminemia, anion gap will rise. So this is the formula for albumin corrected anion gap. Anion gap plus 2.5 into normal anion gap, that is 4, minus observed. So if there is a high anion gap, as I told you, so calculate delta gap. If there is an anion gap, calculate delta gap. Calculate delta gap if anion gap is to determine hidden metabolic disorder, that is non-anion gap metabolic acidosis or metabolic alkalosis. Compare change in rise in anion gap to the change of fall in bicarb. This is delta gap. So this is the formula: actual anion gap minus 12 plus bicarb. So if less than 18, additional non-gap metabolic acidosis is present. If 18 to 30, non-additional metabolic disorder is present. If more than 30, additional metabolic alkalosis is present. Okay, let's continue with our case. So delta gap came out after applying this formula. Delta gap came out to be 14. It's less than 18, so additional non-gap metabolic acidosis is present. So this patient is having both high anion gap metabolic acidosis and non-anion gap metabolic acidosis, both. So let's find out why this is happening. So these are the metabolic acidosis, anion gap, high anion gap acidosis, a differential, that is mud pylus, methanol, uremia, diabetic ketoacidosis, paraldehyde, isoniazid, lactic acidosis, ethylene glycol, rhabdomyl acid, and salicylate. So why there is a high anion gap? So most probably because of uremia, that is 119. So high anion gap most probably because of uremia. Okay, and why there is a non-anion gap acidosis in same patient? Because patient is also having diarrhea. Okay, so in diarrhea, when there is a loss of bicarb or any vomiting, the patient can have non-anion gap acidosis. So these are the causes of non-gap metabolic acidosis. That is, one is diarrhea, one is pancreatic fistula, ureteral diversion, renal tubular acidosis type 1 or 4. And these are some of the causes of other metabolic disorders like metabolic acidosis we already discussed. If respiratory acidosis, it can be hypoventilation, severe asthma exacerbation, respiratory depression from drugs like chronic obstructive pulmonary disease. It's very common. If metabolic alkalosis, severe vomiting, we already discussed, and Cushing disease, antacid abuse, diuretics, nasogastric tube suction. If respiratory alkalosis, altitude sickness, hyperventilation, CNS trauma, hepatic failure, anxiety. So these are the few examples. Thank you.
Thank you, Kamal. You have done an excellent presentation. At the end of the, we have one more PPTs, one more presentation. After that, we'll be discussing. So we'll be taking some questions for you at that time.
Okay.
Okay, is that okay for you? It's okay for you. Now we'll go to our next presentation, which will be done by Dr. Nilu Sunil. She has been the Joint Secretary of SEMI in Karnataka, and she has been pursuing her FRChem. So I would like to request Dr. Nilu Sunil to come over and present a topic, which is chest X-rays. Over to Dr. Nilu Sunil.
Good morning. Good morning to everyone. Can you hear me?
Yeah, it's clear.
Yes, sir. All right. So this is chest X-ray interpretation. I'll only be doing the interpretation. I'll not be going into the pathology and this thing. So first we'll be beginning with the chest X-ray interpretation by checking the following details. We'll be checking the patient details, the name, the date of birth, and the unique identification. The date and the time the film was taken. That is very useful for comparison. Okay. Approach. I have only listed A, B, C, D, E because this will be easier for listening. So A is the airway and the lungs, B is the bones and the soft tissues, C is the cardiac, D is diaphragm, E is any extras. A, B, C, this way if we remember, we'll be not missing out anything. Okay. So A is we can do a systematic assessment of the quality and the airway. So first we need to see if this is a AP film or a PA or a lateral film. And then we need to see if it's an inspiration or an expiration film. And also, so are we able to see 10 or to 12 ribs with a good inspiratory effect? And if it is a good exposure film, we can see a good lung detail and a good outline of the spinal column. So how will you make out if it's a PA view or a AP view? So usually in the ER, most of the films are all AP views. So how will you differentiate? So the scapula will be over the lung fields, the clavicles will be above the apex of the lung field, and the ribs, the anterior ribs are more distinct in an AP view, and the marker is AP. Okay, so to assess the image quality, you can easily remember the mnemonic right. The rotation, the medial aspect of each clavicle should be equidistant from the spinous process. The spinous process should also be in vertical orientation against the vertebral body. So this is how it should look. It is centered, equal distance between the medial end of clavicle and midline. In the next image, you can see it is not centered equally. Inspiration. In the inspiration film, you can see the 5 to 6 anterior ribs, the lung apices, both CP angles, and the lateral rib edges should be visible. Projection note of the film is AP or PA. If there is no label, then assume it's a PA film. If the scapulae is not projected within the chest, it is PA. If it's a exposure, the left hemidiaphragm should be visible to the spine and the vertebrae should be visible behind the heart. So this is in expiration, and the next film is expiration. So how would you make out if it's a good exposure? If it's a correct exposure, you will be barely able to see the intervertebral disc through the heart. So the first film, if you can make it out, it is over-penetrated. The intervertebral disc is very clearly seen in the film. And the next film is under-penetrated. In this, the intervertebral disc are not seen in the film. So we'll come to the airway. So this is the trachea. You can see the right main bronchus, the left main bronchus, and the carina, and the aortic knuckle in this chest X-ray. So next we'll come to B. So B, we'll need to see this. We'll need to scan the bones for symmetry. We'll need to see each of the bones for symmetry, any fractures, osteoporosis, and any lesions. We need to evaluate the soft tissues for any foreign bodies, swellings, and any subcutaneous air. So this, you'll need to look at each rib in return, look at the clavicle, look at the scapulae, look at the humerus, and look at the lower cervical and thoracic spine. And look at the soft tissues. So you can have thick soft tissue due to obesity, which can obscure some of the underlying structures such as the lung marking. The breast tissue also may obscure the CP angles. The lucency within the soft tissue may represent gas, as observed with subcutaneous air and subcutaneous emphysema. So here you have to also see the supraclavicular foci for any enlarged nodes. You have to see the lateral chest wall to rule out any surgical emphysema, as in trauma, and you need to look under the diaphragm to rule out any pneumoperitoneum. So next we come to C, that is cardiac. So evaluate the heart side. The heart should be less than 50% of the chest diameter on a PA film and less than 60% on AP films. Check for the heart shape, calcification, and any prosthetic valves if you can see. So this is a pneumomediastinum if you can make out. And the next you can see air around the cardia. This is a pneumopericardium. Diaphragm. Check the hemidiaphragms for position. The right is commonly slightly higher than the left due to the liver and shape. It may be flattened bilateral in chronic asthma or emphysema, unilateral in case of tension pneumothorax or foreign body aspiration. Look below the diaphragm for any free gas. So this is how we look. Findings. Check for the sharpness of both the borders. Right is normally higher than the left, and check for any free air, gastric bubble, or any pleural effusions in the diaphragm. So effusions, pleural effusions may be large and obvious, or they may be even small and subtle. So always check for the, see in the costophrenic angles for sharpness. Any blunted angles may indicate small effusion. Check the lateral films for any small posterior effusions, because these are more sensitive for small effusions. So the pleura and the pleural spaces will only be visible when there's an abnormality present. Common abnormalities seen within the pleura include pleural thickening or fluid or air in the pleural space. So this you can see there's a lung collapse here, and you can see there's a pneumothorax. This is a lateral decubitus view to see pleural effusion, which is more sensitive. So then we come to F, there is the lung fields. Check lungs for lung infiltrates, interstitial versus alveolar, for any masses, consolidation, plus or minus any air bronchograms, pneumothoraces, and vascular markings. Vessels should taper and should be almost invisible at the lung periphery. Evaluate for any major, you should see for major and minor fissures, for the any thickening in the major and minor fissures, any fluid or any change in position. So you should also see for any foreign bodies, you should see for the ETT position, nasogastric tubes, any pacemaker leads, and also you should see for central venous lines. Then you should see the upper zone, the middle zone, and the lower zones. So on a PA radiograph, you can see the minor fissure can be seen as a faint horizontal line dividing the right middle zone from the right upper lobe. Then the major fissure is not usually seen on a PA view because they are being viewed obliquely. So the great vessels in the gastric bubble, this is G. So the aortic knob should be clearly seen in a chest X-ray. The gastric bubble should be clearly seen and should not be displaced. So this is the gastric bubble, and this is the aortic knob. If you usually, if you want to rule out a dissection, the CT is more sensitive, but if you have a widened mediastinum, it can indicate a aortic dissection. So this is H and this is hyla and mediastinum. So you need to evaluate the hyla for any lymphadenopathy, any calcification, any masses. The left hilum is normally higher than the right. Check for any widening of the mediastinum, which may indicate aortic dissection in the appropriate clinical setting, and any tracheal deviation, which may indicate a mass effect. Example, from any tension pneumothorax or any goiter. And in children, it can indicate even a thymus for a mass. Usually the hyla is at the same level. The left hyla is usually higher than the right. And if the right is higher than the left, then it indicates an abnormality. So you should do is also your impression. And you should see all your lines and any tubes, whatever is there. So everything should be seen in totality. So you should see for any pacemakers, your ET tubes, your any previous surgeries, any subcutaneous emphysema. So see everything and then sum it up. So your lines and hardware, your lungs, heart, mediastinum, the bones, and the soft tissues. So the key points and tips to summarize: always interpret in clinical context, compare size, divide the lung fields into upper, middle, and lower thirds. Star presentation from this frontal chest X-ray shows you can't diagnose aortic dissection on a chest X-ray. If anybody asks you, please do a CT. And opacification, look for a shift in mediastinum towards the lesion. If there's a lesion, if there's a shift, then it's a collapse. If it's away, then it's a mass effect. If there's a fluid in the pleural space, it could be an exudate, transudate, blood, pus, or chyle. If there's pulmonary edema, it could be cardiogenic or non-cardiogenic. So for hidden places on the chest X-ray, you need to see for suprasternal above the clavicles, paratracheal behind the heart and below the diaphragm, and in soft tissues and the bones. And for miliary pattern, it could indicate TB, metastatic malignancy, and fungal pneumonia. And diffuse airspace of opacification could indicate PCP pneumonia, CMV pneumonia. And pleural-based irregular lesions could indicate breast carcinoma mets, mesothelioma, and melanoma can go anywhere. And don't miss a pneumopericardium, don't miss pneumomediastinum, and tentorial miliary lesion could indicate TB meningitis. So my references are lifeinthefastlane.com, emcrit.org, and PubMed. Thank you.
Thank you, Dr. Nilu. It was a good presentation. You explained the X-rays in a very simple way. Now, as we are ending the session 1, will be, I hope Dr. Nilu, Dr. Kamal, and Dr. Chetan all are there online. So we'll open this session 1 to discussion. It's open for discussion to all of you. Can we have questions, please? On the topics of ABG, on the topics of X-ray, and on the topics of anaphylaxis. Let's start with Dr. Chetan. Let's let the discussion be regarding anaphylaxis. Do you have any questions from the audience? Dr. Chetan, are you there? Dr. Chetan? Dr. Kamal?
Yes, sir.
So I'm not getting Dr. Chetan. We'll start with you then, Dr. Kamal.
Yes, of course.
Your presentation is open to discussion. Any questions from the audience, please? So, yeah. So, Kamal, I'll be, I'm not seeing any questions from the audience. I'll be just for my sake, I'll be asking you, can't we take pH and CO2 to discuss the primary disorder? Shall we have to take bicarbonate?
Hello?
Hello, can you hear me?
Pardon,
Kamal?
sir. Again, sir?
So you were saying that we need to take three parameters like pH, PCO2, and bicarb to say whether it's a primary or a secondary, a primary disorder. Sorry. So why can't we take a pH and a PCO2 to say it's a primary disorder?
Sir, to check metabolic, for example, if primary disorder is metabolic, we need to have a bicarb value. So if bicarb value is, for example, if metabolic acidosis, the pH will be less and bicarb value will be more. Okay, bicarb value will be also less, and compensatory response will be respiratory alkalosis. That is, PSO2 will be also low. So we need bicarb to establish if there is a metabolic disorder going on or not, whether it is a metabolic acidosis or metabolic alkalosis.
Okay, thank you. Any other questions from the participants who has joined the conference? Any students who wants to ask Dr. Kamal? Hello. There is a question from Arif Mattu. Should we do a VV? Kamal, can you hear me?
Yes, sir.
Yeah, there is a question from Arif. He's working in Middle East now. So he has asked, should we do a VVG or an ABG? Which will you prefer more?
Sir, in some cases, VBG.
Arif has asked, you can talk to Arif. He's online, I think.
Hi, Arif.
Hi, Kamal. How are you? Thanks for the nice presentation.
I'm good. In some cases, yes, VPG is preferred over ABG. Like if you want to do repeated samples for like in DK. Okay. But if you want to see respiratory acidosis, for example, you want to see gases, PCO2 levels, you want to establish if it is acute or chronic. So ABG will give you more accurate picture than VPG. But yes, if you know that there is a little difference between VPG and ABG, for example, pH is only 0.03 difference. And if you know these values, yes, you can do ABG, VPG, but it comes with practice. But ABG will give you accurate values. So I think for residents, newcomer residents, ABG will be preferred over VBG. But if you have experience and you know the values and you know the difference, yes, VBG is better because you don't have to poke artery again and again.
Thanks, Dr. Kamal.
Thanks, Dr. Kamal. Anyone else from the participant who wants to ask Dr. Kamal anything on ABG? Please send your messages or SMSs. Anyone who wants to ask Kamal? Dr. Chetan, are you there online?
Yes, sir, I'm there, sir.
Yeah, Dr. Chetan, I would like to personally ask you, what about anaphylaxis? What about serum tryptase levels? Mast cell serum tryptase levels we often do not do. Shall we do it on regular basis or?
No, sir. Actually, again, not all the labs do these levels very frequently, and the turnover time will be much more than what is the actual time of the anaphylaxis. The patient will be fine in maybe a few hours, and the report will also come later. So to confirm anaphylaxis, these serum levels don't have much role, but definitely to know the severity and might be to see further like a second episode, or we know the allergen, that time it might support us like how much is the body response to these enzymes.
Okay.
Not on the routine basis.
Okay. One more question I have for you. You have showed on your PPT 2 pictures of EpiPen, right? One for junior and one for seniors.
Yes, sir. Yes, sir.
So are they available
Yes, sir.
in the market? Many of my patients ask me, can I get an EpiPen? But often they do not get it in the market, Indian market, I mean.
Yes, sir. It is not available in the Indian market, but definitely this is a point which we can, as an emergency physician, put forward to the our pharmaceutical colleagues to get these, because nowadays many pre-filled syringes are coming, like heparin pre-filled syringes are coming. Similarly, we can push our pharmacological colleagues to get these things in the market.
Yes.
Definitely, it's not available, and it should be there.
It should be there because
Yeah,
we use pre-filled syringes for diabetes, for
insulin and yeah,
heparin, insulin, anything. So many drugs are available
yes,
nowadays, even LMWHs. So
yes,
we
yes,
can
sir.
certainly get this EpiPen.
Yes, sir. We should now like push our colleagues to get these things available for us as well. Hanji.
Yeah, yeah. So Dr. Chetan is online from the audience. Anyone have any questions for him? Please go ahead. Dr. Chetan's topic is anaphylaxis. Any questions on anaphylaxis can be asked to Dr. Chetan. He's a learned man, FNB in critical care. So ask him whatever you need to ask him. Along with, he has also done his ethic. So he's a critical care man who is in emergency medicine. And also I hope he's looking into critical care too. So ask him if you want anything to ask, students especially. Yeah, we have a question file. Any questions from anyone? So Dr. Chetan, be online. Let's go to Dr. Nilu Sunil. She has done an excellent presentation on X-rays. Ma'am, I personally want to ask you, what
Yes,
do
sir.
we teach our DNB students or MRChem students regarding X-rays? How do you begin?
So in the emergency, I think when we have a very paucity of time, we have to go very systematically so that we don't miss anything. Yes. So we have to correctly identify that we are having the right X-ray in our hand of the right patient. Yes. And we have to always identify that this is the right patient. And we have to ensure that if we can get the previous X-ray, it will be helpful. And then we can go systematically, airway, breathing. So, A, B, C, D, E will help us. And if you're not sure, I will always say, please get help. Please check with the radiologist. Always, always, please get help. And now we also have the ultrasound. It takes you 2 minutes. You can always take your ultrasound machine and can always check with that as well. So always, I would say, if you're not sure, please check with your seniors and your radiologist. Please call. If you're not sure, please, always confirm. So that's what I would say.
Yeah, that's a good approach. You should always, if you're not sure, even we do it at times when we are not very sure,
Yes.
we ask for help.
Because this is something
Or
critical you can miss. And then in the ER, I don't think you should be missing anything. So you could be missing something life-threatening. That's why.
Yeah, in a busy year, if you ask someone something from the radiologist, this does not let you go down in the eye of your students or something like that. You should ask. You should ask for help.
Yes, yes. I think it's never wrong to ask for help. It's always better you ask for help. Yes.
I do agree.
Yes.
So students and other participants, do you have any questions for Dr. Nilu, especially on X-rays? Please write down. I'm waiting on waiting. If you have anything. Okay, so as we have paucity of time, we'll go to our next session. So our next session will be uh, we'll be starting the session 2 right now. So first of all, we'll uh, go with several presenters. Namely, we have several presentations in the second session. We have approach to ischemic limb by Naga Nischal. We have acute heart failure by Shiju Stanley. We have PE and NID by Dr. Sanjukta. And we have a low probability chest pain decision rules by Dr. Tamorish. We also have an aortic dissection by Nishant Agarwal. And these are Pramajit, you want to say anything?
Yes, currently we have Dr. Sanjukta Dutta, who is consultant and head emergency medicine department, Fortis Hospital.
Yeah.
Now she is going to talk about PE, a night in ED.
Okay.
And she is going to start her session. Sir, just a small discussion before starting her session. What is your take on steroids in anaphylaxis?
So, as per the standard literatures in the books, we still go with steroids. Though Dr. Chetan did not agree, did not say that, as per evidence, he's saying there is no steroids. But as I haven't gone through that evidence which says steroids are not to be given.
Yes,
As
sir.
per my knowledge and as per by the guidelines till now, which I have read and evidences which I have read, I still go with steroids.
Yes, sir. The main advice is for the yes, sir. So the main advice for steroid is to counteract the diurnal variation actually in anaphylaxis.
Yeah,
Yes. So now the recent recommendations are suggestive that maybe steroids we can omit actually, which might not have that much action because their onset of action is quite later.
2 to 4 hours. Yeah.
Yes.
So immediate help, it doesn't help. Dr. Chetan, are you there online?
Yes, sir, I'm there, sir.
Yeah. So again, Dr. Ramajit and me were discussing regarding steroids.
Yes,
So,
sir.
yeah. Join us regarding steroids.
Definitely, sir. Sir is right that the onset of action of steroids, either it's intravenous or oral, it's delayed, and we need an immediate action with the epinephrine. So even single dose steroids are not actually contraindicated. They're not contraindicated, but actually they won't serve the purpose what we want to get the patient a better decrease the like have a better hemodynamics. Immediate effect is by epinephrine. And single shot steroids definitely help in reversing the other signs like skin problems, eye swollen problems, or tissue edema. It definitely decreases in some time. It definitely helps in reversing the problems caused by the anaphylaxis, but it does not actually treat the anaphylaxis.
That day I was reading reading in some evidence that it has got some role in stabilizing the mast cells and also the eosinophils, which
Yes,
are
sir. Yes, sir.
mainly responsible for the biphasic response later on.
Yes.
And
Yeah.
as per the books, we say biphasic response is 7 to 8 hours, but it can happen right from 3 to 4 hours to 24 hours. So it's a wide range.
Yes, sir. So that is the thing actually. And even actually, if there is a reaction because of the drugs, which those ACEI or ARBs, which sometimes cause angioedema and followed by anaphylactic shock kind of presentation. So in those cases also, the normal management gets little deferred. What do you say, Dr. Chetan?
Definitely, sir. Definitely, steroids will go hand in hand with the epinephrine, but starting with the steroids is wrong.
Yes.
Of course, I do agree to that.
Yes, yes, exactly.
Yesterday, not yesterday, some days before, I was also reading that what we used to do, we used to give epinephrine followed by an H1 blocker and an H2 blocker. So, and followed by steroids. H2 blocker also doesn't have any role, recent evidences say.
Sir, but literature do say that we have to give, if the patient is having persistent problems, both H1 and H2 inhibitors, not only the H2 inhibitors, both H1 and H2 inhibitors.
Okay.
Yes.
I was reading day before yesterday that you can give H1 but not H2. So every other day something changes and it confuses us more.
Maybe, sir, then I have to look back the
No,
evidence.
I'm not questioning you. I'm saying day before yesterday I read in literature that the role of H2 blockers is controversial. But I
Okay,
used
sir.
to give epinephrine followed by H1 followed by H2 and steroids. So,
Okay.
so these two H2 and steroids, now I'll think again.
Thank you very much, Dr. Chetan. Thank you, sir.
Thank you. Thank you, sir.
Yes, I think now we can just go back to our next session. Dr. Sanjukta Dutta.
Yeah.
Yes.
Slide in.
Yes. Dr. Sanjukta, can you hear us?
Dr. Sanjukta, are you online? Dr. Sanjukta.
Yes,
Dr.
she has
Sanjukta.
joined actually.
Good morning, everybody.
Good morning. So, Dr.
Good morning.
Sanjukta, this
Am I
side,
audible?
we'll start your session. Shall
Yes.
I go ahead? You are ready? Dr. Sanjukta.
Good morning, everybody. Am I audible?
Yeah, now you are audible. So let me begin the session 2 with you, Dr. Sanjukta. Let me introduce you. So Dr. Sanjukta is the head of emergency medicine in Fortis Hospital, Calcutta. She has done her MEM long before and she leads the group in Calcutta in emergency medicine. She will be talking on the subject P19ED. So over to you, Sanjukta. Can you hear me? Can you hear us? Dr. Sanjukta, can you hear us? Dr. Sanjukta.
Is my screen visible?
Screen is not yet visible. I can see you, but your PPTs are not visible. Not yet.
Ma'am, can you stop share and reshare again? Ma'am, your internet is not there. Ma'am, can you unmute?
So there is a serious problem with Vodafone connection. I can now connect it with Jio. So is my
Yes, Sanjukta, Dr. Sanjukta, we can hear you now. I can hear you. Can you hear me?
okay?
Can you hear
Sorry
me?
for my I can hear you.
Yeah.
I can hear you. I have connected with another phone. So basically, first thing, sorry for my throat. Post-COVID, it is really bad. Let me share my screen here. Is my screen visible?
Yeah, it's visible.
Okay. So let's talk about pulmonary embolism. This is important because this is one of the most common cause of death and misdiagnosed death in all the hospitals all over the world. So what is pulmonary embolism? A blood clot, a thrombus, when it becomes lodged in an artery in the lung and blocks blood flow to the lung. It usually arises from a thrombi that originates in the deep venous system of the lower extremities. But it can rarely originate from the pelvic, renal, upper extremity veins or the right heart chambers. After traveling to the lung, large thrombi can lodge at the bifurcation of the main pulmonary artery or the lower branches and cause hemodynamic compromise. So that's how pulmonary thrombolism happens. But there could be non-thrombotic pulmonary emboli as well. We should know so that we can diagnose them. It could be gas embolism like air, carbon dioxide, nitrogen, helium. It could be fat embolism. See, air, it can be iatrogenic. Fat embolism, it could be because after a big bone fracture. Tumor embolism, which comprised of tumor thrombus. There could be infectious agents like parasitic embolism, hydatid embolism, septic embolism. Also in pregnancy, post-delivery, amniotic fluid embolism, also particulate material embolism. So we need to be cautious not to miss any of them. Let us see why it is so bad. What is the pathophysiology behind? So increased RV afterload happens because of pulmonary embolism. The pulmonary vasculature, there is a stress, there is a high pressure, so there is increased RV afterload as there is problem in the lung. So RV cannot send the blood smoothly to the lung. So there is increased RV afterload. It causes RV dilatation. It causes tricuspid valve insufficiency, increased RV wall tension. There is neurohormonal activation, which in turn causes myocardial inflammation. RvO2 demand increases, intrapulmonary AV shunting, then RV ischemia, hypoxic injury, decreased RV contractility, decreased RV output, which in turn causes LV preload decreases because of that. Then cardiac output decreases, systemic blood pressure decreases, coronary perfusion of RV decreases, RvO2 delivery decreases. So it becomes a hemodynamic compromise as a whole because also the heart is also compromised. So this causes hemodynamic collapse and death in acute pulmonary embolism. So one thing I want to stress upon is it is in pulmonary embolism, it is not that we are just worried about hypoxia or the saturation is falling. We need to diagnose pulmonary embolism early because it can lead to hemodynamic compromise soon. What are the symptoms? The usual symptoms are, first thing, pain in calf or thigh, because that is the most important source of thrombus to the lung. So that is something we need to search first. There's pain in calf or thigh. Patient can present with sudden shortness of breath, coughing, even coughing of blood, that is hemoptysis, dull chest pain, wheezing, loss of consciousness. But there could be many atypical presentations. That's why it becomes difficult to diagnose. The patient can present with seizure, syncope, even pain, abdomen, fever, productive cough, wheezing, decreased level of consciousness, new onset atrial fibrillation, hemoptysis, flank pain, delirium in elderly patients. So all can present as, the underlying cause could be PE. Now, when we do physical examination, that is also very non-specific. Mostly, that is 96% patients comes with tachypnea. This is a symptom. It is present in 96% of patients. Respiratory rate is more than 20 per minute. Rales in 58%, accentuated second heart sound in 53%, tachycardia, fever, diaphoresis, S1 or S3 gallop, thrombophlebitis, signs or symptoms, lower extremity edema, cardiac murmur, cyanosis, all could be there. But you can see that all are, you can get this in many other conditions. None are specific to pulmonary embolism. So let us just quickly go through some cases. 32-year female with no comorbidities present with shortness of breath for 3 hours. Smoker on OCP for 4 years. Saturation 94%. Pulse rate, blood pressure, mild tachycardia, blood pressure normal. Chest X-ray, ECG normal. Now what CT found? Large embolus in the main pulmonary trunk. 18-year-old woman returned from Canada, sudden shortness of breath, pulse 52 to 56, normal respiratory rate, normal saturation. Again, CT found large embolus in left pulmonary artery. These all are real cases. 29-year-old, 32-week pregnant woman presented with chest pain and abdominal pain. Respiratory rate was 28, saturation 99. Obs evaluation normal limits, no cause of pain could be found. CTPA showed bilateral basilar segment and subsegmental filling defects consistent with PE. 18-year-old bedridden man presented with hiccup without concurrent dyspnea or abdominal pain. Respiratory rate saturation was fine. Still, this patient showed pulmonary embolism. 53-year-old man complained of lower right back pain radiating to the right upper quadrant of the abdomen. He denied chest pain or dyspnea, had cough pain for last 2 months. Respiratory rate was 22 breaths per minute, saturation 96%. He was breathing 96% in room air. CTPA showed embolus in the segmental branch of the right lower lobe. 21-year man gave history of 2 recent episodes of convulsion and recent onset dyspnea. Respiratory rate normal, on the higher side though, saturation 95% on room air. Transthoracic echocardiogram was done for this patient, which showed marked dilatation of the right ventricle and right atrium. Moderate to severe tricuspid regurgitation, elevation of pulmonary arterial pressure. CTPA showed PE. So basically, what I want to stress upon in all this, with all these cases is, it is not only the presentation which will lead to the suspicion of pulmonary embolism. We need to remember and think of these risk factors of pulmonary embolism while evaluating any patient in the department. Because the first thing we need to know is, if we are not doing CT pulmonary embolism, CT pulmonary angio, it is very difficult to say this patient has got PE or has not PE. So these are the risk factors we need to remember and see cautiously. So this is a mnemonic I found really good to remember: trauma, travel, thrombophilia, hypercoagulable state, hormone replacement therapy, recreational drugs, old age, malignancy, birth control pills or patches, obesity, pregnancy, surgery, immobilization, iatrogenic cause like central venous catheter placement, and of course, serious illness, bedridden patients. Now let us go back to those cases. Let us see what was actually common in all of them. This patient, the case 1, was smoker on OCP. That's a very deadly combination, can have PE. Second one, returned from Canada, long flight. That means long time immobilization with dangling legs. This one, pregnant woman. You need to be cautious. Bedridden man. Cough pain for last 2 months. We need to think of DVT. 6, surgery for femur fracture. Again, another risk factor. So in PE, most important thing is we remember what are the risk factors are, we suspect, and then we search for this. Potentially useful lab test could be D-dimer, ischemia modified albumin level, white blood cell count, arterial blood gas, serum troponin level, BNP, but none of them are specific for PE. Imaging studies, CTPA, pulmonary angiography. CTPA is gold standard. Pulmonary angiography, when only CTPA is unavailable. Chest radiography, non-specific. VQ mismatch can be done. It is marginally good, I would say, but again, not as good as CTPA. When it is not available, we can go for this. ECG. ECG is again non-specific changes. Most common abnormality is tachycardia and non-specific ST wave abnormalities. Typical ECG stigmata of PE is sinus tachycardia and S1Q3 T3 configuration. S1 is S wave in lead 1, and lead 3 you have got pathological Q and T wave inversion, but we don't get it all the time. Rare, actually it's rare. MRI in a specific setting can show increased signal intensity within the pulmonary artery. Echocardiography, transesophageal echocardiography may identify central pulmonary embolism, or at least with the echo we can see the RV stress, RV dilatation that can lead to our suspicion, or that can tell us that we need to go for CTPA. Venography for diagnosing DVT, duplex ultrasonography, non-invasive diagnosis of pulmonary embolism by demonstrating the presence of DVT at any site. When there is PE, we need to go for hypercoagulation workup, PE or DVT, why this is happening. So we can do this. If no obvious cause of embolic disease is apparent, then we need to search for the underlying conditions if there is any. Antithrombin 3 deficiency, protein C or protein S deficiency, lupus anticoagulant, hemocysteinuria, occult neoplasm, connective tissue disorders. These are the things we need to search for if we are not getting any reason for the thrombus. As I said, CTPA is a gold standard. Emboli,
Continue, Dr. Sanjukta.
sorry?
Continue.
Yeah.
We have
Can you hear me?
Yeah, we have shortage of time. Make it short and crisp.
Okay. So there could be partial or there could be complete block. Now D-dimer. D-dimer is a good negative predictor, but raised D-dimer is seen with PE but has many other causes, and therefore it is non-specific. Age-related D-dimer is better, which is age into 10 microgram per liter. The management, the main management is, I would say, before PE happens. So first thing is, whatever patient we are getting, if there is a chance of development of DVT, give prophylaxis. The patients who are coming to emergency, going to ICU, you are suspecting prolonged bedridden, advise stocking or give medical preventive dose of low molecular weight heparin. And then if the patient comes with PE or DVT, definitely our goal is to give anticoagulation as soon as possible. So we can go for unfractionated heparin, low molecular weight heparin, factor 10A inhibitors, fondaparinux, warfarin. Thrombolytic therapy is only for the patients who already has got hemodynamic compromise, has presented with hypotension, and there is no high risk of bleeding. And also in selected patients who has got high chance of hemodynamic compromise, we are apprehending that the patient may go to shock hypotension quickly. The drugs we have are altiplase, retiplase. There are surgical options if it is a big and we think we need to go for that. Catheter embolectomy and fragmentation or surgical embolectomy can be done. Placement of vena cava filter for DVT patients are important. So that is it. Thank you and all the best. Right now in the COVID era, the only one thing I would like to say is post-COVID PE is common because it causes microvascular thrombi and then later on it can produce thrombi which can cause to different thrombotic dysfunctions conditions which can, present, the patient can present with PE. So we need to be cautious in those patients as well. All the best.
And thank you, Dr. Sanjukta. It was a nice presentation, though a bit long, but you covered all the topics. Thank you so much. Be online so that we can discuss. After the end of the session. So we'll go to our next topic, and the next speaker. Thank you, Dr. Sanjukta. We'll discuss at the end of the session. Your P, right? Okay. So now I'm going to invite my friend and colleague, Dr. Tamorish Kole. He has been the past president of SEMI, and he is also the president of Asian Emergency Medicine Society. Well, we welcome you, Dr. Tamorish. So he will be talking on low probability chest pain decision rules in ED. Which is a very important topic because we are always faced with chest pain in the emergency department. Over to him.
Close the door. Can you see my screen?
Yeah, we can.
Okay. So I'm going to talk on low probability chest pain decision rules in emergency department, a very important topic for the residents as well as for all of us, because it is easy to admit and send patients to cath lab, but it is very, very difficult to send patients of chest pain out from the ED getting discharged or discharged after a few observations. So let's see where does the evidence stand. So in the beginning, I'd like to point out 2-3 things which is very important to understand why this is so important. So this is a review article which was published in 2010 on emergency medicine clinics, and this particular list charts out that why patients were inadvertently discharged with a missed cardiac ischemia from emergency department. And if you just concentrate on the last 4, which talks about physician experience that can happen with any of us, lower volume of emergency department who is not very much proficient or efficient with chest pain pathways of management, failure to detect ischemia on initial ECG, and even failure to obtain ECG because of overcrowding or some other reason. Okay. Now, in addition, one more thing we must keep in mind that there are traditional as well as non-traditional risk factors for coronary artery disease, and we all know the traditional risk factors, but it is good to remind ourselves the non-traditional risk factors for the coronary artery disease, which are HIV, SLE, end-stage renal disease, cocaine, amphetamine abuse, type A personality, and genetic and acquired thrombophlebitis.
Dr. Kole, hello. Dr. Kole, can you hear me?
Yes.
Your slides are not moving. Yeah, they're moving.
Oh, sorry. Let me share back again.
చూస్తే ఏమో ప్యాకేజ్ అవి ఇవి గలాట ఏదో ఒకటి పురుగు కనపడిన దానికి they made a big fuss about it.
Can you see my screen?
We can see your
వేరే
screen.
ఏం లేదు, పేషెంట్ కేర్ ఏమీ లేదు, కాక్రోచ్ కనపడింది అని they made a big fuss about it.
Sorry.
పాజిటివ్ వచ్చినాక రిపోర్ట్ చేసుకోండి అంటే చేసుకునే లేదు అని గలాట. వాళ్ళ మదర్ పాజిటివ్ వచ్చినాక అందరిది రిపోర్ట్ చెప్పించుకుంటే గలాట, లోపల 10 మంది వదులు అని గలాట. అవన్నీ రాసలేడు పేపర్లో. వాడి స్టోరీ రాసినాడు, 10 మంది కాదు, ఇంక వాళ్ళు తెలుసు కదా.
Dr. Kole, can you share your screen? Full screen?
Yeah, admin, kindly mute everyone except Dr. Kole, please.
Yes.
It's full screen now. Can you see the picture?
No, sir.
No?
No. I think, yeah, your full screen just came and went off.
Okay, just hold on. There may be a memory issue.
Sir, if I may suggest, don't go into full screen. With the left, on your left, you can see the small slides. You can click on them and move.
Correct. Can you see my screen now?
We can see your screen. There's a small slides on the left and your be prepared slide, which is showing.
Okay. So I can start now. Okay. Right. So the third thing which I wanted to remind all of us that we need to be prepared.
I would request you to start from the beginning again.
Okay. Sorry. So I need to go a little bit fast. So low probability chest pain is a decision rules in ED. In fact, it is very, very important topic because it is very easy to admit patients and send them to cath lab or ICU, but it is very difficult to discharge patients from emergency department. It takes a lot of knowledge, a lot of strategies, and a lot of shared decision making, and I'm going to talk about that. So in the beginning, I would like to point out three important things which are very, very important, that why this is an important topic. Now, this is a review article on low probability chest pain which came up in 2009 in North American clinics, which talks about the reasons of inadvertent discharge of patients with missed cardiac ischemia. And four in the list, which is in the last four, which talks about physician experience, lower volume emergency department who does not deal too much of chest pain and things like that, and failure to detect ischemia on initial ECG, even failure to obtain an ECG. And that is why we have to always be cautious on evaluating these patients. There are also important to understand that there, in addition to traditional risk factors of coronary artery disease, which we all know and the residents usually remember, but there are non-traditional risk factors for chest pain, which includes HIV, SLE, end-stage renal disease, cocaine and amphetamine use, type A personality, genetic and acquired thrombophilia. So it's important to remember that this group of patients can be presenting with chest pain and they have risk factors with CAD. So first and foremost, we need to be prepared. Although we will be dealing with low risk chest pain, if there is any complication or there is any further evaluation required, it is better to have them in a facility which has got resuscitation capability, which has got 12-lead ECG, and which has got access to point of care or a lab troponin, because most of the pathways till now have troponin in their in their arm. While I was preparing this lecture, recently the 2021 guidelines for the evaluation and diagnosis of chest pain patients have come from AHA and ACC, and it is a good time to go through this, because there is a little bit of change in the way we evaluate chest pain in 2022 based on this guideline. So we all know chest pain suggestive ischemia is not just discomfort in chest, it can be discomfort in shoulder, jaw, epigastric area, neck or back. The class 1 recommendation suggests that the initial assessment of chest pain is recommended to triage patients effectively. So triaging is very important in chest pain patients. And the third recommendation which came that till now we are using a term called atypical chest pain, but it's not helpful and can be misinterpreted that these chest pains are benign in nature. So this has been recommended to be removed henceforth from our daily practice. And chest pain therefore should be described in those cases cardiac, possibly cardiac and non-cardiac, because these are terms are more specific in going forward. We all know that evaluation of all patients with chest pain requires the identification of life-threatening cause, and I'm not going in detail. There are other speakers will speaking about that. We just had a good lecture on pulmonary embolism. Aortic dissection is also coming, and the other things will be covered. And the cardiac chest pain characteristics, I guess all of us know that. But there are groups which need to be cautious. Most and foremost important is women. Women with chest pain, they are at a risk of underdiagnosis globally because they not only present with chest pain but also present very well with accompanying symptoms, and we'll come back to that. And similarly, in elderly patients with chest pain more than 75 years of age, ACS should be considered. And whenever we are encountering patients who is ethnically diverse or we don't understand their language, we must take help to understand their symptoms and things, medications, and like that. We have to put an extra effort in evaluating these chest pain patients. There are emergent clinical symptoms, as I was just describing, which can be diagnosed, which can be suspected, I'll tell, based on the clinical constellation of symptoms. For example, the pulmonary embolism we just discussed, tachycardia, dyspnea, pain with respiration, aortic dissection, where we can find extremity pulse differential, abrupt onset of pain, syncope in some cases, whereas in esophageal rupture we can find emesis, subcutaneous emphysema, features suggesting of pneumothorax, which can be very well auscultated, unilateral decreased or absence, breath sounds, and even we can use point of care ultrasound as well. Now the list goes on. There are other things we can also diagnose when the patients are presenting with the other causes of chest pain. So if we want to summarize, there are thoracic causes of chest pain, there are extrathoracic causes of chest pain, which brings to a broad differential of chest pain patients in emergency department. And in terms of non-cardiac diagnosis, respiratory stands very high in pneumothorax, pulmonary embolism, even pneumonia. Gastrointestinal such as cholecystitis can present at chest pain, chest wall, herpes zoster, refracture, psychological chest pain can happen, and then hyperventilation. But we have to first rule out the acute coronary syndrome in all the patients regardless, or the other emergent cause of diagnosis, before we come back to this non-cardiac chest pain diagnosis. So as we all know, the next best step is to do an ECG, a 12-lead ECG, class 1 indication in chest pain management. And there are classification now, the newer ones which has come. We all encountered STEMI, diffuse ST elevation, which is pericarditis, ST depression, non-ST elevation, acute coronary syndrome. But non-diagnostic or normal ECG, again, either we have to do repeat ECG or troponins, will come to that, or we can do posterior leads if your posterior MI is suspected. And if there is a new arrhythmia, that has to be managed as well. So what does the guideline suggest? The guidelines suggest that in patients presenting with chest pain, a chest X-ray is useful to evaluate the potential cardiac, pulmonary, thoracic cause. There's a class 1 indication, but also to remember that in patients presenting with acute chest pain, serial troponin I or troponin T levels are useful to identify abnormal values, and high sensitivity troponin is preferred, and clinicians should be familiar, this is a very, very important point, with analytical performance and the 99th percentile of upper reference limit for the troponin assay which is used in the institution. So with this assay, everyone should be talking to their lab or the point of care devices assistants on what brings that level, which is important for them to diagnose chest pain patients. And we all also know now that with availability of cardiac troponin, CKMB and myoglobin are not useful to diagnose acute myocardial infarction. There is class 3 indication, there is no benefit. So the next question is, how do we define low or high risk? Well, again, if we just follow the guideline, if there is a possible ACS, we have to obtain troponin and use the clinically differentiated pathways. We will come to that. And if it is low risk, then there is class 1 indication that there is no testing required and we can discharge. But if there is intermediate and high risk, then further diagnostic testing and invasive coronary angiography is indicated. Now this is the most important thing. What defines low risk and high risk? I'll come to the high risk first. If there is a new ischemic changes on ECG, There is a troponin confirmed acute myocardial injury, new onset left ventricular dysfunction, newly diagnosed moderate severe ischemia, hemodynamic instability, and high clinical decision pathway risk score. That was nice. Rest everybody again go to the low risk pathway, and low risk can be defined using troponin at the 0 time, HS troponin limit or very low threshold if the symptoms present for at least 3 hours. And there are other assays which suggest that we do 0, 1 and 2 hours and then take a delta and use the criteria of troponin. But there are other pathways, which is clinical decision pathway, heart score, which also uses troponin. If heart score is less than 3, initial and serial troponin or HS troponin as a 99th percentile, then it's a low risk. Similarly, there are other pathways, which is EDAX, ADAPT, modified ADAPT and NOTR, which are also used in clinical decision making of low risk chest pain patients. This is the summary of TIMI and heart score. I'm sure that you are all familiar. I will strongly advise to use an application in your mobile phone which is called MD Calc, which have all this score incorporated, so you don't need to remember. You can do it bedside and you can get a clear score and the interpretation as well. Now, in addition to TIMI and heart and other scores, we were talking about a few years back. Richard Body, based in UK, came up with a T-max score, which is troponin only Manchester acute coronary syndrome decision aid score, which considers EKGs, worsening angina, pain to the shoulder, pain associated with vomiting, hypotension, and as well as the HS troponin. And based on that, there are formula to calculate the T-max score, which can easily rule out ACS in very low risk patients as well. Now, what is the T-max interpretation? 0.02, less than 0.02, risk is very low, and these are the patients who can be considered for discharge. If it is 0.02 to 0.05, we can consider serial troponin and in the ED or observe, and 3-hour troponin and consider discharge if they are normal. If they are moderate, then we can do serial troponin in the general ward and consider chest testing, and if they are high, of course, we have to rule out cardiology folks. Okay. Now, what are the take-home messages? So, if you look into the 2021 guidelines, there are 10 take-home messages, out of which 4 or 5 are relevant to this talk. First and foremost is high sensitivity troponins are preferred. High sensitivity cardiac troponins are standard for establishing the biomarker diagnosis acute myocardial infarction. So, get hold of HS troponin at your place. Then shared decision making, the next big thing. Clinically stable patient presenting with chest pain should be included in decision making. Information about risk of adverse events, radiation exposure, cost, and alternative options should be provided and facilitate the discussion. This is a new recommendation which has come up. Testing is not needed routinely for low risk patient. This is a clear-cut evidence that in low risk patient you can clearly discharge, and those further testing are not required. Pathways, very important take-home message. Clinical decision pathways for chest pain in ED and outpatient setting should be used routinely. Now, outpatient guideline has been issued. I am not discussed, but in the guideline it is there. And all the outpatients, if it is discovered in outpatient setting, all the patients are therefore advised to direct it to the emergency department. So we expect an increase in chest pain patients in following of these guidelines. And number 7, accompanying symptoms, especially in women. Chest pain is always most often presented with accompanying symptoms such as nausea, shortness of breath in women, so be careful in that. Then non-cardiac is in, atypical is out. Please refrain from using the word atypical from now. And lastly, structured risk assessment should be used for patients presenting with acute and stable chest pain. Risk for coronary disease and adverse events should be estimated using evidence-based diagnostic protocol. So these are few take-home message which is important for practice in 2022. Now, what is the future direction of this? Well, the good news is that there are now thoughts same from Richard Body and his colleagues published in Canadian Journal in this month, 2-3 days before. where they have quoted a study by O'Reilly, which reported an external validation of a modified Hut score because they removed the troponin testing. They name it now HERE score, and a HERE score less than 1 can identify more than 17% of all patients as very low risk index for acute myocardial infarction and 30-day major acute cardiac event and unlikely to benefit for troponin testing. And if this studies or further studies come in this direction and this strategy can be implemented, it can lead to significant resource saving, and the chest pain, low risk chest pain patient evaluation will be much more easier than what it is today. So that's all from my side, and my only advice to the resident is go through your textbook, study hard. Thank you very much. You are mute, I can't hear you.
It was an excellent presentation. We got to know many things, new things, which you often come to know from your presentation, especially Emax scores and ER score. We'll be discussing this course later when we come to the discussion. Excellent presentation. Thank you. Thank you so much. Thank you. We'll be going to our next presentation. It will be done by Dr. Nishant Agarwal. He is the head of the Chanak Hospital in Calcutta. He will be talking on aortic dissection, which we all know is an important topic. So, Dr. Nishant, are you there? Go ahead, please.
Good morning, sir. Good morning, everyone.
Good morning.
So we'll be discussing about aortic dissection today.
We can hear you.
Okay. So just a brief introduction about the aorta. As we all know, aorta is the largest artery in the body. It carries the blood from the heart to all the major structures in the body and the vital organs. By the structure, if we go, aorta can be divided into the ascending aorta, arc of aorta, descending aorta, and the abdominal aorta. Histopathologically speaking, aortic wall can be divided into the intima, which is the innermost lining, media is the middle one, and adventitia the outermost layer. The layers are made up of connective tissue and elastic fibers, which allows the aorta to stretch against the pressure produced by the flow of the blood. Abnormalities in the wall of the aorta may lead to enlargement or bulging out, which is known as aneurysm, or there can be a tearing of the lining of aorta, which is known as dissection. So what is aortic dissection actually? An aortic dissection is a tear in the inner layer of the aortic wall, that is the intima layer, which allows the blood to enter into the wall of the aorta, into the media, creating a new passage for blood known as the false lumen. This false lumen lies in the media layer of the aortic wall. Aortic dissection also weakens the aortic wall and may lead to rupture, which may be fatal, or to formation of a balloon-like expansion of the aorta, which we know as aneurysm. Aortic dissections are uncommon, yet they are highly lethal. If untreated, an aortic dissection can be fatal within the first 24 to 48 hours. Talking about the classification, there are two major classifications of aortic dissection which are there. One is a Stanford classification and other is a DBK classification. Stanford consists of type A and type B. Type A involves the ascending aorta and or the arc, and type B involves a descending aorta and arises distal to the origin of the left subclavian artery. Type 1 originates in the ascending aorta and propagates to involve the whole of the aorta. Type 2 of DBK is very similar to type A and is confined to the ascending aorta or the arc, and type 3 is similar to type B. We can see here in the figures DBK type 1, which involves the whole of the aorta. Type 2 or Stanford type A is including the arc or the ascending aorta, and type B, Stanford or DBK type 3, involves the descending aorta. Talking about the pathophysiology, the aortic wall consists of three layers as we have already discussed, that is the intima, media and adventitia. Constant exposure to high pulsatile pressure and shear stress leads to weakening of the aortic wall, leading to a tear in the intima layer. Following this rent, blood flows into the intima and the media space, creating a false lumen. Most of these tears takes place in the ascending aorta, usually in the right lateral wall, where the greatest shear force of the aorta occurs. An acute aortic dissection, it can propagate antegrade and or retrograde, and depending on the direction of the dissection travels, cause the branch obstruction that produces ischemia to the affected territory. And for proximal type of aortic dissections, can instigate acute tamponade, aortic regurgitation, and or aortic rupture. In an acute aortic dissection, the true lumen is lined by the intima, whereas the false lumen lies in the media. In most cases, true lumen is smaller than the false lumen. The three common sites for aortic dissection are nearly 2 to 2.5 centimeter above the aortic root, which is the most common site, just distal to the origin of the left subclavian artery, and in the aortic arc. This figure shows the pathophysiology. Here we can see that the blood flows and there is a breach in the intima layer, and the blood flows in the media, causing a false lumen in the media. Talking about the risk factors for aortic dissection, these clinical features listed in the table above forms the basis of the aortic dissection detection risk score. Category 1 includes the underlying condition, which may be Marfan's family history, aortic valvular disease, recent aortic manipulation, thoracic aortic aneurysm. Category 2 is based on the symptoms, which include the pain in the chest, back, or abdomen. And category 3 is the abnormal examination findings. 1 point each is given for each category with a feature present by history or physical examination, and the score may range from 0 to 3. Now, talking about the clinical presentation of aortic dissection. As we have discussed, the aortic dissection can propagate antegrade or retrograde. And depending upon the extent of the aortic dissection, the arteries are obstructed and it may compromise the blood supply to a specific territory, and the symptoms are based on that. Various studies identify the intensity of onset of pain as the most reliable historic factor. And when the pain is accompanied by physical findings, such as discrepancy of the blood pressure in the upper extremities, a pulse deficit, or presence of diastolic murmur, which is present in less than 50% of the confirmed cases of aortic dissection, the chances or the probability of aortic dissection increases. Additionally, the presence of chest pain with any neurological deficit, like the combination of chest pain with abdominal pain or chest pain accompanied by limb weakness or paresthesia, should alert the clinician about the possibility of aortic dissection. Talking about the pain, the characteristic of pain in aortic dissection, it is often sudden in onset, reaches maximum severity quickly, can be tearing in nature. However, in about 10% of the patient, the aortic dissection is painless, which is more common in Marfan syndrome. The pain can be located in the anterior chest in case of ascending aorta. In the back, if the dissection is descending, it may have a migrating character as dissection propagates caudally. At the time of presentation, neurological deficits are present in 1/5 of the patients. Syncope is also a common finding in aortic dissection and may be due to hypovolemia, arrhythmias, MI, or an increased vagal tone. If the dissection is antegrade, it may involve the extremity vessels leading to loss of pulses, paresthesia, and pain. Hoarseness of voice and Horner syndrome have also been described in patients with acute aortic dissection. If the aortic dissection is leaking or ruptured in the mediastinum, then the patient may have dyspnea and hemoptysis. Talking about the physical findings, most of the patients present to the emergency with hypertension. And if the patient presents with hypotension, then this is a grave sign, most likely indicating a rupture. A difference of more than 20 millimeters of mercury of blood pressure between the arms should arise a suspicion of acute aortic dissection. Other features which can be there are widened pulse pressure, aortic insufficiency, a diastolic murmur, muffled heart sounds, syncope, altered mental status, loss of peripheral pulses, Horner syndrome. Talking about the investigations, routine investigations like ECG and chest X-ray are done, which, if normal, can be misleading. Furthermore, while the widening of aortic cylinder increases the likelihood of aortic dissection, its absence not reliably excludes the diagnosis. Confirmation of aortic dissection requires cardiovascular imaging to identify the presence of an intimal tear, establish the classification, and detect valvular or branch involvement. Most society guidelines recommend either CT aortography or transesophageal echocardiogram in expert hands for the diagnosis of aortic dissection. Talking about the ECG findings, it may be difficult to differentiate aortic dissection from acute coronary syndromes on ECG because both conditions are associated with ECG changes, and dissection may limit or obstruct the coronary artery blood flow, giving us a picture very similar to acute coronary syndrome. The abnormal findings in the ECG may include new Q waves or ST segment elevation in 3 to 4%, ST segment depression in 15 to 22%, non-specific STT changes in around 40 to 60%. However, ECG is normal in around 20 to 30% of the patients. A plain chest X-ray may provide important clues for the diagnosis. However, 12 to 37% of patients have no abnormality, and this study should not be used to rule out dissection. A chest X-ray may show a widened mediastinum, which is more than 8 centimeter or more than 1/3 of the transthoracic diameter at the level of the aortic knuckle, or fluid collection in the hemithorax due to rupture. Other X-ray features which suggest acute dissection include left apical cap, pleural effusion, deviation of the esophagus, deviation of trachea to the right, depression of the left main stem bronchus, loss of paratracheal stripe, and calcium sign, which is the separation of the two parts of the calcified aortic wall. Here we can see the pleural cap, widened mediastinum, loss of aortic knuckle, pleural effusion, and like we have discussed regarding how to read an X-ray, there are certain structures like intercostal chest drain is there. CT findings. CT is the imaging modality of choice for the diagnosis of dissection. It helps us to identify the intimal tear and the classification for further management. If the patient is stable, a CT scan with contrast is recommended. The spiral CT can quickly detect the location of the intimal tear and help the surgeon to plan the procedure. CT findings suggestive of acute dissection are intimal dissection flap, double lumen, aortic dilation and hematoma, regions of malperfusion. Contrast leak indicates aortic rupture. Triple rule out CT angiography, which is used to differentiate acute coronary artery disease, pulmonary embolism, and acute aortic dissection, has not been shown to improve diagnostic yield, reduce clinical events, or diminish downstream resource use. Therefore, in its current form, it cannot be a recommended investigation of choice. In this CT finding, just a short, we can see there is a tear in the aorta, which is suggestive of acute aortic dissection. Echocardiography is also a useful modality to detect aortic dissection, and with the availability of bedside ultrasound point of care resources, it is an imaging modality, means we can use it as a choice for diagnosis of acute aortic dissection. However, the result varies on the operator because it is an operator dependent investigation. Transesophageal echocardiography is the preferred technique that can be done at the bedside and used for intraoperative visualization. If the patient is unstable, transesophageal echocardiography is the recommended procedure because we can't send the patient for CT. Other indications include renal insufficiency, contrast allergy, and the findings can be dissection of flap with a differential Doppler flow, true and false lumen in the ascending aorta, thrombosis in the false lumen, central displacement of intimal calcification, and pericardial effusion. Here we can see a tear or a flap in the aorta, which is suggestive of acute dissection. Talking about differential diagnosis, alternative diagnosis on the differential of aortic dissection include the following life-threatening conditions: myocardial infarction or acute coronary syndrome. As we know, it may present like acute coronary syndrome, pericardial disease, stroke, musculoskeletal disease of the extremity, spinal cord injuries and disorders, intra-abdominal disorders, pulmonary disorders including pulmonary embolus, pneumonia, pleurisy, pneumothorax. Pulse deficit can be a sign of non-dissection related embolic phenomena or arterial occlusion. What are the consequences of aortic dissection? Actually, the consequences all depends upon the artery As the dissection progresses, it obstructs the blood supply or a territory, and the presentations are depending on that. If the origin of dissection is the ascending aorta, like it can lead to cardiac tamponade, aortic valve incompetence, coronary vessel occlusion, right hemothorax, arc of aorta in the mediastinum, hematoma, compression of the pulmonary artery, carotid artery occlusion, subclavian artery occlusion. Descending aorta can lead to left hemothorax, aortic esophageal fistula. Abdominal aorta can lead to retroperitoneal hemorrhage, celiac or mesentery artery occlusion, renal artery occlusion, and spinal artery occlusion, leading to paralysis. Talking about the treatment, while aortic dissection may cause hypotension that require fluid or blood product resuscitation, suspected aortic dissection commonly requires antihypertensive treatment because most of these patients present with hypertension. An initial treatment should be a negative inotropic agent in order to lower the blood pressure without increasing the shear force on the intimal flap of the aorta, which may lead to progression of the aortic dissection. Beta blockade is ideal, and a short-acting beta blockers such as esmolol or labetalol are the preferred over long-acting beta blockers. The ideal target blood pressure is undefined. However, systolic blood pressure of 120 to 130 is a reasonable starting point. However, some guidelines suggest a goal of 100 to 120 millimeters in the absence of aortic regurgitation. Talking about the emergency departmental care, we must consult with the vascular or thoracic surgeon for patients with confirmed or strongly suspected aortic dissection to determine if operative intervention is indicated. Stabilize the hemodynamics with large bore IV access, IV fluids for hypotension and blood transfusion when required. Manage hypertension with beta blockers, we have already discussed. Additional blood pressure reduction agents such as nitroprusside or nicardipine should be used when needed after adequate inotropic blockade has been achieved. And the systolic blood pressure remain above 120. So talking about disposition, rapid referral to vascular surgeon. Emergency open repair remains the treatment of choice in most patients. However, endovascular repair is being used more frequently. Patients with acute aortic syndromes are likely to require admission to an intensive care for hemodynamic therapy and careful monitoring. Acute intramural hematomas and penetrating ulcers have an unclear clinical course and natural history. Therefore, the management of these patients' disorders is difficult. However, no patient in an acute aortic syndrome should be discharged without specialty consultation. Aortic dissection still carries a very high mortality. At least 30% patients die after reaching the emergency room, and even after surgery, the mortality rates are very high, which vary from 20 to 30%. For those who survive the surgery, the comorbidity also takes a toll and the quality of life. Special consideration, aortic dissection in pregnancy is rare and usually it occurs in the third trimester and postpartum. Risk factors we have talked. Simultaneous consultation with obstetrics and cardiovascular surgery is needed to rule out. Despite the best circumstances, it is next to impossible to diagnose every case of aortic dissection presenting to EP. Factors contributing to high miss rate include perceived mildness of the symptoms in most of the patients. We must keep the risk factors in mind, and the diagnosis of aortic dissection must be in the back of an emergency physician when dealing with such cases. Aortic dissection is a life-threatening condition that must be diagnosed and treated without delay. Dissection involving the beginning portion of the aorta are treated with emergency surgery, and those involving the descending aorta are usually treated with medications. Because the aortic dissections may be related to an underlying genetic abnormality of the aorta, first-degree relatives should be screened for aortic enlargement. Thank you.
Thank you, Dr. Nishant. It was a good presentation. So for all the participants who has joined late and for all, we are continuing with the session 2 of day 1 of Semicon. Dr. Nishant has just finished his presentation. We would request him to be online so that we can, at the end of the session 2, we can discuss with all our speakers. Now we'll be moving to the next PowerPoint presentation by Dr. Nischal Naga. He will be speaking on an approach to an ischemic limb. Dr. Nischal, please go ahead with your presentation.
Hi, Doctor. Good morning, everyone, and congratulations on a very good Semicon 2022. I know we're all in virtual mode. I think learning will continue to be in virtual and hybrid mode for a while now. So without any, can I start sharing the screen? Hello?
Yes, you can.
Can you see my screen, please?
Yeah, we can see your screen.
All right. I'll just, all right. So without any delay, I'm sure all of you have had a wonderful start for this Semicon 2022. Let's start off with academics right away, and I'm sure we're going to have a lovely couple of days forward. So approach to an ischemic limb is like sitting on a ticking time bomb. Like all of you know that this is an emergency that you dread to receive, and we just want to make it as simple as possible for all of you. What are the things that you should do? What is an algorithm you have to follow? And what are the steps that you need to do as a red flag and intervene at the earliest? So this is no less than a stroke or an MI. So don't take it light just because it's a limb ischemia. All right. Are my slides moving? Are my slides moving?
Yes.
All right. Thanks, Dr. Kole. So that's how the limbs look. If you can appreciate the change in the color of the limbs, that's how an ischemic limb will present to you. Of course, it's challenging in Indians because we're not that fair skinned. But please remember, when you look in detail and always compare both the limbs when you think of an ischemic limb. So that's just to tell you how it looks. And let's dive into the etiology management part right away. So what are the possible etiology? There are two very common etiology why there is an ischemic limb presenting to you. The commonest being an embolism, acute arterial embolism, and then there is an acute arterial thrombosis. So we all know embolus is what is going to travel all the way, and it's mostly the arteries are healthy, whereas the embolus has traveled all the way, most commonly the heart, and got stuck in one of the limbs. And there is acute arterial thrombosis where the tree or the arterial tissue itself is damaged. And that is why there is a thrombus formation there. So these are the two very common. And of course, there is traumatic ischemia where you have dashboard injuries, you have falls where the bone snips off the artery, which is very, very common. So these are the commonest causes of an acute limb ischemia. And remember the word arterial. So if it is venous, you have time. Whereas when you're sitting on an arterial etiology, you don't have time. So embolus, what kind of an embolus? I'm sure all of you can read that. I'm not going to read the slides, but please think, where is the origin of an embolus? Always when a patient comes, let's say patient of endocarditis on treatment. Let's say there is a patient on MVP. There is a patient on AF on treatment. Whenever you get such patients, please ensure you make it a habit to look at the limbs and check the pulses of all the four limbs as a default. So acute limb ischemia may not come directly to you with the classical symptoms, but you have to ensure you do all the basic clinical assessment of these patients who come with these diseases. Thrombosis, certainly about aneurysms. We just heard one of the aneurysm being discussed, and certainly the hypercoagulable states. So protein C or S, protein deficiencies, any patient who is on some kind of atherosclerotic diseases, please ensure you look for pulses for all patients. Make that a habit, and I'm sure that will pay you well. Let's come to the pathophysiology. Like I said, it's usually an emboli traveling from somewhere, and where else can it? It's usually from heart, and very, very common is MS with an AF or an MI with a mural thrombosis. It's usually a dilated diseased arteries or an aneurysm which has just burst open. So an emboli suddenly occluding in healthy artery, it usually arrests or a complete cessation of blood flow from the proximal to the distal. And its favorite place is the bifurcation. That's crucial because there you're blocking more than just one artery continuation. So that's usually is the embolic ischemia, and the way it looks on a on an X-ray or a CT angio. This is how it looks on a CT angio, where there is complete cutoff of the dye on the right side, if you can see. And this is a classical way how a saddle embolus of the iliac artery looks like. So this is the etiology of a thrombotic ischemia. Like I said, here the culprit is the local, where the artery itself is diseased. And then you have periodic, buildup of thrombus. And then one fine day, there is a big clot and it completely cuts off the blood supply. So the importance here is acute thrombotic usually takes time, whereas embolic is very, very fast. That's the culprit area. Yes, collaterals sometimes, but when you don't have collaterals, that's when your emergency time ticks off. So what happens? The classical 5 Ps, I'm sure all of you are aware and know this. And if you don't know, this is very, very simple to remember. So what's the first symptom that somebody comes to you with pain? Obviously, it's color. First and foremost, look at the color and always compare it to the next limb. Put both legs, both hands next to each other. Look at the color. First is it loses color, then it becomes cyanosed because of the pulling of blood. Then there is mottling, and then the mottling doesn't disappear when you press or remove your thumb. So that's the very, very classical initial symptom. And then what happens? Second is your inspection then has to go on to looking at the pulse. What's the important thing that you do? All the big pulses, femoral, popliteal, tibial, dorsalis, pedis, radial, ulna, brachial, and auxiliary. Ensure you check. Believe me, you're not going to diagnose an acute ischemia only by a Doppler or an angiogram. This is what an emergency physician is supposed to do. Elicit pain, look at paleness. Third important thing is check for pulse. Very, very basic. You can pick 9 out of 10 cases if you do this properly. So paresthesia, there is certainly loss of, there's a feeling of numbness to begin with. And then as the numbness increases or the ischemic time increases, there is a sensory loss. And the sensory loss is as per the distribution mentioned there. But just remember, any numbness and any progressive loss of sensation means that you're just losing the bus. So please don't delay. Ensure you pick these things up. And remember, you're the only physician who's going to look for this, pick it up. And if you miss it, then there'll be a loss of limb or morbidity. Palpation, very, very important. Ensure you look for motor function. But I must say this is very, very late sign. And if you're looking at paralysis or you're looking at all this, then you missed the bus or the patient has come late to us. So let's look at the management quickly. Like I said, in a stroke or an MI, this is exactly like you're sitting on a ticking time bomb. The time is everything. Limb or no limb depends on how quickly we pick this up and get it to the right person to do the intervention. So general investigation, as soon as the patient comes, I would still say that examination precedes every single thing that you do in an approach to acute limb ischemia. And the labs will be sent, but these labs will never come to you when you want to make a decision. This is for the evaluation of the patient. What you need to do as an emergency physician is what you need to examine, and that's completely within you. And I'll tell you, these examination and the gadgets you need are very, very simple. So a simple Doppler, and this is very, very easy because it makes some kind of noise. I don't know how many of you have used. Very easy, doesn't need a lot of technique to be learned, non-invasive, easily available. And that's how your strip looks like. Important is, even if with a less training, if you don't hear any sound when you put the Doppler on that, then please call your vascular surgeon. What interventions you have to do in the ER, please start off. Then that means you're certainly sitting on an artery which has no blood supply down the line. Whether it's ankle, hand, popliteal, please ensure you do Doppler, because this is very, very easy to interpret. This is another important, easy hands-on process that you can do. Ankle brachial index. What you're going to do is to measure the ankle pressure and the brachial pressure. They should match. If it doesn't, then it only shows that whether they have a mild, moderate, or a severe disease. This is one of, it's not very, very sensitive, but it is one of the thing that you can always do and document so that you can put the disease into one of the category. So if time permits, yes, I'm sure all of the departments that where we work, radiology is just next door, or there is a machine. Do a duplex where you can see the waves of the blood flow in the affected artery, or where you suspect there is a thrombus. Just below and above is when, and the radiologist can trace it down. You can learn this too. This is not very difficult. And all we have to do is to learn for very specific arteries. We are looking at acute interventions here, mind you. So arteriography is one of the investigations that you can do, where it can clearly tell you whether it is embolic or whether it is thrombotic. And if the limb condition persists, then you will have to do an angiography. CT angiogram or an MR angiogram is good enough, both. And the importance is we need to pick the localization. Where is it? Which level of the artery is the blockage? And where do you need to do an intervention? Importantly, you can pick an embolus here and ensure we can do the intervention what is needed. Quick look at the differentiation. Emboli, like I said, cardiac most of the time. Claudication, no, because this is acute. And there is absolute normal pulses on the other limb. Angiogram, very minimal disease of the artery. Whereas thrombus, usually not a cardiac source. Claudification, yes, and they would have had some kind of an artery disease before. And then abnormal pulses everywhere because it's a systemic disease of the artery. So there you go, very simple, only one classification. Look at your patient and put them into one of these. Category 1, 2A, 2B, and 3. Whether it is viable, category 1, threatened, the biggest opportunity for us to intervene is here, whether it is threatened to A or to B. So that's important, and let's go into treatment so that we can look at what we are supposed to do. Immediate care, ABC all the time. Ensure you get your lines, ensure you manage your ABC, ensure you have all the thrombolytics stocked in your department, streptokinase, urokinase, alteplase. The dosage is also very classical, remains same, and have your surgical surgeon informed right away. Immediate care, anticoagulation and fraction heparin, analgesia, your pain ladder, what you follow. Ensure you measure and maintain the existing perfusion. ABC, circulation, MAP has to be maintained at all times. Let's say these are all the things what you can do. Put a catheter and go and remove the clot. You can use all the thrombolytics that we know and generally use. And what are the contraindications? They're pretty much same. CVA in the recent past, any recent GI bleed, any active bleed, intracranial pressures high, or intracranial trauma. All these are pretty much classical contraindication, what you all know for stroke. So surgery, what are the surgical options? Embolectomy, where you put a tube and then balloon, open the block. And these are all the mechanical thrombectomies that you can do. Different names, but the job to do is to remove the thrombus or the block what is there. So that's just to show you how intense the disease is, and this is most probably a thrombus there. And surgical, obviously you can go and remove the thrombus or do a graft and ensure there is, if nothing happens, nothing works, this is not a good outcome, but amputation is the only outcome we can do. Dr. Kishal, I just need 1 minute, sorry.
Yeah, sure.
So mortality, 15-20%, major morbidity is bleeding, amputation. You have to be very careful with the third one, fasciotomy. Look at the limb. If there is swelling, if you think that going into a compartment syndrome, please ensure we do a fasciotomy quickly. Renal insufficiency, most probably because of the rhabdomyolysis. And the anticoagulation warfarin, ensure PT, APTT are checked. And these are novel things. You need to know, you may not be doing this, but you should just know. And I will skip all this and go to algorithm. That's the last slide. So if look at what is class 1, class 2, class 2B and 3, look at what are the best interventions you have to do. The danger is 2A and 2B. This is where your intervention has to be extremely spot on and ensure we do it at the right time. Remember, nobody is examining the limb before you. I again stress examination number 1, and then the gadgets come later. So that's my bit of it. I'm sure all of you are taking care of yourself. Please take care of yourself to ensure you take care of patients. I wish you all a very happy new year. And I look forward for 2 days to have a very happy learning. Thank you. Sorry, I exceeded by a couple of minutes.
Thank you, Dr. Nischal. It was an excellent presentation. So we came to know about many things. So at the end of Dr. Nischal's presentation, we conclude our session 2. Now we'll be inviting all our speakers in this session for a discussion, round of discussion. We have Dr. Kole with us. We have Dr. Sanjukta with us. We have Dr. Nischal with us, and we have Dr. Nishant with us. All of us are there, right? Dr. Nishant, are you there?
Yes, sir.
Yes. So I open this session to all of our participants. Any questions, please? You can type, or you can directly send, or you can directly ask to the speakers. So beginning, I have a question for Dr. Kole. I would like to know more about the HERE score. TMAX score we have hard, so less than 0.02 to equal to or more than 0.05. That's the range. So can we use it regularly in our EDs? We don't use this TMAX score till now. Our cardiologists are also not much helpful regarding this score. So what's your yeah?
The HERE score, which is just released, as I say, that that doesn't use the troponin. You know, now for years, and have you seen the guidelines? The troponin is the mainstay of many cases making decisions.
Yeah.
Now this is the first time Richard Body, who is an authority over the risk scores. He's an emergency physician based in UK. I have interaction couple of times with him. So what we have to think is, what is our resources? If we have access to troponin, especially high sensitivity troponin, the guideline says, and logically it is also concluded that we use troponin in decision making. But if we don't have troponin, we may use HERE score because it has clearly shown benefit in reducing the major acute cardiac event, which is the main concern post discharge of a patient, which can lead to bad outcome medically and legally as well. So I would say wait for some time on HERE score, let more studies come in, use high sensitivity troponin, and most important is share decision making with the patient and use of clinical decision pathway, and not acting on a single individual's assumption or intuition or gestalt.
Thank you. Any more questions for Dr. Tamorish on this platform? Please go ahead. All the participants, please ask him directly. Anyone? So let Dr. Tamorish be online. We'll be moving to our next speaker, Dr. Nischal. Any of the participants who wants to ask Dr. Nischal anything? Yes. Yes. Anyone? Someone said something?
So I think if they don't have questions, I think we can discuss among ourselves and question and provide information.
I would like to ask you, when do we thrombolize? Is it with the same dose, or you said the contraindications and the indications are same? We thrombolize such thing with the same dose?
So for streptokinase is usually 50,000 to 1.2 lakh. And what we commonly use is alteplase 1 to 2 mg per kg, 1 to 2 mg bolus. So it's the same dose of 0.05 mg per kg body weight. Whereas I think wherever there is, affordability question, then unfractionated, heparin that we use, 600 units per hour. That's pretty much what we do. And what's important here, I think we all have to remember, is the habit of checking all the limbs and doing the examination, which is what will help us to cut the ischemic time. Whereas where an MI or stroke, where the symptoms are very, very clear, and then people are aware, this is, like I said, a ticking time bomb which doesn't show up quickly.
Do you have a warm ischemic time for the limbs? At what some time where do you intervene? Do you have some time frame or some time guidelines?
So the time guidelines is usually the earlier the best. So it's like 60 minutes is what they say is the best. But the interventions or the morbidity have shown that just like any stroke or MI, the earlier the best. The longer you take, the morbidity is very high. And if you look at what's the best way of treatment with thrombolysis versus mechanical, they are pretty much, the outcomes have been pretty much same. And there is very marginal benefit of doing a mechanical thrombectomy versus thrombolytic.
Yes.
So depends on what setting you are in. I mean, if you are at a place where you have the vascular surgeon, you need a cath lab accessible, and you need to have the ability for the finances. But otherwise, this is very, very sad. It will only result in a loss of limb, which I don't think any of us want. That's the biggest or the scariest part of this.
Okay. Coming to Dr. Tamorish, I would like to ask, so the new classification as per HA is STEMI, NSTS, ACS, and then low and intermediate risk group ACS. So in that low and intermediate group ACS, where we have ECG is to be normal. So how do you proceed there?
Sorry, I could not hear you. What is the question?
So as per the AHA criteria, we have three groups nowadays: STEMI, NST-ACS, and low and intermediate group ACS. So to discharge this, where we have normal ECG in this low and intermediate group ACS, how do you proceed to discharge them in our present context?
Okay. Yeah, so low risk, as I said, you have to follow the clinical decision pathways. So there we have two choices. One is the troponin pathways, troponin based pathway, and then here score, which does not use troponin. And two other important component is shared decision making with the patients, and consult a team before discharge. So that's about low risk. But in low risk also, there is two entity which has been found. One is the known coronary artery disease, and the other one is the coronary artery disease is unknown, or there is no suspicion of coronary artery disease. In the known coronary disease, you have to do further testing. Now again, there are two approaches which has come up into new guideline. One is the stress testing, the age-old stress testing, which is very much feasible and doable in our resource settings. It can be exercise based testing or a pharmacological based testing, but then there is also increasing reference of the coronary CT angiography, and more and more pathway on ED based coronary CT angiography is being evaluated now. In West, especially in US, coronary CT angiography based pathways are being advocated in ED. In our setting, I would say if the patient can afford and if the system can afford, that is one more thing which we can look into.
So now coming to Dr. Nishant, you have been working in Calcutta. So do you get a lot of aortic dissection cases?
Not very frequently, but yes, I have.
Your voice is low. Can you increase the volume?
Yes, sir.
I think, yeah.
Is it audible now?
Yeah.
Yeah. Over the past, in my experience, I have encountered aortic dissection many times. Not very frequently, but yes, it has been spontaneous aortic dissection also, and also related to road traffic accident. Because of the shearing force, we have encountered aortic dissection also.
You get a lot of traumatic aortic dissections, you mean?
Not very much frequently, but yes, I have seen some.
Okay. I haven't seen one
The
of them.
most dangerous one, because the road traffic accident is a shearing force, and then the aortic dissection, it is a progressive one, and the patient collapses like anything. Along with the other injuries, the patient is having aortic dissection. So we tend to get misguided by the other injuries which are present, and the chances of missing the aortic dissection is very high in these cases.
Yeah. Dr. Sanjukta, are you there? Dr. Sanjukta.
Yes, I am. Tell me.
Yeah, I saw in your PPT there were 6-7 cases. All patients complained of chest pain, and we had gone for CTPA. So
not all complained of. Sorry, Kishana, not all went for came with chest
all
pain.
that having chest pain.
No,
So
not really. I can go back.
Listen to me, yes. Is there a guideline so I come and complain of a chest pain, and whatever history I have, you doubt, and will I go for a CTPA? That was my thinking initially when I was looking at the case presentations. Do you have a guideline for that?
Sorry?
Do we have a guideline for CTPA?
Even
On
if
what
it is,
basis you need to, yeah.
I am not totally aware of any particular guidelines. If you know, you can go ahead. But what I believe, if we are getting any specific reason of the chest pain, so then we are done. Like a patient comes with chest pain, we are finding STEMI, we are finding aortic dissection, we have got a reason. So we are not suspecting PE at that point of time. But there is chest pain, we are not getting any reason of it. And with that, definitely we will search for the risk factors. So as I said, this is very important in case of PE. One, if there are risk factors of PE, we need to be very cautious. For us, I'm just telling, we had one patient. The patient came with complaining of hemoptysis. The way she was bleeding from mouth, it was definitely looked like blood vomiting. But later on, found it was massive hemoptysis.
Okay.
It was massive hemoptysis. He was, coughing out blood. She was, getting all those blood inside her stomach and vomiting those out. When we did a CTPA for this patient, it was a huge pulmonary embolism. So basically, it is not just chest pain. There are multiple atypical presentations of pulmonary embolism. It is very difficult to find. Even if I say all this, maybe there is a high chance we might miss one. But the only thing I want to stress upon is we need to be cautious so that we think of pulmonary embolism when we are in doubt, we are not finding anything. If we are finding something, still we are thinking that we need to rule out. If there is low risk, we can do a D-dimer. If D-dimer is normal, we can say the patient is fine. But if you are suspecting it, then I think we definitely should go for CTPA.
Okay, thank you. So thank you all of, thanks to all of you. We are proceeding to session 3 as we are paucity of time. Thank you again. It was excellent talking to you guys. Thank you so much. Thank you.
Thank you for moderating this so nicely.
Thank you.
Yeah, really, you were doing it the way we will sit in the stage. Usually the virtual moderators are kind of quiet and we can see them.
Thank you so much. We'll be proceeding to
all the best, everybody.
Thank you.
Thank you all. Thanks for your time. Good to see you all. Bye.
So we'll be proceeding to the third session. So we'll start with my friend and colleague, Dr. Venkatesh. He's down with COVID. He's also the national president for SEMI. He sent us a pre-recorded video. We'll play on that. So again, for those of the participants who have joined late, here we are proceeding with the day 1 session of Semicon. We are into the session 3, and we start with Dr. Venkatesh, who is our national president of SEMI. So as he's down with COVID, we'll play his pre-recorded PowerPoint. Thank you. Go ahead. So he'll be talking on lung protective ventilation. is the Senior Consultant and Head, Department of Emergency Medicine, Apollo Hospital, Bangalore. He's also our National President for SEMI. So let's play his pre-recorded PPT and let's follow it. Thank you. Over to you guys. Please start the presentation. Please put on the audio also.
With common cold and flu-like illnesses to severe hypoxic patients presenting in respiratory failure. Acute respiratory distress syndrome is one of the serious complications of involving lungs. This could be a complication of disease of lung or as a result of systemic response from illness elsewhere in the body. Today, let's have a look at what is ARDS. What are the available strategies we can implement in our emergency departments to improve patient survival? Also, we will have a look at changes in COVID ARDS, that's CARDS. What is ARDS? Acute respiratory distress syndrome. The most recently accepted one is the Berlin definition, which describes ARDS as an acute diffuse inflammatory lung injury leading to increased pulmonary vascular permeability, increased lung weight, and loss of aerated lung tissue with hypoxemia and bilateral radiographic opacities, which is associated with increased venous admixture, increased physiological dead space, and decreased lung compliance. As we can see, this illness is due to complex pathophysiological process in lungs. The description of illness does not end there. Along with the complex above description, the key components of ARDS also need to satisfy the following. The onset of illness should be less than a week. They should have bilateral opacities consistent with pulmonary edema and may be detected on CT or chest radiograph with PF ratio of less than 300 mm of mercury, excuse me, with a minimum of 5 PEEP. Also must not be fully explained by cardiac failure or fluid overload. In the physician's best estimation, using available information, an objective assessment, example echocardiogram, should be performed in most cases if there is no clear cause such as trauma or sepsis. Now we can get our patients at various stages of this illness. The severity can be categorized as being mild, moderate, or severe. They can be classified based on PaO2 or FiO2 as shown in the table. As we can see, even in mild forms, the illness mortality is quite high, that's up to 27%. One in 4 patients with mild ARDS do not make it. Excuse me. These only get worse with severity to mortality for 1 in 3 in moderate, and in severe cases it is almost 1 in 2 patients do not make it. As we have seen so far, in ARDS there is a lung dysfunction due to pulmonary edema leading to decreased oxygenation, which in turn results in decreased oxygenation of vital organs. Next, ARDS is a result of complex interplay of various inflammatory mediators resulting in diffuse alveolar damage, non-cardiogenic pulmonary edema, surfactant dysfunction and atelectasis. This interplay of inflammatory process classifies ARDS into 3 phases: the exudative or acute phase, the proliferative or subacute phase, the fibrotic or chronic phase. The role of angiotensin II has been recognized as being of particular interest because of its ability to induce alveolar apoptosis and fibrosis, highlighting its further research potential. Next, Coming to the exudative phase or an acute phase, this results in hypoxemia and a reduction in pulmonary compliance, owing largely to alveolar flooding with protein-rich fluid. Radiological evidence of infiltrates appears during this phase, which can last for up to a week of time. The proliferative or a subacute phase may occur from day 5 onwards, with further reduction in lung compliance and continued hypoxemia, owing to fibroproliferation and microvascular thrombus formation. Some patients show rapid clinical improvement at this stage, others progress to the last stage. Next, coming to the fibrotic or chronic phase, this is characterized by widespread fibrosis and lung remodeling, which may be irreversible. These phases can happen in sequence, or the illness may develop and progress in hours. Next, as seen with the key components, each element of the component is in line with the pathophysiological process of illnesses. Next, coming to the X-ray of a patient having ARDS. As it can be seen here, there are bilateral infiltrates with pulmonary edema features. And the pictures we can see why the shadowing present in the region due to the fluids in the lung. In further detail look, we can appreciate the fluid is in alveoli represented in the pictorial way here. Next, coming here, we can see another patient of ARDS showing features of pulmonary edema in a CT scan. It is important to note that the opacities are distributed centrally and the peripheries are free of opacities. This is important nowadays as the patient with COVID pneumonia present with non-homogeneous opacities, but they are distributed more peripherally and then more inwards. Coming to the causes of ARDS, there are direct causes like pneumonia and there are some other lung problems. Indirect causes will be like sepsis, trauma and others. Next, how do you manage these patients in emergency department? As we are all aware, this is not a condition which can be treated and discharged from emergency department. These patients need intensive care management and and continuous care. It's important that we recognize these patients in ED and initiate the most appropriate management. Once recognized, it is equally important to actively intervene and escalate the management of such patients, including endotracheal intubation, where needed to prevent further deterioration of the. There are various elements in the management of patients with ARDS, like fluid management, optimizing hemoglobin levels, pharmacological intervention, ventilatory strategies if patients are still not responding, can consider proning and ECMO. Next, the fluid management. This is one of the basic management for many illnesses in ARDS. It has also been noted that in patients who are prone, early aggressive fluid management can reduce the mortality and morbidity. Once the diagnosis of ARDS is confirmed, either conservative fluid management or liberal fluid administration has not been shown to be beneficial, but fluid management is crucial in the management of ARDS. The trials with albumin have shown some short-term improvement in patients' condition, but no mortality or morbidity benefits. Even assessing IVC for fluid status have to be done with caution due to complex pathophysiological process in ARDS and also considering the pre-existing condition of the patients. Hemoglobin is a primary transport of oxygen in our body. Hence, it is important to make sure that the patient has a hemoglobin level of 7 to 9 for better delivery of oxygen. But be cautious as transfusion can cause transfusion-related acute lung injury. Next, coming to the drugs which can be started for patients in ARDS in emergency department. First is antibiotics. Early antibiotics are very helpful. Antibiotics have shown to have immunomodulatory effect in the pathophysiological process as well as hence early appropriate antibiotics are beneficial in ARDS. Next, the steroids. the advice and guidance on use of steroids has been fluctuating for years. The current recommendation is to give steroids in ARDS. Coming to the immunomodulators and anti-inflammatory. These group of drugs are used in blocking the specific inflammatory pathways and hence modulate the disease processes. Next, the anticoagulants are helpful in prevention of venous thromboembolisms. They act by modulating the coagulation pathway and hence preventing further complications. Nitric oxide has been previously used with questionable benefit. One of the most important mainstay in management of ARDS is assessing the early use of ventilatory support where it is indicated. Strategies which are useful in these steps are limit tidal volume, provide adequate PEEP to keep the lung open and prevent alveolar collapse, limit end inspiratory plateau pressure and limit the FiO2. Next, coming to the tidal volume. Set the ventilatory setting with low tidal volume. Consider ventilating as a baby lung. Monitor the plateau pressure and keep it less than 30. Titrate tidal volume to achieve this. Next, about the positive and expiratory pressure, P. Adjust PEEP to achieve target saturation and try to achieve target saturation of at least FiO2 possible. Next, titrate down the FiO2 to the lowest possible required as soon as possible. Adjust PEEP to achieve the target saturation of 95%. 88 to 92% in COPD or obstructive sleep apnea patients. Patients who are not responding to the above measure would be tried on proning. Proning is a procedure of ventilating patient while patient in prone position. As this has risk of its own, it has to be done only in specific units who would be able to manage these patients. Prosiva study showed the benefits of prone ventilation and augmented the use of prone ventilation. As proning is not conducive in every emergency department, a trial of reverse Trendelenburg position is tried. Patients who are not responding or deteriorating to all the above measure can be assessed for consideration of ECMO as per the ELSO guidelines. In today's case of increasing COVID cases, ARDS can present in COVID patients as well. It is important to identify these patients early as these patients show response to ventilator in improving their hypoxemia. Various studies have shown the contributing factors toward COVID patients developing ARDS as shown in this table. The commonest we notice is like obesity and hypertension along with other comorbids as listed. Now it's been noted in COVID patients who present in ARDS, they can be classified as L-type and H-type patients. As shown, the patients with L-type have low compliance, low lung weight, and low recruitability. Hence, we should remember that these patients can tolerate slightly higher tidal volume as compared to other ARDS cases. Hence, it is important to identify these patients early and start on aggressive ventilatory therapy. The type H patients are similar to other ARDS patients with stiffer lungs, reduced elasticity, and hence have potential for lung recruitment strategies. Though these patients need intensive care and interventions of intensivists for ongoing care, as emergency department, we need to recognize these patients early and initiate the appropriate treatment at the earliest. In type L patients with dyspnea, several non-invasive options are available. High flow nasal cannula, that is HFNC, continuous positive airway pressure, or non-invasive ventilation, beyond which early critical care intervention has to be considered. So once the patient is intubated and deeply sedated, the type L patients, if hypercapnic, can be ventilated with volumes greater than 6 ml per kg, maximum up to 8 ml per kg, as the high compliance results in tolerable strain without the risk of lung injury. Prone positioning should be used only as a rescue maneuver, as the lung conditions are too good for the prone position's effectiveness. The PEEP should be reduced to 8 to 10 centimeter, given that the recruitability is low and the risk of hemodynamic failure increases at higher levels. An early intubation may avert the transition to type H phenotype. Type H patients should be treated as severe ARDS, including higher PEEP, if compatible with hemodynamics, prone positioning, and extracorporeal support. So definitely, early we have looked what is ARDS, its pathophysiology.
Dr. Venkatesh, we on behalf of Semicon wish you a better health. You should be okay from COVID soon. Thank you for your pre-recorded video. As we move on, we come to our next topic or PowerPoint presentation. That will be next PowerPoint presentation topic is NIV Beyond Horizon. Dr. Sanjay Jaswal is leading the emergency department in Max Patparganj. He will be talking to us on NIV Beyond Horizon. Welcome, Dr. Sanjay.
Thank you, Kisada. How are you?
I'm fine. How are you?
All good.
All good.
So thank you everyone and the members and organizing committee of Semicon 2022. So before I put on my slide, it is just a little historic slide, which I have as my first slide. And I'm sure most of you know this slide. Is it shareable?
We can see the slide.
Yeah. So just for some fun, there's a very simple quiz that name an all-terrain vehicle with zero carbon emissions. There would be a lot of answers because in today's date, there are electric vehicles also, but electric vehicles are also not all-terrain vehicle. So why this quiz? This quiz was asked to be by course director way back in 2008. And everybody knows who my course director was, Dr. Tamorish. And the whole idea from his side was to inculcate the habit in all the residents, like whenever you get a presentation of any kind in your department, any kind of patients, develop a habit of assessing and understanding its pathophysiology, because behind every presentation, what you see in ED, the presentation could be same, but causes can be very, very different. And once you understand the pathophysiology, you can be able to treat the patient. So NIV is again a part of ventilation, and there's nobody better than Dr. Kishle Dutta here who can tell us what ventilation is all about. So thank you everyone for joining today on camera from across the country for Semicon 2022. I would like to congratulate the entire organizing and scientific team of Semicon 2022 and of course the Semi West Bengal. I'm actually excited to talk to you all regarding one of the most passionate things that we as an emergency physician will ever come across in our career. And NIV basically has fundamentally changed the way we take care of our patient and approach their plan of care. I'm also eager to share the same. I wish there would be an easy magic trick where we can buy, like 7 to 8 lakhs rupees of machine, which can understand the physiology itself and will do the needful. Well, we all know it's not like that. It takes a lot of time, effort, ingenuity, and commitment from an ED physician to help our patients with proper ventilation and gas exchanges. I will talk in very brief about the NIV and its importance in our life, because it's easy to learn when to intubate, but we need to learn and understand when not to tube our patients. And NIV is such a thing which protects a lot of intubation, and it really needs a lot of focus, planning, and understanding of physiology and not only the patient's pathophysiology as well as the machine, how does it function and how does it work about the ventilation. So this is a small case which came like 60 years old male who presented to an ED, which is a very common case. Every ED gets such kind of patients, and this kind of patients will typically be, smokers, chronic smokers, shortness of breath with wheezing and a low saturation. So how do we approach such kind of patients? What do we do next is like you start thinking and making differential diagnosis, and in your differential on the top of your list will be a COPD case. So you know what COPD is and its pathophysiology. Basically, this patient is having SOP due to obstruction and hyperinflation of airway. So what we do, we order for a gas ABG and see how this patient's blood gases are. So you can see there is a lot of acidosis, there's hypercapnia with low oxygen level. So basically this patient is in respiratory acidosis. So we all need to understand that NIV would be used in shortness of breath, either due to a pulmonary cause or a cardiac cause like heart failures. So I will not discuss much about pathophysiology because COPD is one of our speakers who is going to speak on this. So, but just to make a basic understanding that how NIV we use, thinking what, because COPD we all know is an inflammatory condition which involves the airway, lung parenchyma and pulmonary vasculature, of course. So what happens, there is obstruction of the airways which causes a decrease in the forced expiratory volume and which impaired, due to which the gas exchange is impaired. There's also hyperinflation of the lungs, which will be seen on the chest X-ray. If you see, the COPD X-rays are very, very typical, which occurs due to the air trapping from airway collapse during exhalation. There would be also reduction in ventilation, which causes elevation in carbon dioxide levels and impairment of gas exchange. So when we understand this pathophysiology, now we know what would be the action of NIV. First, which is there's an obstruction which happens due to increased inflammatory cells, which produces mucus, which contributes to the obstruction of the airway. So action of the NIV on this kind of obstruction would be positive pressure will be given, which will stent open your airway. Second thing, hyperinflation as one of the other pathophysiology which is there. So what happens? There is alveolar destruction secondary to emphysema, which leads to loss of elastic recoil and leading to hyperinflation. So what happens? The EPAP in the NIV will prevent alveolar collapse. Third thing, the increased work of breathing because of the hyperinflammation. There's high intensity pressure support ventilation, which reduces diaphragmatic effort. And due to this, there's a decrease, we can save the decrease in work of breathing. So now coming to the non-invasive ventilation, which is the main part of this presentation. So basically, ventilation in itself is a big art. You need to be very, very smart and understand the machine and the patient both, because every setting there's not a blanket rule that every patient will have the same settings. The patients are different, so you need to play smart. You need to have an art which requires the ability of clinicians to choose the best ingredient. Ingredients means the settings of IPAP and EPAP for a successful recipe, avoiding intubation in case of a respiratory failure. Then what is that NIV? So NIV basically refers to the administration of a mechanical ventilation without using an invasive artificial airway. I mean, without intubating the patient, It eliminates the risk associated with intubation, number one, because that's the added advantage, because like upper airway trauma and ventilator-associated pneumonia. Secondly, it also helps to reduce patient discomfort and the need for paralysis and sedation. Thirdly, it also preserves airway clearance and swallowing. Hence, normal eating, drinking, communication and expectorations can be permitted during when you're treating the patient with NIV. So indications basically are two. I'm just making a very, very short presentation because the NIV is a big chapter. I am just trying to contribute the little knowledge which will be useful for the residents as well. Either there will be hypercapnia or hypoxemia. So these are two indications, broad indications for NIV. So hypercapnia, we all understand it can be due to exacerbation of COPD. It can be in acute asthma. It will decrease work of breathing and unload respiratory muscles. Secondly, it can be in the hypercapnia due to post-extubation acute respiratory failure, which is a planned strategy in selected patients. Thirdly, we can also notice in patients with OSA or obesity where hypoventilation syndrome or neuromuscular weaknesses can lead to hypercapnia. Secondly, the indication which was hypoxemia. Hypoxemia can be in various causes, like in pulmonary edema where alveolar recruitment or decrease after load or decreased work of breathing is done. In post-respiratory or traumatic failure, we all know because in the trauma there could be various rib fractures and all those things can lead to all those things. So pre-oxygenation prior to intubation and patient not candidates for intubation or on comfort care are also indications. So we should also understand certain contraindications to use NIV. And the most important are like anatomical barriers to mass seal. If example like facial trauma or burns where the mask cannot be sealed properly on the face, you cannot use NIV. Then in cases where there are a lot of respiratory secretions, like BiPAP, if you are using BiPAP, it will generally impair expectoration. BiPAP should be avoided for patients with copious secretions, which can develop mucus plugging with subsequent deterioration. Also, the patient has aspiration risk. For example, the decreased mental status. Patients with depressed mental status are at increased risk of aspiration. However, many patients with somnolence due to hypercapnia will do fine with BiPAP. So you need to be little judgmental use you have to do, calculative, where in every mental status, decreased mental status, you should not be saying that this is a contraindication. So in GI pathology and vomiting, we know the intractable vomiting increases the risk of aspiration again. Then GI pathology may increase risk of MSS, for example, like in pancreatitis or bowel obstruction or GI hemorrhage. So untreated pneumothorax can also convert a simple into a tension pneumothorax. Now that we understand a little bit about the pathophysiology, indication and contraindication of using NIV, I would just like to simplify into, the rules of tools. So much of information we have got. So it's a simplified algorithm so that we can remember everything important about NIV. So the rules of two will always help us to remember everything. For example, the rule number 1. So the two types of respiratory failures are there where it can be used. Either hypoxemic, like in case of congestive heart failure or LVF, what patients we get a lot of time in our ED and we do not intubate now. Earlier we used to intubate, but now by using the NIV and other treatment line of congestive LVF, we can simply treat this hypoxemia within minutes, maybe 30 minutes, the patient feels better. Or the second rule is ventilation, where there is hypercarbia, like in COPD. The rule of 2. Second, when you have a hypoxemia, you have 2 settings on NIV to improve hypoxemia: increase FiO2 and increased PEEP. In patients who do not improve, especially in patients who do not improve their oxygen saturation with FiO2 alone, because of the lung shunt pathology, physiology is there. So these patients need PEEP to help recruit atelectic alveoli to overcome the shunt. Also, you know that CPAP. So it will recruit the alveoli. In hypercarbia, then again 2 settings: increased tidal volume or increased respiratory rate. So there are many different kind of settings to treat hypercarbia. But generally in BiPAP, what you use a BiPAP machine, you can use increased tidal volume and you can increase the respiratory rate. But there are also other kind of settings, like if you want to wash out the carbon dioxide. I'm sure most of our colleagues must have gone through this during COVID time to wash out the carbon dioxide. You increase the IE ratio, decrease the tidal volume, so increase the PEEP. So you have to play with this machine. So and then monitor the gas exchange, how it is functioning, and then you treat hypercarbia. Second, then there are two types of NIV. One is a CPAP, what you called as continuous positive pressure airway, and the other is BiPAP, which is bilevel positive airway pressure. CPAP can really help in type 1, like hypoxemic respiratory failure, and BiPAP can help in both hypoxemic and hypercarbic both. Then on BiPAP, again, you have two settings on BiPAP, like IPAP and EPAP. So the ranges varies from 0 to 20 centimeter of water, and the difference between both IPAP and BiPAP is what will improve the tidal volume. In other words, the bigger the difference, the bigger the tidal volume. You have to understand this. So these are the rules of two. And back to our case, this case was supposed to be, there were advice given to intubate the patient and all those things. So we use this BiPAP setting with oxygen and bronchodilators, and the repeat ABG had, within an hour, the patient has improved drastically. The acidosis has improved, the hypercarbia was corrected, the hypoxemia was corrected, and the patient, later the work of breathing also was reduced, blood gas improved, and patient was basically discharged after 48 hours from emergency only in a stable condition. So NIV is basically a very, very important tool. If you correct it very wisely, it can change your scenario. So take home point is, you remember actions of NIV, indications and contraindication, reduce the need for intubation. It will help you reduce mortality and the rules of tools. And thank you very much for this opportunity. Dr. Kesle, I'm done. Thank you very much. So
thank you, Dr. Sanjay. It was excellent hearing to you. We'll discuss some questions once the discussion period comes.
Sure.
We are on time, let's proceed with our next presentation, which will be done by Dr. Srinath Kumar, PS. Srinath is a friend and a fellow emergency physician. He is also the academic chair of SEMI, and he is now the HOD of senior consultant and the head of the department of Narayana. Welcome, Dr. Srinath.
Hi, Kishale. Thanks for the introduction.
How are you?
Very nice to see you.
Thank you.
Yeah. I was trying to share the PowerPoint. Can you see my PowerPoint?
Yeah, we can see your PowerPoint.
Yes, Doctor.
Yeah. At the outset, from the Society for Emergency Medicine India, I would like to welcome all the residents, speakers, faculty to this rapid revision course on emergency medicine for this program. And I congratulate Dr. Larry, Dr. Sudeep, and all the organizing team of West Bengal chapter for hosting this on behalf of Society for Emergency Medicine India. So I don't want to waste much time. I would like to proceed with the topic given to me, that is hemoptysis. And as the sessions are going on since morning, I could see that a lot of the presentations have been covered on this topic, especially because everywhere is blood. We know in COVID, it is blood, in trauma, it is blood. When you put a central line, it is blood. So we have to differentiate which and what it is creating the blood. So what do I cover in this next 10 minutes? These are the few salient points which I would like to cover. The definition, pathophysiology. As Sanjay Jaiswal was mentioning rightly, you should always look into the pathophysiology of any disease. That will give you the best outcome. Without knowing the pathophysiology of any disease, you cannot treat a disease in emergency medicine. You have to know the causes, differential diagnosis of the patient, how to do in the emergency department, and treatment of the patient. So as far as hemoptysis is concerned, it is nothing but the coughing of blood originating from below or above the vocal cords. That's what is the simple thing which I would like to mention here. And then the word hemoptysis comes from Greek. That is, hema means blood and tysis means spitting. So that is what, and it can range from a small blood streak in your sputum to a gross blood, which is life-threatening. That is what is the thing. So whenever it is the quantity is more than 600 ml in 24 hours, or if it is more than 150 ml per time, it is mostly called as the life-threatening or massive hemoptysis. And only 5% of the hemoptysis is massive. And when it is massive hemoptysis, we all know in emergency department, prior to emergency departments and now, prior it was 80% mortality. With our interventions, it has been reduced much earlier. And now coming into the causes of hemoptysis, we can look into various types of causes. What we have to look into, especially the infectious, neoplastic causes. So today in India, it's very common with lung cancer, and we all know infectious wise tuberculosis leads the hemoptysis from ages in our country. Cardiovascular wise, I was hearing to Dr. Sanjukta where she was mentioning exactly about the pulmonary embolism. Yes, that is very much true. Pulmonary embolism is one of the leading causes who are more prone for sitting and doing their jobs, especially our software people. Mitral stenosis, congestive heart failure, pulmonary hypertension, all these things. And then the alveolar hemorrhagic syndrome, that is mainly because of the hereditary causes, which I don't want to go into in detail. Then the hematological causes, especially with renal failure patients increasing day by day, you should keep in your mind about the uremia. And now it is the dengue season. We all know platelet dysfunction can cause the hemoptysis. And most of our patients who are on COVID management, aspirin, so clopidogrel, warfarin, all these medications are still going on left and right. So you have to keep in your mind. Traumatic, it is mainly because of your foreign body aspiration, especially in the children, or ruptured bronchus, which is very rare in cause. Iatrogenic, it can be mainly because of we doctors and healthcare providers introducing it, especially when you're trying to intubate a patient, do a bronchoscopy, or doing a lung biopsies. And then miscellaneous, it can be because of the medications and especially catecholamines and cocaine. So this is a full diagram which is showing which is common causes of the hemoptysis, which all the residents have to keep in their mind. And when they're answering, they have, if they look into this diagram, then it will be easier for them. Then it is easier for the examiner also. So when you write it in a depicted manner, you will never forget it. So looking into the mechanism and sources of hemoptysis, these are the sources. Mainly the bronchial circulation. 90% of the hemoptysis is because of your bronchial circulation. Remaining 10% is because of your pulmonary circulation. The mechanism which can cause a hemoptysis is mainly because of the pulmonary hypertension or erosion or rupture of your vessels, which is causing your hemoptysis. And then mucosal ulcers. Bronchial artery, you have to note this diagram because you can note where it origins and where it ends. So the origin, we all know it is from the thoracic aorta. 80% arise above the T5 to T6 level, and the systemic pressure is the main thing. 90% of the source is because of this. Cryptogenic, when you don't see any cause which is causing the hemoptysis, then you automatically say it is an idiopathic cause. So what is the complications? As an emergency physician, we have to be careful about hemoptysis. When they come into emergency department saying that there are hemoptysis patients, then the thing which you have to note is the ABC. In the airway, you can know that the patient can go in for asphyxia. In the circulation, you can always look into shock, anemia, renal failure, or atelectasis. And then the disability wise, when you're looking into the commonest causes, then you can look in for pulmonary infections. So what is your approach for a patient who is coming with your hemoptysis? The approach is very important. Look into whether it is a true hemoptysis. That is the first and foremost important thing. And then look into the severity of the hemoptysis. Look into the clues, which will always give you with the history. History is very important even today. Once you complete your resuscitation, please look into the history, or one of your subordinates or your colleagues, let them keep asking the history when the other person is doing the resuscitation. Looking for diagnostic investigations which will lead you to the cause and the treatment. And lastly, the appropriate treatment, which is important. So grading wise, you have mild, moderate, and severe. That is, if it is less than 200 ml, 20 ml in 24 hours, it is mild. If it is between 220 to 600 ml in 24 hours, it is moderate. Anything about 600 or even 150 ml per time is severe or massive. So important points. I have divided my slides into such next 4-5 slides, you're going to look into like this, which will give you a clinical cue and the suggested diagnosis. Say if there is a patient who gives you an anticoagulant history, then it is the hemoptysis is mainly because of your medication effect. Like this, associated with your menstruations, that is catamencial hemoptysis. If there is a dyspnea on exertion, then automatically you have to think that it is because of a cardiac which is causing the cause. Then if it is a fever or productive cough, we all know it is because of an infective cause. Again, you can also look into, it can be now it is a COVID thing, so you have to look into like this. Then if the patient is having a cancer history again, then you have to look into the metastasis. And if you see that if it is a chronic obstructive airway diseases, then the patient will automatically lead you to bronchiectasis or lung abscess. So like this, each and everything you have to keep in your mind. When you look into this whole picture, you can easily say what is your suggested diagnosis. So there is two things. One is true hemoptysis and the false hemoptysis, which can be more like this. So when you look into the true hemoptysis, it is always mentioned that if it is below the vocal cords, or if there is a persistent blood-thin sputum, or it can be mixed with a sputum, or there is an history of cardiopulmonary illness before, and if the chest X-ray is abnormal, these are the 5 points which you have to keep in your mind that is leading to a true hemoptysis. So when you look into this slide, you can easily mention the differential diagnosis when you look into the patient or you're presenting your case to your examination, this will give you. And if it is a false hemoptysis, it is always exacerbated. And then if it is always above the vocal cord, it does not persist, it is not mixing with your sputum. And when you just put your tongue depressor and see, you can see that it is the cause, you can automatically see it is just above the vocal cords. And when you take an X-ray and see, it is normal. Examination, clinical science is very important, my dear friends, because I see every resident, once the patient comes in, he'll be taking an ABG, he will do ready with the ultrasound probe, and the other person will be looking into the investigations, what he has to send. Please remember to have your clinical clues. Clinical history holds good even today. Signs and symptoms will hold good. Please keep your stethoscope. If you are unable to keep your stethoscope, ultrasound probe is there, which is an alternative and which will suggest you the diagnosis. So clinical clues, accordingly, you have the suggested diagnosis. So to want of time, I can share you the slides to the organizers. They will share you and you can look into what is the clinical clue which the patient is presenting with and the suggested diagnosis, what you have to look in for. And then differential diagnosis. So always there's a thought, whenever there is a massive hemoptysis, you will get confused whether it is originating from their respiratory system or it is because of the hematemesis, which is because of their GI system. So this is an important point which you have to keep in your mind. So hemoptysis is coughing of blood. Hematemesis is vomiting with the blood. So this is the most important point when you're taking an history, you have to keep in your mind. And always remember the hemoptysis is lungs, cardiovascular system, and hematemesis is your GI system. It will be bright in red in color. Hematemesis, we all know it is dark brown in color until and unless it is frank hematemesis, which is originating from your varices. And always sputum remains bloodstained, whereas the hematemesis will be followed by melena. And then blood is frothy in hemoptysis, but it is airless in hematemesis. And when you look into the pH, it is alkaline in hemoptysis and acidic in hematemesis. So diagnostic features, what is your specific thing? Then keep your pathophysiology in book, look into the clinical clues and accordingly send to your lab investigations. If you always think only CBC, RFT, LFT, these things only you have to send, then you may miss out. Accordingly, you have to look into what is the thing, and then you will also have the diagnostic findings. Like if there is a frank hemoptysis, massive hemoptysis, if your HB can be normal, it can be deviating it in a different way. So you have to look for the hematocrit also. Looking for platelet count, then it will say you it is dengue fever or there is a thrombocytopenia or qualitative thrombocytopenia. Like this, you have to look one by one, and then convert it into your diagnostic tool. Especially, please don't forget today, tomorrow, or any day when you are practicing in India to test for tuberculosis. If you don't test for tuberculosis, you're going to miss it out, because even today that holds good. And then diagnostic evaluation, chest X-ray. So chest X-ray, always examine from the medial to the lateral, make it in the right way, soft tissue, lungs, trachea, bronchi, heart, everything. When you look into like this, you will never miss out your diagnosis, because each and every point you see in your chest X-ray can give you a diagnostic picture when you're looking into the hemoptysis. So like if there is a cardiomegaly and then there is increased pulmonary vascular congestion, so that means that there is a chronic heart failure like this. So if there is a mass, then automatically you have to think about carcinoma, hyperinflation, COPD. If there is one side, there is no resonant node and it is totally black, we all know it is a pneumothorax. If there is blood in the whole pleura, that is nothing but blood in the pleura. So like this, chest X-ray holds good. CT scan, of course, it is a gold standard. It is non-invasive. You can make the diagnosis along with the help of your radiologist. So some of the examples I'm giving you, you can see here, this CT scan, there is a mass and also there is a pleural effusion. So you can automatically tell it is a malignant pleural effusion. And then there is a pulmonary nodule, you can see there, or you can see there is a large cavity lesions. So that means that it is of an infectious cause. So ordering a CT or an X-ray or an ultrasound is not important. Following up and then mentioning the diagnosis in your history sheet is very, very important, because whatever you diagnosed in the emergency department, it will be carried forward either to your ward or ICU, because 90% of the time they believe in their emergency diagnosis and they take it accordingly. So like this, each and every CT is very important. And now coming to your invasive method, that is two things. One is fiber optic, or you can have a rigid. That is both types of a bronchoscopies. Especially if you are suspecting for a foreign body, then fiber optic is the best. You can always take out the lesion. So what is your advantage with the fiber optic? You can always do a diagnostic and also you can do a therapeutic also with the fiber optic bronchoscopy. So rigid, the advantages is wide suction channel. That is the most important thing. But again, it ensures ventilation, because you can know that the fiber optic is thin in nature. You may be difficult to intubate these patients. But with rigid, you can always ventilate the patients also. But disadvantage is you require your anesthetist help to be with your side, and also specialized skills. So this is what is a picture which depicts about the rigid bronchoscopy. Angiography, yes, when you are in doubt for pulmonary embolism or arteriovenous malformation, all those things you can keep in your mind. But especially if the patient is in renal failure, then it will be a problem. So this is one of the picture. You can see the pulmonary embolism with the angiography, which is showing. So this is the whole algorithm for diagnosing non-massive hemoptysis. So you look into this one, then you will never forget the whole picture, whatever I have said last 10 minutes. So you can note this one and then see what is the best, how I have to diagnose the patient, what are the things which I have to consider when a patient comes in with hemoptysis, and how this will be helpful clinically for managing the patient. Now coming to the most important thing, because we are not going to do the rigid endoscopies, bronchoscopies, or fiber optic bronchoscopy also. Our management goal is airway, breathing, circulation. Please don't forget these three things. So your goal is look into the severity, evaluate the patient with hemoptysis, protect your airway, because when you protect the airway, suctioning is easy. You can maintain the saturation levels. Identify the site of bleeding. That is very, very important. Try to stop the bleeding and treat the cause of the bleeding. So two things, whether it is non-life-threatening or life-threatening. So non-life-threatening, you have time, so you can diagnose and treat the patient. Life-threatening, only two things, whether it is medical or surgical. And give immediate reference to a pulmonology friend or a ENT friend. They have to come down there. They will help you out with your fiber optic or rigid bronchoscopy. Look into the cause and do. Along with them, your role is very important because emergency physicians are the fastest to act, to maintain the airway, maintain the oxygenation. So look continuously and then maintain the volume status, because already the patient is losing blood. If you don't maintain the volume status, euvolemia or balanced resuscitation. Maintain balanced resuscitation, that is also more than sufficient. Immediately activate if it is a massive hematemesis or hemoptysis. Please activate for your massive transfusion protocol. 1 PRBC, 1 platelet, and 1 FFP. Don't forget this. Continue with this. And then cross-reference is always very urgent. Please call for help. When you are in doubt, call for help. That is the most important thing. Embolization, you are not the one who is going to do. Radiology, you interventional radiologists, you activate them, say that we are unable to control the bleeding. They will be helping you out for embolization. The complications can be paraplegia due to occlusion of the spinal arteries. And this is how the surgical management, there can be a lobectomy or pneumonectomy or wedge resection or segmentectomy. So these are all high-end surgeries which we are not going to get involved. As a completion sake, I'm just informing you. So this is another technique where you can introduce the balloon and inflate it, and then you can also stop. What is your carry-home message? My carry-home message for you is airway, breathing, circulation. Find out whether it is a life-threatening or not life-threatening. So that is what is the message. Thank you very much. Any further details, we'll have it on the chat box due to want of time. Thank you, Dr. Kishal.
It was an excellent presentation. You are always a good teacher, so the presentation was excellent. Thank you again. Discussions will be done in the session 3 discussion panel. So now I'll be welcoming my friend, fellow emergency physician and a respected name, Dr. V.P. Chandrasekhar. He has been the past president of Society of Emergency Medicine, and he is now the director of SRM Medical College, Chennai. Welcome, Dr. Chandrasekhar. We are waiting for your talk. Over to you, Dr. Chandrasekhar. Dr. Chandrasekhar, are you there?
He is there. He's there. He's very much there.
Okay. So Dr. Chandrasekhar will be presenting about COPD in the emergency room management.
Can you see the screen?
Yes, doctor, we can.
Yes, sir.
Thank you. Very good afternoon, everybody. I'm going to discuss about the COPD in emergency room. Okay, how we going to manage. So I will be discussing only about acute exacerbation of COPD. I don't go into regular management of COPD, which all of us know. I do not want to waste time on that. I'll be talking to you about the step-wise approach from oxygen therapy to ventilator, what to monitor, and what are the pitfalls and pearls, and the take-home message. So when you say what is the definition for acute exacerbation of COPD, there is no clear-cut definition in any of the book given. So every book, every society gives different kind of definition. So at the best one, what we can feel is a worsening of patient symptom from the usual stable state, which is beyond normal day-to-day variations, and which is acute. So that is what we can say, acute exacerbation of COPD. So initially, we all know we will start with the nebulization. That will be continuous nebulization. We will give oxygen, and also we will give nebulization with short-acting bronchodilators and ipratropium. This is there since 30-40 years, and there is nothing beyond. And the steroid, we can give a low dose of steroid for 5 days. That is enough for 5 to 7 days. And the supportive care, IV, and the antibiotics are indicated only when you suspect infection. So antibiotics are not indicated in all the cases of COPD. Only when you suspect purulent and excessive secretions and sputum from the lung, then we can give antibiotics. Otherwise, not necessary. And an X-ray is a minimum basic requirement in the emergency room bedside X-ray. This is because sometimes there will be hidden pneumothorax. We'll be aggressively treating with the nebulization, all these things. At one point, we will even go for NAV. If there is going to be a small pneumothorax that get worsened. So before you start the NAV, at least a chest X-ray is must. And sometimes there could be a pneumonia, we'll be simply giving no antibiotic. It is of no use. So the X-ray can help us to find out the pneumonia. And once you intubate, after intubation, the tube confirmation. These are the three basic requirements for the X-ray. So the oxygen therapy, we can start from 2 to 4 liter, then venturi mask, given non-rebreathing mask. The myth of giving hypoxic drive loss, all these things are not there. Whatever oxygen you want to maintain the saturation up to 88 to 92%, that is enough. So let us not expect 94% saturation. Rather, you give only a target for 88 to 92% of oxygen saturation. That is fine. And the HFNC, after the era of COVID, the HFNC is now available everywhere. We can very well use the HFNC, and there is no clear-cut guidelines, and the proof is not being proved. But what has been assumed, and what has been, some few studies have told that when you use HFNC, this actually reduces the CO2 narcosis by reducing the dead space in the nasopharynx area. So by giving the high flow, the dead space in the nasal and pharynx area is decreased. Thereby, the chance of decreasing the carbon dioxide is that PCO2 may fall down. So one way it is helpful, but when you compare the NAV is always superior. So non-invasive ventilation, this is the best one. Previously, Sanjay Jaiswal has spoke about non-invasive ventilation. And by doing this non-invasive ventilation, we can definitely prevent the intubation and intubation related complications like VAP, sepsis, all these things. And the only thing is the cooperation of the patient side will be questionable. And you see, NICE, like non-invasive ventilation, the routine face mask will be a challenging one because of pain and the leak. But you look in the first slide, this thing, the total face mask, there will be some convenient comfort to the patient, but again, the eyes may be having some challenges. You may have some complications with the eye, dry eye, all these things can come. And the nasal mask is some more convenient, which most of them are familiar with this, that also we can try. The third one is the helmet non-invasive ventilation. This is most comfortable, which I used it during the COVID season. It was not available in the peripheral areas like Salem, all these things. I devised something with a plastic bag. I had taken a polythene plastic bag and stitched a elastic strap and attached the L connector. Through the L connector, we connected the ventilator circuit for the NAV. It was very useful, which could save a lot of life on that. And always keep in mind that if you are going to intubate at the right time. Do not delay it. By delaying it, you are going to lose the patient. So don't think that NAV will improve or mask is enough or oxygen is enough. There is a cutoff point. We should know what time we are supposed to switch on to ventilator. So whenever a patient is restless, don't try simply with oxygen, don't try with NAV, go for intubation. Whenever a patient is non-cooperative, is continuously pulling on the mask, don't try to convince him, go for intubation. Whenever, despite of giving non-invasive ventilation, the patient work-up breathing is very high, or even before starting non-invasive ventilation, you feel that the work-up breathing is very high, you can jump the non-invasive ventilation and intubate. And whenever there is obtundation is the one which will cheat us. When we call the patient, he will wake up and say the answer perfectly, and immediately afterwards he will go for sleep. So this is the one we will be thinking the patient is fine, he's answering me, he's responding to me, but actually not. The CO2 is getting built up, he is going for CO2 narcosis, will be a problem. And persistent hypoxia, even after giving the maximum effort, and anybody in altered sensorium. So these are the indications. We should switch over to intubation immediately. Never ever delay in consoling the restless patient and making the cooperative patient, non-cooperative patient cooperative. These are the strict indication. Go at the early for intubation. So prevent the death. Yes, now we have decided to go. The patient respiratory rate is around 40. He is very restless. He's very restless, and now slowly is going for CO2 narcosis. He is having tachypnea, and his heart saturation is 84, 82%. His PCO is 100 millimeter mercury. So what is the option? There are two options. option A and option B. Because there is CO2 narcosis, COT is high. The option A says respiratory rate of 18 and tidal volume of 500, PEEP of 5 centimeter, FaO2 of 100 and IE ratio of 1:2. Option B, respiratory rate of 12, tidal volume of 400, PEEP of 5, FaO2 of 100 and IE ratio of 1:3. Yes, of course, we being an emergency physician, we are very well aware that the raised PCO2 in a routine condition in a non-COPD patient, option A is perfect. More respiratory, more tidal volume, thereby increase the minute ventilation will definitely help. But in case of COPD, it is not going to help. I will tell you in the subsequent slides how it is. Whereas in option B, we have selected as per the book, respiratory rate of 12, tidal volume of 400, PEEP of 5, FaO2 of 100, and IE ratio of 1:3 or 1:4. So this is okay, but still after that, the patient went for sudden cardiac arrest. So why is it? So immediately CPR was initiated, and while doing CPR, manual decompression of the chest was done. All the trapped air came out, and return of spontaneous circulation has come. But still, you are worrying why I followed all the textbook guidelines. Why did the patient had a cardiac respiratory arrest? The question here is, yes, I will address that next. I will tell you what is dynamic hyperinflation first. So in a normal patient, when the patient is having inspiration, that is 1 time, expiration because it is passive, it is 2 times. That is for normal patients. Whereas in COPD and asthma, the patient is going to have a severe spasm because it is passive, and the expiration is going to be prolonged, 1:4, 1:3 like that. And because there is also hypoxia, patient respiratory drive is going to be high. Before even he completes the expiratory drive, there is another inspiration. It keeps on building up. Before even complete exhalation, next inhalation is started. When it is going in multiple steps, the air is trapped much into the alveoli. That is going to create auto-PEEP. The trapped air is going to create auto-PEEP in such a way that it is going to block or significantly reduce the input to the heart. The preload will be reduced. Because of that, the low preload, patient will go for shock and then cardiac arrest. So to prevent this, we have to address this auto-PEEP. And the first slide. So what is routine for others? Giving more respiratory rate, more tidal volume in otherwise normal patient CO2 narcosis is not fit for the patient who is having COPD. So this is COPD patient, this is normal patient. So we need to have a special consideration to decrease the tidal volume, to decrease the rate, so that they increase the respiratory cycle time. Thereby, we allow the exhalation. Yes, now I will explain why did we lose the patient despite of giving the low respiratory rate, low tidal volume, all these things. This is because you kept the low tidal volume perfect. You kept the IE ratio 1:3, 1:4, that is also very perfect. But what happened? I said the patient respiratory rate was 40 per minute. Now we kept a respiratory rate of 12 here in the ventilator. And you set the IE ratio of 1:3. So what happens? You kept IE ratio of 1:3, the machine will calculate for the set rate. The set rate is 12. If the set rate is 12, each cycle, the cycle time is going to be 5 seconds. In that 1:3, if you give 1.5 is going to be inspiratory time, 3.5 is going to be expiratory time. In real scenario, what is happening? Patient is having the respiratory rate of 40 per minute. If the respiratory rate is 40 per minute, the cycle time of each respiration is going to be only 1.5 seconds. And the machine is giving full ventilation for 1.5 seconds. Where is the time for exhalation? So always keep in mind that we have to set the IE ratio for the patient rate, not for the set rate. So either in severe cases, initial 6 hours or 12 hours or 1 day, initially, I don't say for permanently, initially you paralyze and take over fully. So that what is the respiratory you give, only the patient is going to be, the patient is not going to have his own rate. Or if you do not want to paralyze, fine. You calculate the patient's own respiratory rate. Suppose the respiratory rate is 30. The cycle time is going to be 2 seconds for each breathing. In that case, if you want to keep 1:3, keep 0.5 second inspiratory time. It is very challenging. It is not possible to give 0.5 second inspiratory time on 1.5 second expiratory time. Better to paralyze. Respiratory rate is 20, fine. Each cycle time is going to be 3. 3 seconds, you can give 1 second inspiration, 0.10 second inspiration, 2.2 second expiration. But it is a rare scenario. Now, we are not going to debate when the patient respirator is 20. So, whenever there is an acute exacerbation of COPD, the patient is going for intubation. Either you count the respiratory rate, calculate the inspiratory and expiratory time, and then fix accordingly, or else paralyze the patient and fix the low rate, everything. So, if you fail to do, you keep the rate of 12 and keep 1:3. Each time is going to be 1.5 seconds, and there is going to be mismatch, the patient will collapse. This small thing is not noted in any of the book. That is what you have to note. Okay, so allow low tidal volume, have the IE ratio for the patient rate, not for the machine rate. And if you have a challenge, paralyze for the initial hours, and then we can come out of the paralysis and give a continuous circulation. Now I told about autopeep, all those things, how to identify the autopeep. If you have a graphical representation displaying your ventilator, time is over. Can I speak?
Continue.
Yeah. So in the expiratory hold the expiratory hold. If the bottom line is going to rise above the set peep, that means there's an autopeep. So we need to address aggressively, reduce further the respiratory rate, decrease the tidal volume, and give more nebulization. Thereby you can address. And see this picture, there is a prolonged expiration, whereas before the next inspiration, it is clear. So that in this case, we can be happy. But still we can attempt nebulization to achieve to shorten the expiratory time. See the next graph. Here, expiration is prolonged. Before it completes, the next inspiration is started. So this is not fine. So the dotted line is better. We have to aim for the dotted line. So go for more aggressive nebulization, decrease further the tidal volume. And if you look at the loop, if the left side of the loop is bulging out, probably this is because of the spasm. We need to give more nebulization. The right side of the loop is bulging out. This is because of smaller size ET tube or patient is biting the tube. This is first in handling the COPD. And next, everybody is having a concern about pressure control ventilation, but having very few staff nurses, 1:3 ratio, 1:4 ratio for the staff nurses, having put the patient on pressure control ventilation, we'll have a lot of challenges, because even a small mucus plug can cause a big obstruction. With a small 100 ml of tidal volume itself, the pressure waves will reach the top line, so further ventilation will be stopped. So if you are going to put the patient on pressure control ventilation, one dedicated nurse has to stand next to the patient to monitor each and every tidal volume. Okay. And I would say volume control is better, but at one point we need to go for pressure control. The point is, when you are not in a position to achieve the targeted tidal volume within the pressure limits, then we have to switch over to the pressure control mode. So what is the advantage of pressure control mode? In a volume control mode, the flow is going to be constant. So when the flow is constant, irrespective of the filling of the alveoli, to deliver even a minimal amount of tidal volume, the pressure generation will be more. Whereas when you put the patient on pressure control mode, the flow is going to be decelerating. When it decelerating flow, as the alveoli is getting filled up, the flow is going to be decelerated. With limited amount of pressure, we can give you a better volume. So you can see in this example, see this is volume control, the pressure is 29, the tidal volume delivery is only 502. Whereas in the pressure control we have put, the pressure is 26, whereas tidal volume delivered is 530 or something. So that is how the pressure control is going to help you. And next one, what you have to note is, when you put the patient on ventilator, you look at the loop. If there is going to be something like this is called beaking. It's like a bird's beak. If there is a beaking, that means we are over ventilating. We are causing volume trauma. So here the safe will be 450 ml. See, when it is reaching 525 ml, this is causing beaking. So the small amount of volume can cause more damage to the lung. So you restrict your target volume to 450 in this patient. So this is the most important one that you should know. Beaking should be avoided. And asynchrony, you put the patient and every graph is like this, totally desynchronized. Patient is not at all convinced, not at all cooperative. Better temporarily you paralyze the patient. I don't say permanently, temporarily you paralyze. Then you take over the sedations. And it's also important to know about the ETCO2. ETCO2 should be 35 to 45 millimeter mercury, and the shape should be almost like a square. And initial ETCO is like this, subsequently it is a flat line, means probably you have intubated the patient in the esophagus, re-intubate. Totally it is flat line, the tube is dislodged, it is not in the trachea. So as I told you before, the ETCO2 curve should be square shaped. If we have the curve like this, like a sharp fin, that means there is prolonged expiration, there is bronchospasm, you have to address, you have to be more aggressive in giving the broncho nebulization and steroid and adjusting the ventilator setup. And if you see like this, the bottom line is going high, that is autopsy, air is getting trapped. So be more aggressive on this. So here I have told you when to oxygenate, when to ventilate, when to go for NAV and HFNC, and when to switch over to ventilation, and what are the points you take care of when you giving ventilation, how to tackle the CO2 narcosis, and how to tackle the autopsy, how to prevent the cardiac arrest, and how to monitor with the loop waves that is display as well as ETCO2. And in case of advanced setup, you can go for extracorporeal membranous oxygenation, extracorporeal membranous removal of CO2. But this is possible only when you have the lung transplant ready. It's going to be a bridging therapy for the lung transplant. Otherwise, it cannot be of much useful. And not to miss this, it may be a COPD case. Whatever is the case, we are supposed to take care of the basics. So take care of CBC, urea, creatinine, renal, any comorbidity you address. Take care of CBG. It could have been a silent DKA. Patient must have been having a tachypnea because of DKA. We'll be thinking it is COPD. So address that. Take an ECG, rule out the cardiac problems. Take an ABG, which will help us in identifying the PCO2 value and the oxygen levels. Do an ultrasound. It can easily tell us about the pneumothorax before even the X-ray comes. And DVD prophylaxis is most important because most of the COPD patients will have polycythemia, as well as they are more prone for thrombosis because they are bedridden. And alpha beta is must to prevent the bed sore. Stress ulcer prophylaxis, and make sure when you put the patient on ventilator, you give subglottic suction, closed suction, brushing of the mouth, so that the VAP is prevented. If VAP comes, that's all. Already it's compromised. We cannot save him. Infection control is must. Nutrition is must. And early tracheostomy. So asthma patient can recover fast. COPD patient cannot. So suspect if you feel the patient will have challenges in weaning, don't wait until 4-5 days. Go for early tracheostomy. If you feel the patient is better, extubate him only always on NAV and then take it out. Just like they don't extubate. And early tracheostomy will benefit in difficult weaning cases. Thank you.
Thank you, Dr. Chandrasekhar. It was an excellent presentation. You always give a good idea. Thank you so much. Due to paucity of time, we'll go to our next speaker. Our next last speaker in this session is Dr. Goma Bali Bajaj. She will speak about acute breathlessness, whether it is cardiac origin or respiratory origin. Over to you, Goma.
Thank you.
Goma, are you there? Goma, are you there? Dr. Goma? Dr. Goma, are you there?
Yes, I'm there. Very much there, Dr. Dutta. Yeah. And good afternoon, everyone. And I hope the weather out there is okay, because here it's really extremely cold and really, you know, very cold. And the topic itself actually denotes acute breathlessness. Is it cardiac or respiratory? And in this northern part of India, in Jalandhar, actually, we are actually getting such kind of people, you know, basically, as the temperature is also dipping to -1. Okay.
-1.
Yeah. This and Adhampur and Amritsar, they go to the extremes, you know, actually. According to Stephen Wells, most common causes of dyspnea are asthma, heart failure, COPD, interstitial lung disease, pneumonia, psychogenic problems, you know. We all know that, and we have been treating them in our ED. Emergency departments are always, you know, we are, during the winter season especially, we see that these kind of patients keep coming. Now, how do we actually differentiate that whether this is cardiac or whether this is respiratory, you know? So as soon as patient enters ED in acute breathlessness, what as emergency physicians we should do? First of all, we should take the patient, put the patient attached to the monitor, attached to the thing, set up the, see all the vital signs and supplement oxygen and ventilatory support if required, and start the initial examination. And history is also very important. If the patient is not able to say it out, please ask the relatives, but at least we should have something about the history. The vital signs, including RR, oxygen sat, and temperature, very important. The patient may be cyanosed, may be sweating, they may be pallor. So these are the distinction things, which distinguish that, and we can also make out that yes, actually what exactly it is. In the neck, trachea, you can see the JVP raised, stridor is there. And then what do? We do chest auscultation. That is very, very important. See to the breath sounds. Is it there? Is it not there? Crackles, wheeze, or a rub is there. Go for the murmurs. If you can see the rubs, you can see the gallops, you can see peripheral pulses. Are they symmetric? Check the abdomen. Is it distended? Is it tender? The splenomegaly is there. And the extremities, what do they feel like? Is there edema present or cyanosis is there in the whole face? Lips, nails, these things. So these are the conditions. So as soon as the patient enters the emergency department, we as emergency physicians, we should see to it and understand that, yes, this looks like cardiac, this looks like respiratory. The neuromotor sensory mental status. Now, immediate investigation is what we think is go for an ECG. That is very, very important, an ABG. And these will actually let us know that, yes, is it cardiac? If it is an MI, definitely a patient is of MI is going into failure. We will be able to see, yes, this is an MI patient. Get the lab test done, get the troponins, we can get it done. But chest X-ray is also very important. That is also really very, very important, because when that we can make out that, yes, what exactly it is. But basically before that, just check the patient, see the heart sound. If there are no heart sounds, well, definitely it indicates a patient may be of COPD, maybe of a pneumothorax, a COPD which has actually gone into a pneumothorax. So how do we go for it? Immediate interventions are to be done. We have to give oxygen to keep the oxygen above 95%. Take the blood samples and immediately ventilatory support if required. Now, what are the differential diagnoses of all these things? What we are talking about? Is it cardiac or is it respiratory? So as soon as a patient enters, asthma will present with shortness of breath, cough, wheezing. The patient already has a history of asthma. There is acute exacerbation due to allergen. You can make out there is an infection, patient is expectorating also. And also medicine non-compliance has been done. Patient requires immediate treatment with bronchodilators, steroid, magnesium, if possible, and may require epinephrine also. We go for an ECG and chest X-rays, they can be done later on. But the history of an asthma...
I'll just interrupt, your slides are not moving.
Are they not moving?
Not moving.
But here it's moving.
Okay, continue.
Yeah, COPD exacerbation includes components of bronchospasm, airway inflammation, airway collapse, and emphysema. So precipitants includes infections, allergens, medicines, non-compliance. These are the very important things. And we should also consider pneumothorax with an acute sudden exacerbation. So chest auscultation is very, very important. And if we have an ultrasound, well, that can be immediately diagnosed. That yes, a pneumothorax is there, which can be, if required, treated, or what exactly are we going to do with it? Pneumonia, well, with this season, coming, it presents with cough, fever, hypoxia. It may require ventilatory support. Now, in an elderly patient, pneumonia can just come as a hyponatremia. You can just see if an ABG is done and hyponatremia is present, and patient is also...
Sorry for interruption, ma'am. Your slides are not moving, ma'am.
Are they not moving?
No, slides are
it's
not
moving
moving.
here. But it's moving here.
Ma'am, can you stop share and start share again, ma'am?
Computer term.
Okay, see.
Can you please stop share and start share again, ma'am?
Okay. But okay, here it's moving. Okay, stop share.
Then again share, ma'am. Timer to stop karo.
Is it?
Please move the slides, ma'am. Yes, now it's moving.
Okay. So I'm starting with pneumonia. So pneumonia in an elderly patient, it will always present with cough, fever, hypoxia, and they come with breathlessness. At times, they just come normally, I mean, they're just, there's a disorientation kind of factor present. So that is when we check out for the ABG. And if an ABG shows low sodium hyponatremia, please get it re-evaluated for pneumonia, elderly patient. And chest X-ray is the key diagnosis, and comorbidity is also there. So treatment, we start with immediately, in the emergency department. As it is said, like appropriate antibiotic, we do not give immediately, we give after the lab reports come, and immediate ventilatory assistance is provided. Provide oxygen, provide everything, and appropriate disposition is to be done. If the lab reports show that yes, the patient is really infected, has infection, please admit the patient in the ICU, or else the patient goes to the ward. CHF, patients will present as shortness of breath, again, with exertion, with the history of exertion and on lying down. And they have a previous history of CHF and are on diuretics. They are typically hypertensive patients with crackles at the base of lungs. And so when you auscultate, there'll be tachypnea, there'll be S3, S4, gallop will be present. On auscultation, elevated JVP is there. So it can be due to hypertension. It can also be due to ischemia. It can be due to MI, ongoing, prolonged MI, or high output failure as in severe anemia. So if you see a patient who's very severely anemic, a lot of pallor is there and has come with breathlessness, just think about an output, it could be due to high output failure, and a patient is going into a congestive heart failure. So what do we do with that? We go for an ECG, we go for an echocardiography, in the ED itself, lab, where we go for BUN, creatinine, D-dimer, cardiac enzymes to exclude MI. BNP, this is a diagnostic, and which is typically elevated above 100 in pulmonary edema and LV dysfunction. Definitive management is give high flow oxygen, cardiac monitor, pulse oximetry, all in the ED is to be done. In case of respiratory distress, assist with BiPAP, CPAP, or intubation if required. We can start on with the loop diuretics, nitrates, but do avoid nitrates if a patient is in hypertension. After load reductions, we can give morphine, dopamine, dopamine. And the last resort can be intra-aortic balloon pump, for cardiogenic shock. That a cardiologist has to intervene, and we have to refer the patient immediately to the cardiologist. So the disposition will be either in ICU or in the CCU. COPD, assess the RR, temperature, BP, HR, heart rate, oxygen saturation. Lung auscultations for unequal breath sounds, crackles, wheeze, murmur. So if it deteriorates, there is superimposed infection, cardiovascular events, or a pneumothorax. So anything can be there. So auscultation is very, very important. Chest X-ray is the main diagnosis, and an ECG can also be done, which will reveal the right ventricular hypertrophy or P pulmonale. So we can say, yes, this is the respiratory cause, and this is the cardiac cause. And go in for a BNP, because that will differentiate between a CHF and a COPD exacerbation. APG assesses the respiratory status and cardiac enzymes for the MI. So we have to go in for ECG, X-ray, point of care tests. These are very, very important. But as an emergency physician, just as soon as the patient enters, have a look at the patient and see what kind of breathlessness it is, and what do you exactly think about it. And initial assessment is very, very important. Definitive management in CHF is oxygen, we can bronchodilators, anticholinergics, steroids, antibiotics. After the report come, face mask ventilation with CPAP or BiPAP, and intubation should be the last resort. Disposition, like either you go for ICU if it requires ventilatory assistance. Now, a patient can come with acute breathlessness, and we can just say what exactly it is, could be cynosed, could not be cynosed, but acute breathlessness, so that can be pneumothorax. Once, yes, I did see a case of pneumothorax, and a lady about 30-year-old, she came to the hospital and she was breathless, and she was cynosed also. So I just looked at her, and it felt that there was some tightness was there on her face. Immediately she was put on monitor and everything. The breath sound, no breath sound, and I made out that it is a pneumothorax. So did a needle decompression, and there was a sound, kind of thing, as if some balloon has just, blown apart. And then she was better. And she was, actually, the surgeon was called, and we actually put the test tube and everything and all. And the history was taken, and that it was come out to be that lady, she had a 3-year-old son who was actually the night before was jumping on her ribs, basically. So twice and 4 times it happened, and she felt there was some sound, crack of a rib or something like that. And since then she had the pain. But that ultimately it became, and it caused this tension pneumothorax. So you have to be very careful with the history, and you should take the history properly. So in pneumothorax, sudden breathlessness could be tension, absence of heart sounds, immediate auscultation is important. Chest X-ray, and nowadays we do ultrasound, immediate ultrasound for pneumothorax. That is point of care test actually, and which reveals a pneumothorax, which is to be treated or not to be treated. And in ECG, immediate intervention, needle decompression or chest tubes. And supportive therapy, oxygen therapy, antibiotics if required. So either you give for disposition, it goes to the surgical board. The surgeon has to be asked to come. Now we come to another acute breathlessness cause in the emergency department is pulmonary embolism. Patient comes with breathlessness, pinkish frothy sputum is coming out, could be hemoptysis also with blood. Chest pain, leg pain, swelling since few days, pain, back, going to the back, bluish twinge of the lips and nails, and this is mainly due to the clot which travels to lungs from the deep veins. Now it could be anytime the patient requires immediate investigation. So that time we have to have a very good history just to know whether the patient is ambulatory or has been on bed, since more than 6 weeks. There's been an operation. If it's a female patient, is she in OCPs? And there are so many, there's a recent flying history or whatever it is. There's Perks criteria is there. There is Wells criteria. They are the scores actually which we see, for further investigations required in pulmonary embolism. Immediately, pulmonary embolism can be very fatal also. So we have to treat it as an emergency, and therefore the ECG, we go for an ECG, which may show sinus tachycardia. And there is a sequence that is S1, Q3, T3 pattern. This is termed as McGannon-White sign, which indicates right heart strain, and so it may be diagnostic of pulmonary edema. Get a D-dimer done, which is again, and pulmonary angiography, which is the diagnostic aspect. Lung ventilation perfusion scan, and which actually shows that yes, this is pulmonary embolism. We start with treatment of low molecular weight anticoagulants, released for 3 months, stockings, elastic stockings, and we have to prevent it. So we have to prevent all these things, and we have to counsel the patients also for all the efforts. What is the winning strategy? When a patient comes in an emergency department and we see a patient is breathless, what exactly are we going to do? We are going to immediately order for the...
Madam, sorry for interrupting. Your time's
Yes.
up, ma'am. Time's up actually. And your slides are not moving.
But is it moving? It's moving.
Yeah, it's
here.
moving now. Yeah, ma'am. It's moving now.
Yeah. Okay, just I'm just finishing it.
Okay, ma'am.
Okay,
Actually,
so
okay, thank you.
Okay. Yeah. In patients with acute breathlessness, it can be life-threatening. Always provide immediate oxygen and ventilatory support. Use history and initial assessment for definitive treatment. In COPD presenting with breathlessness, always think of spontaneous pneumothorax. Beware of a silent chest and asthma, sign of impending respiratory failure. Beck triad of elevated JVP, hypertension, and diminished or muffled heart sounds, rarely present in, cardiac tamponade. So we have to be careful. Hypertension can be the late sign of a cardiac arrest. So involve surgeons immediately in tamponade. Bedside pericardial censuses can be done. The bottom line is many problems possible causes of dyspnea, nearly all are immediately life-threatening. They require immediate evaluation and intervention. Provide immediate supplemented oxygen ventilatory assistance to patients in distress. Use history, examination, and stat bedside tests to narrow down causes and begin the initial treatment. That is the mainstay. So before beginning with anything, know the history also and start the treatment. Let the lab tests come later on, but please start the treatment immediately. Thank you.
Thank you, Dr. Goma. We are proceeding. We are concluding the session 3. Now, inauguration of Semicon will be done by Dr. Harike Prasad, and a lamp inauguration will be done. So we proceed with that. Thank you.
Thank you very much, sir. Thank you for giving so much your valuable time. Thank you, sir.
Good afternoon, sir.
Good afternoon, sir.
Good afternoon.
Sir, it is our honor and privilege to have you with us, sir.
Pleasure.
Hello.
Go ahead, Larry. We can hear you.
Yes. Ladies and gentlemen, everyone, it is a privilege and honor to have with us Dr. Hari Prasad. He is an executive chairman of SEMI, and not only an executive chairman of SEMI, he is also the president of Apollo Group of Hospital. He is well known across all over India. And sir, it is our extreme privilege and honor to have you with us and to inaugurate the session with your esteemed speech, sir. Please, over to you, sir.
Good afternoon, everybody, and a lot of familiar faces. I can see Mahesh, I can see Tamorish, and a lot of familiar faces. It's good to be talking to all of you, at least virtually, in these days of COVID. First of all, congratulations for hosting this event. And I think what started many years ago is continuing. And I think it's a very good sign for the specialty in the country. And I think the silver jubilee of SEMI is going to approach in for a couple of years. And you need to make that a big bash and really create a big event out of that. I logged in a little early, or the previous session got a little postponed, whatever way. I managed to listen into some of the lectures of the previous session. And one of the things which I wanted to highlight was, in every other specialty, they have a luxury. And the luxury is the luxury of time. While as an emergency physician in the emergency department, you don't have that luxury. Every second, every moment means life and death for a patient who comes in. Suppose just taking the same tension pneumothorax, unless you put that needle in and relieve the tension, the patient is going to die within seconds. So you don't have that sort of a luxury in the emergency department. And the only way you would be able to perform optimally in a situation like that is to be having adequate knowledge, skill, expertise, and most importantly, the mind of an emergency physician. A lot of people think it's very easy, but let me, as you all would agree, the mindset of an emergency physician needs to be significantly different from a physician or a surgeon belonging to any other specialty. So you need to have that mindset, and that comes from training and from working in the emergency department for many years. Very few people still in the country understand the department and the needs of the department. But the good thing is, a lot of you have worked really hard to showcase the department, and people are beginning to recognize the department. And COVID has actually propelled the department into the forefront. And I must congratulate every single emergency physician in the country for what they have done for the people of this country, because they were definitely the most frontline workers. If there are frontline workers, they were ahead of all the other frontline workers. And I must thank you from the depth of my heart for what every single emergency physician has done for the people of this country. The people of the country are indebted to you. And imagine a situation where you did not have the specialties still established in this country and COVID came in. It would have been disastrous, not just for the patients, even for the hospitals, because the emergency physicians were literally the gatekeepers for the hospitals. They were actually facing the patient who's coming in. And today I'm told a lot of patients who come in with other emergencies, non-COVID situations, are actually COVID positive. And they are actually being moved to the COVID positive side of the emergency room. So you are actually dealing with the unknown, and you've done a fantastic job. Please continue the job and keep your morale up. It's very easy to get frustrated. It's very easy to get fatigued, but the country needs you guys to work hard, and the country needs you to deliver what you've been delivering for the last 2 years. Then knowledge is power is what everybody says. And the common human mentality is, when you have power, you want to keep everything to yourself. So in that way, if you want the power of knowledge, keeping it to yourself doesn't give you the power of knowledge. The power of knowledge is truly leveraged only when you pass it on to your colleagues, your juniors, your students. And I think it's events like this which help you to pass on the power of the knowledge and experience that you've gained over the years. So I'm glad that you are, and I see a lot of seniors on the screen, and I'm glad that all of you got together and are passing it on to the juniors and building the next gen of emergency physicians for the country. And for the younger lot, learning is power. Every day is learning. And I'm sure 2 years ago when COVID came in, nobody knew what to do with it. Nobody knew anything about it. And from that day, every day has been a day of learning up to today. Even today, we learn new things every day. The protocols keep changing. I'm sure all of you remember when the hype of chloroquine was created, then the hype of remdesivir, then the hype of monoclonal antibodies. Today, it's no more useful for the current strain. So every day is a learning day for us. And as being at the front line, I think we need to keep ourselves abreast with the latest that is happening. And it becomes the responsibility of the seniors within the specialty to make sure that everybody across, irrespective of which institution they're working, irrespective of which sector they're working, it is very, very important that all the emergency physicians get together in terms of knowledge exchange, knowledge upgradation, skill exchange, and skill upgradation. So I'm very, very happy that this event is being held, and I congratulate the West Bengal chapter for hosting this event, and I look forward to the next gen of emergency physicians really making it happen for the country. So good luck and all the very best to each one of you, and congratulations to all the seniors for what you've been doing. Good luck.
Thank you. Thank you very much, sir, for your encouraging speech, sir. Now we will go for the virtual lamp lighting. So.
शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या कुन्देन्दु तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना. All the best.
Thank you. Thank you very much, sir.
You'll have to excuse me because it got delayed. I had another call. I have to join the other call right now. Thank you so much and good luck to all of you.
Thank you. Thank you very much, sir. Yes. Let's go to our next session. Now we have our welcome speech by Dr. Venkatesh, who is currently the president of Society for Emergency Medicine India. Well, we would like to thank him enough. No, can't thank him enough because he is already suffering from COVID, and still he is along with us in every way, supporting us to organizing and carry forward this event, Semicon 2022. So we'll start with his inaugural welcome speech.
Good morning to all, dear SEMI members of West Bengal State Chapter and all the SEMI board members. I'm very happy to be a part of this SEMI learning session, Semicon 2022. And I wish all the very best for SEMI West Bengal Chapter in conducting this wonderful conference. I look forward for an engaging and educative days ahead. I'm happy and pleased to see that we are all continuing our efforts as SEMI organization to keep ourselves updated while also taking necessary precaution to fight the ongoing pandemic. Hence this online conference. I eagerly look forward to get over these difficult times and meet everyone in person. Till then, let us all continue to contribute positively towards the fight against COVID. I thank SEMI West Bengal for giving me an opportunity to be part of this program. It is great pleasure for us to continue this program inaugurated by Chairman and Founder of SEMI, Dr. K. Hari Prasad, without whose hard work, support and encouragement we would not have been here today. I wish all the delegates and speakers a warm welcome on behalf of SEMI National Board and hope you all have a great fun while we learn during these days. Thank you very much.
Thank you, Dr. Venkatesh, for your encouraging speech, as always. May I like to call none other than everyone's favorite, Dr. Srinath Kumar, who is also the academic chair of SEMI. Well, he is not only the academic chair, he is always there whenever you require. And it's nice to have you, sir, with us. And over to you, sir.
Dear friends, all the SEMI board members, SEMI chair and executive chair, and all the past presidents of the Society for Emergency Medicine India and SEMI West Bengal chapter who is leading from the front. It's really nice to see you all. Since the morning, the lectures have been going on very well, and it is a very good time which we have been kept this, keeping in mind of all the residents. Semicon was the word created by Dr. Mahesh Joshi sir, who is here in 2014 when we met in the December. And he said, why don't you create something which gives the residents all the rapid revision? So in that way, we immediately created it. And then we started this Semicon, a rapid revision program for all the residents in emergency medicine in the month of February in 2015 at SRM SIMS Hospital under SRM University. Dr. Sai Surinder was the one who led this from the front. We thank Dr. Sai for initiating this in the first, and then year on year, it has seen how it goes upon. Every year, this has been happening in the month of February or January end, so that the residents who are going on, whatever the course may be, so it will be very useful for them. And as we all know, the Society for Emergency Medicine India has three parts. One is service, one is research, and the other one is academics. And being the academic council chair, it is my pleasure to welcome you all to this Semicon 2022 and listen to all your experts to create and take forward for your exams. So this particular rapid revision has been created kept in mind with all the topics which are there in the Tintinali and which has been spoken by all the teachers across the country, and few speakers are also been invited from internationally. So taking the inputs not only from the textbook, it is also important to look into the research object also and looking into the recent updates. As Dr. Hariprasad sir rightly mentioned, we have to be updated every day in and day out. Otherwise, we will be outdated. That is what we all keep saying. And always emergency physicians are in the front line, let it be COVID, non-COVID, or EMS front. Now we have also approached into the air ambulance also. So we are in the air, we are in the land, and both the places. So this gives an opportunity to all the residents who are pursuing their emergency medicine to take forward, look into forward, and be a wide range. And recently I also saw one of the advertisements for the cruise medicine saying that you will get a $10,000 per month. So that is a way how emergency medicine has progressed from the scratch, where we all know in 1999, it was started by Society for Emergency Medicine India, bringing an awareness. And that is how it has been progressed way forward. And we are all teachers with you, all residents, to handhold you, take you in the right direction. So congratulations for registering for this program and being part of this. Thank you, West Bengal chapter, for taking this forward. All the best. Jai Hind.
Thank you very much, sir. Thank you for your wonderful speech. Now may I like to call upon Dr. Tamorish Kole, sir. Sir, have a few words, sir. Dr. Tamorish Kole, he is the president of Asian Society for Emergency Medicine, and he was also the past president of Society for Emergency Medicine India. Over to you, sir.
Thank you, Larry and Srinath. We just heard Dr. Hariprasad sir, our guru, and as he rightly pointed out that we need to be updated because we are at the front line and things are changing so rapidly. And in that regards, I think this kind of virtual meeting used to happen before, nobody liked it. But due to COVID and now in a post-COVID world, we are now habituated virtually, and we can see the power of virtual meetings. We all are attending since morning, and most of the residents are attending, and a lot of faculties are attending in a very eased manner, which may not be possible physically all the time, attending conferences because somebody has to work back in emergency department. So virtual meetings should progress, virtual learning should progress, and updated knowledge in terms of not only Semicon, which is a yearly event, but also if something can be done as a monthly, grand round kind of fashion, it will be very helpful. And if that can be recorded and put it into cloud, it will be helpful as well. Nevertheless, this meeting is going on so far very nicely, and I myself is also in a learning mode and will be in learning mode for these 2 days. Thank you very much for organizing this.
Thank you very much, sir. Now I would like to call Dr. Sudip Chakraborty. He is our Vice President East Zone to have a few words.
Thank you, Dr. Lahiri. So I would like to share a few things on behalf of the organizing committee. When we initially thought about conducting the conference, we thought about doing it in a physical manner, but due to COVID, we had to switch it to virtual manner. And one thing is very important. Now we're in the middle of the peak of the third wave. And whenever we are calling any faculty to give a talk and all these things, they are saying they are suffering from COVID. And we told them that you are an EM physician. So EM always rocks. So you have COVID, that's not a problem. You should present. And they did it. It is an excellent and wonderful cooperation from all over India. Multiple faculties are now in active COVID phase and many are hospitalized, but still they are presenting. I would like to thank all the faculties, all the delegates and all the senior leadership for making it such a grand success. And right now we have almost 300 people online watching this event. And in future, we thought of organizing a big physical conference, that is your Eastern Zonal Emergency Medicine Conference, and just have a look at it. Thank you.
Thank you, everyone. And I welcome you for this future event, Eastern Zonal Emergency Medicine Conference, and hope to see you all there. And I'd like to declare lunch break. Thank you, all of you, for attending this conference. Thank you. Welcome again. I would like to invite Dr. Tamorish Kole to chair this session, post-lunch session. We'll be starting now, and we'll be starting with the first talk of Dr. Saujanya. She is treasurer of Central Society for Emergency Medicine India. Over to you, sir.
Thank you. Good afternoon, everyone. We have exciting sessions ahead. And I think post-lunch, it will be a little bit of struggle for some time, but everybody, given the fact that we are all virtually, we should be okay with it. And I will also request faculties to stick to time. The first talk in this session, which is on COVID and emergency, very, very important session, is from Dr. Saujanya. She's going to speak on lung infection in COVID. Over to you, Dr. Saujanya. Is she here?
I have sent my recording already. I'm just waiting for the recording to be played.
Okay. Larry, can you ask them?
Yes. We are going to play the recording.
A very good afternoon to one and all, and welcome to the knowledge extravaganza of Semicon 2022. I wish all the organizing team of Semicon a grand success of this event. I am Dr. Saujanya. I am a consultant and head at Continental Hospitals. I am the National Treasurer for the Semi-National Board and Controller of Examinations from Academic Council of Semi. Today, I will be going to speak about lung infection in COVID. We have been seeing that last 2 years has been a tremendous stress for all healthcare workers dealing with this pandemic. And day by day, the cases have been increasing across the world and across the country with a lot of new variants and all. And these are the numbers which I just wanted to highlight before I present my talk on lung infections. These are the COVID numbers of Jan 2020 worldwide numbers. And this is the situation in India, where we are reaching around 2 lakh plus cases a day now with the third wave in progress. So we all know that COVID is declared as a pandemic on 11th March 2020, and the main symptoms are cough, fever, pneumonia, or shortness of breath, and it spreads from respiratory droplets. As we know that it is affecting the lungs more, this is because of the affiliation to the ACE receptors of the lung and intestines, where the coronavirus enters the cells and cause viral replication and causes the damage either by antigen presentation or cellular immunity or humoral immunity. So this is how the lungs get affected due to the ACE receptors get attached to the spike proteins of the COVID and gets involved into the cell and replicates inside the nucleus of the cell, the respiratory cells. So it causes a greater potential for innate immunity of the system. Cross reactivity between immune responses happen, and reduced immunity and functionality of ACE2 inhibitors are seen. So basically, coronavirus is known to affect the respiratory epithelial cells. So the spectrum of lung involvement in COVID ranges from a pneumonia, acute respiratory failure, acute respiratory distress syndrome, or there can be blood clots inside the vessels of the pulmonary vessels, or there can be a sepsis or secondary infections. Having said that, 80% of the cases of COVID are having mild symptoms, 14% may have pneumonia, 5% develop respiratory failure and sepsis, and 2% of the cases can be fatal, either cause mortality or morbidity in terms of long COVID syndrome. A spike in pneumonia cases was the first sign of the new coronavirus seen in China in 2019. What happens in pneumonia? Air sacs become filled with fluid, pus, and cell debris, limiting their ability to take in oxygen and causing shortness of breath, cough, and other symptoms of respiratory origin. So pneumonia of COVID tends to hold both the lungs, predominantly basal, peripheral, and subpleural regions are affected. The classical feature of COVID pneumonia is dissociation between severity of hypoxemia and relatively preserved respiratory mechanics. So patient may look very normal, but they will be having severe hypoxemia or mild tachypnea, which is disproportionate to the amount of hypoxemia seen on ABGs, is the classic picture we have seen during the second wave of COVID with the Delta variant. So the features what we see is hypoxemic, hypocapnemic respiratory failure. Both carbon dioxide and oxygen levels decrease in COVID pneumonia patients. So this is how the brief of COVID pneumonia, where it ranges from cytokine-driven hyperinflammation, lymphopenia can be there. There can be lymphoid organ failure and disruption of ACE2 receptor epithelium of the respiratory epithelial cells. That directly causes inflammatory response, dysfunctional type 1 responses, myeloid hyperinflammation. These are all the symptoms what we see either in the lungs or the blood that causes the cytokine storm or ground glass opacities on the lung, leading to pneumonia and respiratory failure. So this is again microvascular and macrovascular injury related to SARS-CoV-2, where there can be microthrombi that affects the blood vessels and leads to dysfunction of the endothelial cells as well. Coming to respiratory origin, there are two types of phenotypes that has been noticed. One is a non-ARDS type of picture, where there can be severe hypoxemia, there will be high respiratory compliance, high tidal volumes, and lung recruitability will be there, which is preserved with small efforts. And the second one is there is a severe hypoxemia in this, but the compliance is decreased in these cases. The lung recruitability is also decreased. There can be increased in lung weight and edema because of the accumulation of air sacs, either with the debris or lymphocytes, and edema will be there. So why do we need to know these types? Different phenotypes need different strategies for management of these cases. So these are the stages of CT scan picture you will see depending upon the early stage. In early stage, you may see single or multiple scattered patchy ground glass opacities, predominantly disrupted in the peripheral and subpleural areas of the lung. A crazy paving pattern secondary to intralobular and interlobular septal thickening can be seen in the early stage. As the disease is advancing, there can be increased extent and distant density of bilateral lung parenchymal opacities. There are both areas of ground glass opacification and areas of consolidation in both the lungs, which coexist and may with varying sizes and presence of air bronchogram in between. Then in the severe disease, there can be a diffuse consolidation of the lung parenchyma with uneven density, air bronchi and bronchial dilatation, which may be present as white out lung or on a corresponding chest X-ray. Then dissipation stage, areas of ground glass opacities and consolidation near completely gets resolved, leaving some residual curvilinear areas of density. So this is the spectrum of COVID lung infection you will see on CT scans. Then the common CT manifestations are, there can be ground glass opacities, airspace consolidation, crazy paving pattern, interlobular septal thickening can be there, and reticular patterns are the common things what we see in COVID pneumonias. The uncommon presentations can be bronchial wall thickenings, bronchiectasis, pleural thickening, pleural effusion, air bronchograms, reversed halo signs, lymphadenopathy, pericardial effusion, spiderweb designs, fibrous stripes in the lung parenchyma, or there can be a pneumothorax or pneumomediastinum also was seen in few of the cases. So how do we manage these lung infections in COVID? First and foremost is a prone positioning. Prone positioning, the advantages are it recruits the lung. Aeration of the degassed ventral lung regions happen because of prone positioning, and it diverts the blood flow from the gasless regions to the aerated regions so that the gaseous diffusion occurs very good, and improve the secretion clearance and reduction of transpulmonary force disparities. So it has a robust advantage in high lung compliance in the early phase of the disease. The next part is, if there is a COVID-19 pneumonia, the management algorithm is see if the patient is hypoxic or non-hypercapnic with saturations less than 90. Try with 6 liters of oxygen. The goal is to maintain saturation between 92 to 96%. Then try with NRB mask to achieve this, and FiO2 between 28 to 35%. You can increase the NRB mask with oxygen supply to 12 liters with FiO2 35%. If the patient is still having respiratory rate more than 30, with acute respiratory failure with use of accessory muscles is there, or PaO2 less than 65 and saturation less than 92%. If any of these is there, call ICU team for CPAP management. If despite of CPAP, if the patient continues to have respiratory rate more than 30, then you have to think of intubating the patient. Then what are the advantages of PEEP in COVID-19 patients? It maintains a set pressure throughout the respiratory cycle, both in inspiration and expiration. It constantly opens the airways and keep them inflated during expiration also. It reduces the atelectasis and improves ventilation perfusion matching and improves oxygenation. So this is the reason why most of the cases require CPAP in these patients. So this is a critical care management if the patient is on NIV, restrictive fluid resuscitation, not to put a lot of fluid and cause edema. Awake prone positioning with which helps in opening of the alveoli. Then if the condition is not improving, then we think of mechanical ventilation with lower tidal volumes, lower inspiratory pressures, prone position for more than 16 hours, and conservative fluid management, higher PEEP. If not responding, we have to consider ECMO in these patients. So this is the stepwise approach for these patients. In first, we'll try with nasal cannula, then non-rebreathing mask. Then in the step 3, we have to think of a CPAP with oxygen machine to lungs. Then step 4 is invasive mechanical ventilation. If that also fails, is ECMO. So this is how the pattern of your lung infection management in COVID happens. I will be open for any questions, and saluting all the healthcare workers who have been struggling hard in this pandemic. And thank you to the Semicon team for giving me this opportunity.
I think, thank you, Sajana. We will keep the questions at the end. We pass on to the next speaker. The next speaker is Dr. Imran Suban, and he is going to speak on acute chest pain, golden hour, and pandemic. Is he present, or we are going to play his video recording?
I have given my video, Tamorish.
Okay, okay. Like, can we play the video?
Good afternoon, everyone. It's very nice to be at Semicon 2022 this year again, virtually. So let me start my lecture on acute chest pain during a pandemic. So my name is Dr. Imran Suban, and I am a consultant and head of emergency medicine department at Apollo Hospitals, Hyderabad, India. I'm also the past president of the Society for Emergency Medicine India. As we take this session through all the clinical issues which are there with COVID, I will talk about chest pain during the pandemic. So before COVID-19, we can look back at how we were all handling chest pain before. So when you look at various gold standards which exist related to clinical care, related to emergency department protocols, department guidelines, protocols related to the specialist care, the laboratory timelines, then cath lab timelines. Only the developed emergency departments have such systems. There are always weaknesses in handling chest pain, simply because the patient goes through a cascade of different departments in order to get treated for chest pain. It can be MI, it can be unstable angina, it can be any other condition. But because there are multiple people involved, the systems are not perfect, were not perfect before itself. And the COVID has added another layer of problems in handling these chest pain patients. So what has happened with the pandemic, with the COVID? In our emergency rooms, we have created multiple checkpoints and multiple delays which are new in the emergency room for any chest pain patient or someone with a cardiac problem. We were overloaded in the triage as well as in our emergency rooms during the first and second waves, and it's also happening now in the third wave. So these overloads will create delays for acute patients. Our entry points are clogged, our triage is overloaded, there are too many patients, there are queues which are present, stretchers are unavailable. In such conditions, the simple task of a patient entering into the emergency itself is delayed. So this is a problem. Then we have created mandatory COVID tests before admission to ER. There are many hospitals which have done that. There are mandatory CT scan which is done before any kind of assessment or admission. We have made it mandatory for RT-PCR, which takes many hours tests to come before we plan for any cath lab or coronary intervention. There is so much of paperwork delays which are involved now, taking IDs, taking Aadhaar card, various requirements to fill forms before anybody is treated. Specialists are avoiding to come to the emergency room because they themselves are scared about their health. The other people involved in chest pain pathway do not assist the way they used to do before the COVID. And telephone directed thrombolysis is now preferred over PTCA, even though patients are eligible for PTCA procedures. Patients are being sent away because of obviously ICU beds are unavailable or ward or some other cardiology ward beds are unavailable. So all these have created delays and problems for chest pain patients. This is a new guideline which has come out just last year by the DGHS. This is the guidelines on post-COVID sequelae. This says that chest pain occurs in 20% of post-COVID patients. Remember that chest pain will also occur in acute COVID infections also. Myocardial injury occurs directly because of virus, the COVID-19 virus. It can occur because of hypoxia, which is happening, microvascular dysfunction, the thrombosis which happens, the cytokine storm which happens. So plaques get disrupted with cytokine storm. So all these relate to possible angina as well as various acute coronary events. Myocardial fibrosis, which happens after several weeks and months, left ventricular failure, which is persistent, arrhythmias, which are persistent, again lead to various chest pain happening in these patients. So you will have to do a lot of investigations in a thorough manner in order to pick up these patients and make sure that they are taken care of. So ECGs, chest X-rays, cardiac enzymes, echocardiography, cardiac CT, cardiac MRI, all these will be required in order to filter these patients and diagnose correctly. There is a study which was released just this month that patients present late to the emergency room. This happened, we saw it happen in the first wave and second wave. The patients who had problems, non-COVID problems, were concerned whether they would be allowed into the hospital and whether it is safe for them to come to the hospital or not. They were more concerned that they may be refused treatment in various hospitals. So this was consistently seen in many different hospitals. We have seen it here in India also. And the other problem was that patients were avoiding hospitals due to fear of getting COVID. Entire families were avoiding coming to the hospital for assessment. Critical patients were avoiding and ignoring their problems because they were scared of coming to hospitals, thinking that they will contract COVID infection. So all these are problems related to chest pain patients. We had seen depression happen. This long lockdown, which had never happened before, had caused so much of depression in patients who were isolated, especially those who didn't have family support, those who were completely locked down, isolated, and they had other problems, financial issues, social issues, which are causing depression. Depression was leading to a higher risk of cardiovascular disease, higher risk of developing acute problems, including chest pain, and they were coming more. Depressed patients were visiting emergency departments more frequently, and this was not only overloading the emergency room, it was also causing difficulties for the staff to identify such patients correctly, because normally if there is a depressed patient, you will attribute it to depression and anxiety, whatever symptoms they are experiencing, but you have to assume that they may be having a real acute coronary syndrome or acute MI and filter them. So this is one of the other unique problems which happened during the pandemic. I would also like to add this particular thing. It is not just related to pandemic, it is also happens in general, but it is more amplified during the pandemic. There is gender bias in handling acute coronary syndrome patients. Women receive less attention. The multiple studies have shown this. Risk is underestimated in women patients who experience chest pain or any kind of ischemic symptoms, both by patients themselves as well as the emergency physicians who see them. Female patients are known to present late to the emergency room because they tend to not take it seriously, their chest pain and other serious symptoms which happen. They are misdiagnosed or diagnosed late. Their ECGs are not taken seriously. They are marked as normal, even though it may be suspicious. So women are more likely to be diagnosed with a non-ischemic problem. There are many studies which have shown this. So again, we have to be very, very careful when chest pain patients come in female patients and take them seriously and make sure there is no gender bias in their triaging, in their assessment, in their treatment and resuscitation. We have also seen COVID-19 related vaccine, COVID-19 vaccine related complications. It's a known problem, very, very small risk of thrombotic events. It can be cerebral venous sinus thrombosis. It can be mesenteric thrombosis, coronary thrombosis, which happens within 2 weeks of vaccination. This has been given a term called vaccine-associated immune thrombotic thrombocytopenia. So this is a known problem where post-vaccination within 2 weeks, patients can present with chest pain. Vaccine also causes myocarditis and pericarditis in patients which may present as chest pain. So these patients may have chest pain, shortness of breath. There may be ST elevations on the ECG. There may be elevated troponins because of the myocardial injury. But when you look at it clinically, their echo will be normal. They'll not have other signs and symptoms which will indicate that it is a acute myocardial infarction. So you'll have to see this very, very carefully. Again, issue related to the pandemic. So you must remember that reperfusion of a myocardial infarct or thrombolysis in a pulmonary embolism, which will present as chest pain, should occur within the first 2 to 3 hours of presentation into the emergency room. So end of the day, we have to make sure that this happens. So how do we do that? I'll not go into the details, but I will tell you that the acute chest pain protocols or pathway, whatever you have to make sure it is strengthened well, so that patients, when they are picked up in the ambulance, the pre-hospital care assessment, the protocol which people follow, the paramedics, what they do, that must be perfected. And when the handoff occurs to the triage and then to the emergency care room, again, the protocols, everything must be fine-tuned to pick up these patients quickly and take care of them in a time-bound manner. That's what I would tell. So if a patient comes with chest pain, within the first 5 minutes, you should complete the assessment. Within the first 10 minutes, the ECG should be completed. Within the first 15 to 20 minutes, you should try to get the cardiologist to see and take a diagnosis, so that within the first 30 minutes, your thrombolysis or any coronary intervention can be initiated immediately at that point in time. So the entire pathway must be improved and it must be perfected in order to take care of these chest pain patients. So just remember that differentials of chest pain, even during a corona pandemic, can be anything. Acute coronary syndromes, unstable angina, acute MI, I already spoke to you about. Acute pulmonary embolism, you have to think, because thrombotic events do happen in COVID. COVID-19 pneumonia itself can cause chest pain. Fungal pneumonia, pulmonary edema, pneumothorax can cause chest pain. Acute pericarditis, myocarditis due to the coronavirus itself can cause chest pain. And of course, other things like aortic dissection also are there to cause chest pain. So my take-home points will be that chest pain can occur during acute acute COVID-19 infection, as well as during the post-COVID recovery stage, and also during post-vaccination. So just remember, these patients can come. Do not delay emergency interventions for the COVID RT-PCR test or CT scan. Avoid gender bias during your assessment and treatment of chest pain. Diagnose and treat quickly all these patients and take care of them. Encourage people with chest pain to reach hospital early, and ensure that you have communicated and reassured all the public and community about our hospital protocols during pandemic, and encourage them to come and visit whenever there is chest pain. So these are my talk. I hope I was useful in helping you learn about chest pain during pandemic. So thank you very much.
Thank you, Imran. I think Imran has requested, our permission to leave. But if you have one or two questions, we can ask Imran right now. Okay, if there is no question, it was a beautiful presentation and a very practical one during COVID period. And I quickly pass on to Kiran. Dr. Kiran Kumar Verma, who is based in Hyderabad, and he's going to speak on pandemic and pregnancy. Kiran, please.
Yeah. Thank you, sir. Sir, am I audible, sir?
You are audible. You can share your screen if you want.
Yes, sir. Yes. Yeah, good afternoon all. Myself, Dr. Kiran Verma, working as head of the emergency department, Yashoda Hospital, Malakpet. So first of all, I will take this as an opportunity to welcome you all for this academic phase Semicon 2022 Connect by West Bengal. So thank you, Semicon 2022 team. So topic for today is pandemic and pregnancy. As we know that, so we are going through the pandemic phase. So because of this, many of the sectors have been affected. Still we are struggling and still we are fighting against pandemic situations. So it comes to our topic proper, pregnancy and pandemic. First of all, I will talk something about what are the effects of COVID on pregnancy. So pregnant women per se, they are not at the increased risk group, but because of underlying conditions like heart disease, diabetes, hypertension, asthma, immunocompromised condition like HIV, SLE. So these are the things what made pregnant lady at risk. And when patient presented to our hospital with a history, with the signs or symptoms or suspicious of COVID, so we need to triage at our hospital on arrival. So after triaging, then we can decide whether patient can be discharged home or patient can be admitted. So this is the criteria for the patients whom they discharge home safely. The patients who have stable vital signs like heart rate less than 100, respiratory rate between 50 to 20, temperature less than 38 degrees, saturation 94 at room air. Then who doesn't require oxygen requirement? Who doesn't require oxygen? No SOB, suitable for phone call follow-up by public authorities, no acute obstacle concerns, no other concerned comorbidities. These are the patients whom we can send safely home. Then the thing, what are the indications required for admissions? The patients having shortness of breath, cough with blood, chest pain, and signs and symptoms of dehydration, decreased level of consciousness, oxygen saturation less than 94, chest X-ray consistent with pneumonia. Yes, now patient required for admission. Then what are the investigations to be done? So is there any difference between pregnant and non-pregnant patients? Absolutely no separate investigation required for the pregnant patients alone. Then what are the admissions required? At the baseline investigations like COVID nasopharyngeal swab, routine blood work like alkaloids, creatinine, lactates, prognostic blood work, CBC, PT, prothrombin, CRP, LDH, and then lactates, BNP, troponin. If there is a concern for cardiac involvement, then urine and the routine tests, 2D echo. If patient is requiring admissions to ICU and patient is having underlying cardiac conditions. So if any things are abnormal, then you need to have consultation with infectious disease consultant or OB medicines. Then patient being admitted, then how to follow up with the patients. So for admission, we need to have close monitoring of the patient. It requires proper surveillance. So when we are surveilling patient, we need to think about warning signs. If there are warning signs, we should be very careful about all these things. Yes, now patient is admitted. How frequently have to check the vitals with oxygen? The patients who doesn't require oxygen, the vitals should be checked with oxygen every 4th hourly. When patient is on oxygen, then we have to check the vitals hourly with oxygen. The doctor, staff and patient ratio should be 1:1. Then the patient under surveillance, then any of the time patient may develop warning signs. So there is a score called maternal early obstacle warning score. In that, there are few parameters like respiratory rate, oxygen saturation, temperature, systolic blood pressure, diastolic blood pressure, heart rate, neurological response. So in that, we categorize 2 parts. One is yellow alert and red alert. Yellow alert means when respiratory rate is between 21 to 30, then temperature 35 to 36 or 37.5 to 38 degrees centigrade, then systolic blood pressure 150 to 180 or 90 to 100. When diastolic pressure 90 to 100, and heart rate is 100 to 120 or 40 to 50 beats per minute. Neurological response, yes, she will be responsible response to the voice only. That is yellow alert. Then when it comes to red alert, when respiratory rate less than 30 or more than breaths per minute. Oxygen saturation less than 95, temperature is less than 35 or 38. Then systolic blood pressure more than 180 or less than 90. Diastolic blood pressure more than 100. Heart rate is more than 120 or 40 less than 40 beats per minute. Then patient would be unresponsive or maybe response to the pain. So if 2 yellow signs are present, then we have to is like two yellow alerts. You have to involve the infectious disease, general medicine personnel, and even one red alert also is indicated to involve the general medicine. Then patient, what are the antenatal management? So when it comes to routine management of the COVID, it remains same for even for pregnant patients. But there are two concerns, whether we can use thromboprophylaxis or not. Yes, if it is for mild cases, there is no requirement of thromboprophylaxis. But in case of moderate to severe patient, yes, we required to give thromboprophylaxis because the pregnancy itself is a hypercoagulable state. That's why in moderate to severe cases, we can consider giving thromboprophylaxis. Then another concern is uses of corticosteroids. Especially it is useful, especially in pregnancy patients, it is useful for the prenatal, for the benefit of the fetus only, not for the COVID patients alone. But still, there are many confusions and contradictions regarding uses of steroids in pregnancy patients. Then now patient is been admitted and surveillance treated with regular COVID protocols. Then what is the recovery algorithm? See, we can divide into three parts. First one is COVID diagnosis confirmed, but stable patients staying treated as an outpatient department. So they require 14 days of isolation. Then once symptoms are disappear and symptoms improve, we can think it as a COVID recovery. Then again, we don't need to retest the patient. That is one condition. Then second one, COVID diagnosis confirmed and admitted for the COVID support care. Then patient should be there in the hospital for at least 14 days or till he improves the symptoms. In such scenarios also, we have to follow with the patients. Or certain patients who doesn't stay for more than 14 days when they require hospital administration, still you can send for the home isolation, then you can follow with the patients. Once they improve the symptoms, they are freed of the symptoms, we can call it as a COVID recovery patients. But regarding the self-isolation and isolation, guidelines have been changing day to day, and it is changing from first phase of the COVID and second phase of the COVID, and even now. So it is up to us. So what about the delivery concentrations with COVID-19 patients? COVID-19 infection is not a direct indication for delivery. Decision to delivery individuals based on the maternal and fetal status. Then what are the key points for fever and labor? Yes, patient is in labor, patient is having fever. What to be done in case of emergency? Yes, when temperature is more than 36 centigrade, then we have to give the 500 cc of fluid bolus for a period of 30 minutes. So during this time, don't try to give the acetaminophen. Then repeat the check the temperature after 30 minutes. Till if it is more than 37.8, then now patient is now like a patient under investigations. It might be a COVID or something else. Then we have to work up for the chorioamnionitis. Then we have to take up blood cultures. Then you have to infuse. You have to give the acetaminophen. Then administer the broad spectrum antibiotics. As patient since the patient is in labor, she might die at any point of time. If there is a birth, then neonate also like PUA means for patient under investigations. We need to have nasopharyngeal swab. So these are the intrapartum management key points. So regardless of disease severity, always recommendation is hospital birth. So hourly fluid status to be checked to avoid the fluid overload because it affects the ventilation and work of breathing. No hydrotherapy in labor and birth because it carries the risk of viral infection. Encourage epidural anesthesia. It will minimize the general anesthesia, risk of general anesthesia. No evidence of virus in vaginal secretion and amniotic fluid. Then no use of nitrous oxide for pain measurement because it is a aerosolization. No indication of cesarean section unless to improve the maternal registration efforts. Emergency cesarean section for obstetric indication, not for the COVID diagnosis. So when baby born for the COVID patient mom or patient under investigation mom, yes, we have to continue the same thing for non-COVID baby only because no evidence of virus in the cord blood when fetus exposed to the cord blood. So limited evidence of vertical transmission. So it all supports delayed cord clamping. Then we have to encourage the breastfeeding, support skin to skin and any direct baby care. But patient mother has to wear mask. Then with a few points about what are the effects of COVID on fetus. Till now, no data suggesting increased risk of miscarriages, early abortions in the pregnancy, and there is no effects of teratogenicity. Moreover, it is not a indications for MTP. Then no evidence as of now for vertical transmission. Then what about the postpartum thrombolysis? As I told you earlier, it is for if it is mild cases, not required. If it is for moderate to severe cases, yes, it may require. But it is on a case-to-case basis. This is one of the algorithm. So finally, these are the take-home points like a COVID-19 pregnancy key points. So pregnant patients affected with COVID-19 make full recovery. Then 15 to 20% develop moderate to severe illness. 2 case reports of maternal death and the social media and the other parts. No data to suggest increased risk of teratogenicity. Limited evidence suggests that vertical transmission is possible. Limited evidence suggests that no increase of spontaneous preterm birth. Several cases of preterm birth indicated for maternal health concern or fetal health concerns. No data suggests that increased risk of intrauterine fetal death. Based on data from SARS and MERS or other respiratory infection pregnancy, minimal effect on long-term fetal growth and well-being. So thank you, Ananda. Thank you, Semicon. Thank you, Semi, for giving me this opportunity. Hand over to Tamorish. Thank you, Tamorish.
Thank you, Kiran. You are right on time. In fact, you have saved some time. So thank you for that. We'll take questions later on. We move on to Dr. Raja Durai. I think Dr. Raja Durai's presentation will be presented. He has recorded already. So Dr. Raja Durai is going to speak on anticoagulation in COVID, another very, very important topic.
I take this opportunity to express my immense gratitude and heartfelt thanks to the organizing team and scientific team of Semicon 2022. Thanks to the co-speakers, listeners of this gathering, and respects to the moderator for mentoring and moderating this session. I once again truly delighted to be part of this excellent academic extravaganza. Also, I devote this time to request our fellow colleagues to take all necessary precaution amidst the present third wave, and take this time to appreciate all the young guns who are present here, who are all the real time present warriors. My name is Dr. Raj Durai, Head of the Department, Emergency and Critical Care at Apollo KH Hospital, Male Visharam, and I am a National Vice President, South for Society for Emergency Medicine, India. Thank you. The topic for today is I'm going to talk about anticoagulation in COVID-19. As usual, I'll try to keep this session very crisp and try to convey a few points which are useful for our clinical practice. Next slide. Is this topic important? Yes. You guys have to tell me, is this topic important? And I think the answer should be definitely yes. Because considering the fact, the incidence of thromboembolism in our previous COVID-19 waves, it will not be an exaggeration if I say that anticoagulation gained a lot of scientific evidence as against the armamentarium of drugs which got introduced and entered during the first and second waves of COVID-19. So the one drug which is going to have a lot of scientific backup and evidence is anticoagulation in COVID-19 patients. Next slide. So what are the objectives of my presentation? The long objectives would be, like I would like to talk a bit about coagulation. I disclaim that I'm going to talk about coagulation cascade. I'm not going to go in detail about the physiology, the incidence of thromboembolism in COVID-19, the indication of anticoagulation in various settings. I'm going to bring in a lot of journals and clinical articles about anticoagulation in their own settings. For example, hematology, NIH, and Indian scenarios, to compare and contrast the indications for anticoagulation and the duration of treatment of anticoagulation in COVID-19 patients. Yes, the short objective would be to save lives as usual. Next slide. Sorry about the technical glitch where I'm talking in one device and recording in another device for you all to view my presentation. So this slide is about the references that I have taken from various reputed journals and articles to prepare this presentation. Also, most of the slide will have the reference material in the end of the content. Right, next slide. So what is coagulation? Coagulation, you all know it's a dynamic process. The normal coagulation is a balance between the procoagulant pathway that is responsible for the clot formation and the mechanism that inhibits the same beyond the injurious site. As you can understand from the picture over there, there is a balance between the clotting and the bleeding. If the balance is lost, bleeding is provoked. Next slide. So American Society of, it is a coagulation cascade. We have got 3 pathways, the intrinsic, extrinsic, and the common pathway. Next slide. So this slide is what I was talking about. So the intrinsic pathway, the common pathway, and the extrinsic pathway, all leading on to, ultimately leading on to fibrin and the stable fibrin clot. Whenever there is a disturbance in the intrinsic pathway or the pathways which I have mentioned, there's going to be disturbance in the coagulation cascade leading on to coagulation abnormalities. Next slide. So this is about the overall prevalence of VTE as per the Society of Hematology. So which says about 9.5% without screening and 40% with ultrasound screening. And it is higher in intensive care unit, which is about 18.7% without screening and 45% with screening. Yeah, 2 things we can understand from this study. One is the prevalence of VTE in COVID-19 patients, which is high in both the group of patients who are staying in the ward, that is moderate, and who is requiring ICU care. That is one point. Another thing is the importance of ultrasound in screening these patients to find out whether they have thromboembolism or not. So this is what we should understand from this slide. This is about the pathogenesis and the mechanism of forming thrombosis during COVID-19 for COVID-19 patients. Whenever there is a SARS-CoV virus interaction with an endothelial cells, inflammatory process starts in the alveoli, resulting in thrombotic complications. So below is, again, as you can see, a lot of drugs have come into the market, or the existing drugs have come again during COVID-19 to stop this thrombotic complications for COVID patients. But only few are lasting even now. The importance have not been lost, which includes heparin and few more drugs, which I'll be telling in the slides which are coming up. So we need to understand the incidence of thrombosis is more in COVID-19 patients, and the importance of anticoagulation because of the prevalence of thrombosis in these patients. Next slide. So how do we evaluate these patients? Apart from the routine testing, we need to do a platelet count and prothrombin time, activated prothromboplastin time, fibrinogen, and D-dimer. Why I have put this slide is we cannot deny anticoagulation for a patient who requires clinical anticoagulation. Otherwise, when we see a platelet which is slightly on the lower side, we should never stop anticoagulation for those patients. Also, when the patient doesn't have fit into the anticoagulation indication, but if the D-dimer is high, again, that is not the only indication for you to start anticoagulation. So we need to take a patient as a whole. We need to consider the clinical parameters, what disease they are having, whether they are having an asymptomatic, mild, moderate disease, the various biochemical markers and other disease and the co-morbs, the present co-morbs, All those things we need to take into consideration before we start anticoagulation for these patients. Next slide. So next slide will tell you the importance, or how the D-dimer is being elevated. So it is, as I told, it is not only the during SARS-CoV infection the D-dimer increases, or even when during the thromboembolism the D-dimer increases. When there is morbid obesity, localized pulmonary thrombosis, immobilization for a prolonged period, who comes to the hospital with the COVID positive status, older elderly patients, patients with comorbs, and all these patients will naturally have elevated sepsis patient will naturally have elevated D-dimers. And as I told, do not take one parameter for starting anticoagulation. We need to take all the parameters into consideration, including the clinical presentation, the sonography of this patient, and all these biochemical parameters for you to start anticoagulation, so that failure doesn't happen, number one, and the complication because of anticoagulation doesn't happen. So these are all the endpoints or the goals before you start anticoagulation for patients with COVID-19. Next slide. And this is about the anticoagulation in COVID-19 patients in short. So we need to note whether the patient has got documented or strongly suspected thromboembolism. If yes, what is that? Whether it is an acute myocardial infarction or an acute brain attack or an ischemic stroke, massive PE or a dim levity, which is evidenced by sonography and other radiological investigation. If yes, start your full dose anticoagulation and follow your institutional protocols, which includes thrombolytics.
10 minutes time.
No, you need to consider only full dose anticoagulation and start other institutional protocols. If the patient does not fit into this criteria, you need to look into the severity of the patient, whether my disease is mild, moderate, and severe. Based on that, you need to start with molecular weight heparin and continue heparin based on their clinical presentation and their risk factors for thromboembolism. Next slide. So as I was telling, do not start anticoagulation for all patients and never withhold anticoagulation if the clinical condition warrants to. And when there is a low platelets and when there is slightly elevated, or when the D-dimer is normal in COVID patients, but other risk factors are high for thromboembolism for particular patient, you need to consider anticoagulation for those patients. So this is task force guidelines where patients have been classified based on their symptoms and their saturation into mild disease, moderate disease, and severe disease, and admission into relevant areas, and anticoagulation based on their clinical and other laboratory and radiological parameters. Next slide. So what is full dose anticoagulation? Should be based on a comprehensive clinical assessment, and as I told, it should not be on isolated changes in laboratory values. So low molecular weight in heparin, which is again a preferred anticoagulation method, using enoxaparin 1 milligram per kg every 12 hours. An unfractionated heparin can be used based on laboratory testing, and whenever your institution is having a facility to have anti-factor XA, it should be monitored to guide dosing and adjusted according to the nomogram. Next slide. So in the next few slides are going to be on the various the journals or published articles, which is going to tell we are not exactly going to go through all the points which has been excuse me described in the presentation, described in the article, but we are going to take important points from each of the articles mentioned over there. For example, this one, so which is given in the American Society of Hematology 2021 guidelines, the VTE prophylaxis in non-ICU hospitalized COVID-19 patients. The take-home messages are low molecular weight heparin is a preferred agent, and intermediate dose low molecular weight heparin may be considered. When a patient is going or clinically going towards a failure in therapy, you can consider an intermediate dose enhancement of low molecular weight heparin as appropriate. And you can start VTE prophylaxis based on the extremes of body weight, severe thrombocytopenia, or deteriorating renal function, where we need to slightly modify and never stop your VTE prophylaxis using heparin. This should be the take-home message from this presentation, from this article. Next slide. VTE prophylaxis in sick ICU hospitalized COVID patients. So patients with obesity should be considered for a 50% increase in the dose of prophylaxis. And another important point from this study is you need to consider multimodal thromboprophylaxis with mechanical methods too. For example, intermittent pneumonic compression devices also can be considered along with heparin as appropriate for these sick ICU patients. Next slide. So what is the duration of VTE prophylaxis for hospitalized COVID-19 patients? So the approximate duration of post-discharge thromboprophylaxis can be somewhere between 14 days and up to 30 days also, but we need to have a constant monitoring of these patients. The extended post-discharge thromboprophylaxis can be considered for all hospitalized patients with COVID-19 who meets VTE high-risk criteria. So it can be either low molecular weight heparin or oral anticoagulation. Next slide, please. So these are all some of the indication for anticoagulations for the patients undergoing ECMO. Wherever there is a documented or strongly suspected VTE, and whenever we notice clotting of the vascular access device despite anticoagulation, and clotting in extracorporeal circuits, confirmation of DVT using ultrasonography, and transthoracic echo or point of care ultrasound demonstrates clot in the transit in the main pulmonary artery, you need to consider anticoagulation for patients even when they are undergoing ECMO. Next slide, please. So these are all NIH COVID-19 treatment guidelines. The panel recommends using therapeutic dose heparin for patients who have an D-dimer above the upper limit of normal for hospitalized non-pregnant adults who require low flow oxygen and are not receiving intensive care unit of level of care. Next slide. So for hospitalized non-pregnant adults who are receiving intensive care unit level of care, including patients who are receiving high flow oxygen, the panel recommends using prophylactic dose heparin as VTE prophylaxis unless there is a contraindication. The panel also recommends against the use of intermediate dose and a therapeutic dose anticoagulation for VTE prophylaxis, except in the clinical trials. Next slide, please. For hospitalized pregnant patients, the panel recommends using prophylactic dose anticoagulation for pregnant patients hospitalized for manifestation of COVID-19 unless otherwise contraindicated. Because pregnant patients are not included in most clinical trials and there is currently insufficient evidence to recommend either for or against therapeutic anticoagulation for pregnant patients with COVID-19 in the absence of known VTE. Next slide. So these are all some of the evidences which have arisen after the first two waves, or during the end of the second wave. Thromboprophylaxis does not improve outcomes in outpatients with COVID-19, which has been established in the effect of antithrombotic therapy on clinical outcomes in patients with clinically stable symptomatic COVID-19 patients in JAMA. Next slide, please. So definitely there is no role for aspirin in patients with COVID-19, which is from the recovery trial with a significant number of patients enrolled for the study. Next slide. So in Nischal trial, about 320 individuals hospitalized with COVID-19 and deemed high risk for venous thromboembolism were randomly assigned to receive post-discharge rivaroxaban or no anticoagulation after discharge. Most clinicians are unlikely to provide post-discharge thromboprophylaxis until more data become available. So when a clear indication or the risk factors, unless there is a risk factors or clear indication exists for discharge or anticoagulation post-discharge, never need to prescribe or no need to prescribe is what this study has been mentioning to us. Next slide. So this is called as the treatment failure when there is sudden deterioration in respiratory status, unexplained respiratory failure, not coinciding with the ARDS and physical findings consistent with thrombosis. We think that is a treatment failure. And how do we manage treatment failure? As I mentioned, next slide. As I mentioned, you need to consider, next slide, please. you need to consider ongoing clotting despite therapeutic anticoagulation, and evaluate whether it is heparin-induced thrombocytopenia, and check anti-factor XA if your institution is having that facility to do it, and think of heparin resistance, and consider other multimodal ways of anticoagulation for these patients. You need to find out the cause of failure. If you could find out the cause of failure, and go for multimodal other modes of anticoagulation when the treatment failure, when the patient is going for treatment failure. Next slide. Right, coming to the last slide of our presentation. So these are all only the few points we need to take home when we consider anticoagulation in COVID-19 patient. We need to clearly know the indication why we need to start, right? And VTE should be multimodal approach and diagnosis. Titrate as and when it is required, and stop when it is not appropriate. Thank you very much for the kind opportunity. I once again thank Semicon, the organizing team, and the scientific committee for giving me this wonderful opportunity. Thank you very much.
Okay, I think we quickly move on to the next speaker. The next speaker is Dr. Shalini Nalawad. She is into aeromedical transport, kind of pioneer in India, along with her colleague Rahul, and I know them personally. And she is going to speak again a very, very important topic on air transport and COVID. COVID has given birth to a lot of aeromedical transport in India. Importance of aeromedical transport was felt during COVID time. Over to you, Dr. Shalini.
Thank Dr. Tamorish. Thanks a million, and it's a great pleasure to see you, even though we are kind of connecting up virtually. At least it's bringing us all together again after a long time, and it is absolutely amazing to meet the SEMI team again. So, who have been the biggest supporter of ICAT from the day one, and who recognized our contribution or work in the MCon 2015 at Hyderabad itself. So thanks again, and it's great to see you all. And also thank Dr. Sudeep Chakravarti for inviting us. So I think, like, for the juniors who are joining up, I'll just start up with a bit of an introduction about air ambulance. So I and Dr. Rahul Singh Sardar are trained in anesthesia, critical care, and aeromedical. We from the UK and did our undergraduation in India. We came and started this ICAT, an International Critical Care Air Transfer Team, what it stands for, around 5 years ago. And since then, it has been a huge roller coaster journey for us. But we have been kind of bringing two highly sensitive fields of aviation and medicine, and we kind of feel like we have done or achieved quite a bit of milestones so far. So we operate kind of a fixed wing aircrafts and a rotary wing aircrafts. Fixed wing is between the airport to airport, or we can use it for secondary transports. Rotary wing can be used in an emergencies, or we can land it roadside. It was pretty much widely used. We used it during the Kerala disaster in 2018. We connected up with all the relief camps. So this is our Madurai MCon, where we did the aeromedical drill for the first time. And we operate throughout India. We connect up to countries outside as well. We cross the border, initiating ECMOs outside India to Nepal and other countries like Africa. And that was our award, which we won with the beginning of our journey, to be honest, into the aeromedical world in India. And we use different type of aircrafts, Learjet and Beechcrafts, B200, turboprops, for the transfers. So this is our flying kit, if you look at it there, and that was used during the Kerala disaster. And this is where kind of we followed the same kind of a transfer, what we do, like, or the modus of operandi of track and trigger during Kerala, which we tracked all the sick patients in relief camps and airlifted them. So I'll jump on straight away to our COVID air transfer, how we did it and what we did. So during COVID, when the entire world was shut, all the skies were shut, aviation world was shut, we did the first aeromedical transfer of for a patient from Afghanistan Airways, an Indian national. It was a humongous task, bringing all the ministries together, Ministry of Civil Aviation, Home, Disaster, Health, External Affairs, but we successfully brought this polytrauma patient from Afghanistan to India. And we also attempted and we also kind of carried out the longest aeromedical retrieval of India from Johannesburg as well. Again, it was a nightmare when we didn't have any refueling facilities in the airport because all the airports were shut. So you can imagine the humongous task which was taken up to execute this mission. And during COVID, when people started calling desperately from all across the world, in fact, there was no way people were allowed to board or even enter the airport with a kind of a slightly higher temperature, and most of the airports were closed. That was the time when we got this isolation pod transfers for COVID. We revolutionized the way we transfer the COVID patients. So what is an isolation pod? Isolation pod is a biocontainment module. It was first used in 1970 during the Lassa fever and then during Ebola. And we imported this from Germany, and it has got a negative pressure pod. It's got 6 filters, which is 100% safe for the crew. Again, it was a humongous task to get the pilots and airport authorities and aviation and everybody, to ground handlers, airport staff, to agree to get a patient inside an aircraft and fly them out. So that was our first isolation pod transfer. Along with that, we stepped up our service because I and Rahul have experience of ECMO from the UK. We did our ECMO course from Leicester Glenfield, which is a mecca for ECMO. This was in 2015. We did the India's first international ECMO transfer from Qatar. So ECMO was nothing new for us, but at the same time, adapting to COVID and going and initiating it in very remote places was a huge challenge. Luckily, we have a very good set of doctors and paramedics who are trained under our fellowship in aeromedical sciences and aviation. Most of our doctors also have a semi background or semi members as well. And so with that training and having a very robust medical team, and also the training from the UK, and with the isolation pod transfer experience, we started adopting doing the COVID ECMO transfers as well. We have done the highest number of ECMO transports in the world, 126 in 6 months. Normally 10 to 15 happens in 10 years time. So this was again 2015. It was again not new. Why exactly is this COVID transfer or COVID ECMO transfers are very, very challenging? It's because we work in the field of variables. Every single minute the situation is dynamic, including the airports changing the regulation for RT-PCR. We can go end up getting stuck in the airports. So that the logistics that we have to bring in together is the timings, the locations are sometimes very remote. When we went to Nepal, we had to cross the road we had to walk and cross the border, and then we had to go to enter Nepal and fly to Kathmandu. And again, ECMO machines have quite a few different types of machines. Every hospital has a different one. So very few ECMO centers operate across India. Along with that, putting an ECMO patient into an isolation pod is a nightmare, but we mastered the technique purely because of our perseverance. Debriefing after every single transfer, we had thorough debriefing to see how we can improve the next one. No transfer goes without a debriefing, and also empowering the leaders. When we were getting 20 transfer calls for ECMOs every day, we purely did ECMO during the COVID, we were airlifting and retrieving and initiating 4 ECMO patients almost every day during the second wave. And again, creating green corridors. And there are places where we went, we didn't even have lift to bring this patient down. We were called to come and initiate ECMO, where they said these patients are in the hospital, but when we go there, it was kind of a lodges converted into hospitals, which didn't even have a proper lighting. Forget about the ABG machine. So we had to carry every single equipment, ours, including the ABG analyzers. So along with this, the times we have come across having lack of lights in the front door to load the patient into the ambulance after initiating ECMO. Despite this, most of them have been extremely successful in terms of retrieval and initiations. Along with that, we have challenges where we come across weather, pilots FTTL, and also like we get involved in quite a few VIP transfers as well, and getting some of the results and stabilizing the patients when we go there is not again very easy for us, because some of the hospitals do not have any kind of a facility to cooperate with us. Again, once a team comes, and as you all know, in retrieval world, the primary hospital kind of disengages with the patient, but when we require the most support from the local team, it's very difficult. And how did we execute this to kind of perfection is, I'm just kind of going through the slides there, because I know I'm really running short of time in the next 2 minutes. So there are a few transfers. I'll kind of explain how we did this. This was one of the transfers which we did from Ludhiana to Mumbai. Ludhiana, the airport which is closest is Alwara airport, very close to Pakistan border. Any small disturbance in the border, they shut this airport. So every single time we attempted to airlift this patient out of Ludhiana, we were almost kind of cancelled. And then we had to go to Chandigarh, and Chandigarh also had this, because it was November, there was farmers agitation, there was very thick fog. So there was a high risk of us not taking off again. So we had to put an hospital, like a hospital in Chandigarh, standby in case we get stranded in Chandigarh with the patient on ECMO. So, and we also had to use backup ambulances, police escort, and we reached there. Again, if we due to weather or any other reason we can't take off, the entire bay was emptied for us despite COVID in one of the hospitals in Mohali. So, of course, we require a lot of support from all the stakeholders and the critical care world and the emergency world in these kind of transfers. So, we did one of the ECMOs which we initiated was a 42-year-old COVID with subarachnoid hemorrhage. We used a double surgeon technique because we could not anticoagulate him in a big way where we required massive boluses of heparin during during ECMO initiations. And this guy walked home today, and it is kind of, these are the things which are very rewarding for us when we say like we did them successfully. So we follow very strict protocols, standard operating procedures. We have empowered the team leaders to make decisions because we both can't be everywhere. We have multiple conference calls, and we have checklists, which has been almost kind of gets updated on a weekly basis with strict clinical triaging system. I think that was a time we all were kind of overwhelmed with the number of calls, and we were playing God. In fact, all of us, like choosing whom we need to bring in, admit, whom we cannot, whom we can initiate, whom we cannot. It was emotionally exhausting, but again, that was a time the entire medical world gave a huge fight, and relationship building, of course, support from the medical community across India. Thank you so much, all of you, for listening to me. If there's any questions, I'm happy to take. Thank you.
Thank you, Shalini. You're ahead of time. So I thank you for making it up. And I now pass on to, we'll have questions later on. I will now pass on to Dr. Mahesh Joshi, and I have the distinction to introduce him. It's after many, many years, I'm having one more opportunity to attend his class, I will say. And he's going to speak on home care and COVID. Dr. Joshi is a teacher of many pioneers of emergency medicine in India. He's a fellow of the Royal College of Emergency Medicine, and he's also the executive co-chairman for Society for Emergency Medicine India. Welcome, sir. We can't hear you, sir.
Sir, can you say something? Dr. Joshi, your voice is not coming.
We are facing some technical issues. We are on it, sir. Actually, we'll be solving this very shortly.
Hello, yes. Lady, are you saying something?
Yes, sir. Some technical issues, sir. We are trying to rectify it, sir. We'll just rectify.
Okay.
Can you hear me now?
Yes, sir. We can.
Oh, good. So we'll get started. Just give me a second. So was the problem at my end or at some other end? I didn't understand that. Nonetheless, doesn't matter. We'll get quickly started. First of all, Shalini and Rahul, extraordinary work, and so proud of the work that you guys have been doing. And more power to you. Keep up the good work. I know it's been extremely daunting and challenging for you to do this kind of work. Keep up the good work.
Thank you so much. And I think we learn a lot from all your leadership and guidance, and we try to kind of try to be like you people, like, yourself, Tamorish, Krishna, they're all like leaders whom we kind of try to, in fact, copy to be so graceful and perfection and leadership. Thank you so much.
So I think a lot has been talked about COVID. I think it's important for us to pause and reflect. One is, what has COVID done to the entire healthcare system, and particularly what is relevant from emergency medicine, because it's an emergency medicine conference. And my big thank you for the organizers of Semicon 2022, and best wishes for a huge success of this conference. What it did to the entire healthcare system is, first of all, it overwhelmed the system, which was anyway partially overwhelmed. In the second wave, there was shock and awe. We didn't even understand what was happening. Just when we were trying to relax, the third wave again come back. Thankfully, probably, I cannot say for sure, vaccination has played an important role in reducing the effects of COVID virus in the third wave. But still it is ongoing. So I don't want to forecast anything before. And second is, it clearly exposed our entire healthcare system being dependent only on hospitals. So if there was something which stopped the patient from coming to hospitals, or the hospitals got overwhelmed, we did not have any backup system. It clearly pointed out to lack of community care and lack of care continuum. Those who came, should they have come to the hospital? And those who came in, could they have gone early from the hospital? I think these were some very clear challenges that came out into the during the time of the COVID. It also exposed the huge gap between the public and the private healthcare system. On one side, there's public healthcare system, the other side was private, and those who could afford could manage to get care. Those who could not, can't say what exactly happened with so many of those people. It pointed out to inequitable distribution of healthcare in India and across the world. But I think, to me, the biggest learning And I think they always say that if you have to manage a mass casualty incident or disaster or pandemic, it is as good as the triaging that you do. We clearly lacked ineffective triaging. And the best example of this was the first OK for home isolation came at the end of June, whereas the pandemic was declared in March. So we clearly focused on what hospitals need to do. We did not do anything much on what could be done to prevent the hospitals from getting overwhelmed. That's the lesson number one. Now, home healthcare during COVID was not just about COVID patients. Please understand that people were scared about coming to the hospitals. People stopped coming to the outpatients. People stopped coming to emergency rooms. So there were existing non-COVID patients. There was fear, there was uncertainty. So people who were staying alone or whose parents were alone, they wanted somebody to be taking care of their parents or elders at home. So you had the ongoing non-COVID needs plus exacerbated non-COVID needs during this time, like the elderly care, certain critical things which had to be continued, like chemotherapy at home or dialysis at home, blood transfusions at home, came up as an important need during this time of the pandemic. Apart from this, there was COVID need. Now, COVID, at the end of June, for mild cases, the guidelines came. And again, because we were very protective about how we want to handle this, we lost a significant opportunity on how many patients could have handled at a much lesser cost within their homes. But it be as it may, I hope that we learn. And as we are seeing it by the third wave, lot lesser people are going to the hospital. For mild, there is home isolation need. For moderate, there was oxygen support need or an IV. And in some cases, remdesivir administration, especially during the second wave, we saw this. And in severe cases, obviously, beyond hospital, they needed post-discharge care in terms of lung rehab, oxygen support, or non-invasive ventilatory support. So these were the broad areas where home health care came in and really supported the entire existing hospital-based healthcare delivery system. Now, as you know, most of the home healthcare players in India are unorganized. There are only 8 or 10 of them which are organized players who have certain quality check system, protocols, etc., and they have multi-city presence. So whatever we could do in our mind, we did. Some people did work with government on the home isolation front, like healthcare at home and Portia. We did beyond government thing to reach out to the community and see what could be done for them. So what has been our experience? In the first wave, we handled about 10,000 cases over 6 months as a part of the stay at home program that we had launched just for 350 rupees a day. It was a 2-week isolation program as per the guidelines. And apart from that, we managed about 500 cases which were either mild or moderate because the guidelines were very strict during the first wave. In the second wave, we handled about 15,000 cases in just 12 weeks' time. At the peak, I had about 5,000 patients live every single day that we were managing. And then we had about 1,000 cases which were COVID related that we were handling either in terms of oxygen cylinder or oxygen concentrator or a BiPAP or a CPAP, whatever was needed for the patient, or giving injection steroids at home, or in certain cases, remdesivir at home. In the third wave, what has happened? So far, in just 3 weeks, we have already onboarded about 5,000 patients. As of today, I have about 4,800 patients which are live, 200 are discharged out of that. Thankfully, because the case is not so severe, we have about 200 cases which are moderate COVID at home, which are probably needing IV fluids, etc., or some injections to be administered under the guidance of the infectious disease specialist. So this is quick snapshot of what the stay at home program was. This program was not clinical in sense. The needs of a COVID patient were very different, and this is where this program became extremely successful. It was to allay the fear of people, the anxiety that was associated. So it was not so much about doctors, it was about clinical needs, it was about their nutritional needs, it was about their lung rehab needs, and more importantly, it was about their engagement and motivation. So just to give you a small example, we encouraged so many people to get back to their hobbies, whether it was painting, whether it was singing, whether it was playing instruments, whether it was gardening. This became an integral part of that 2-week program that was there. And if you go back to any of our online feedback or reviews about Apollo Home Care, you'll find so much of gratitude being expressed by people, not so much about the medicines, because there was very little on the medical front that you could do, honestly. But it is about how people felt comforted that there was somebody to take care of them during that time. And one of the most fearful times ever in their lives was during the second wave. This program was also awarded the Excellence Award by the FICCI for 2021 in the home health care space. And that's the reason you see immediately in the third wave, within the first 3 weeks, we've onboarded about 5,000 patients. Apart from the immense gratitude I have earned as an emergency physician, I think this was one moment of gratitude where I felt that when the nation needed the most, and we really needed to not do the best for everyone, but do at least something for so many people, we were sitting in a place where we could actually reach out to hundreds of people from over 120 cities. Right up there in Darbhanga, we had online patients who were being taken care by our team of COVID care providers. There were immense challenges during this time. Getting people to come on board was immensely challenging. When everybody was fearing of getting out, we were asking people to go into patients' homes and take care of them. And that requires some sense of motivation. You just can't get people to just push them just by providing a little bit of incentive of money. You need that culture to be instilled into minds of people. Staff illness, particularly in this wave, has been a huge challenge. It was always there, but in this wave, it is a huge, huge challenge. Nearly 20-30% of our staff are down. Customer expectations, they needed everybody to be available every time, particularly the doctors, even for the smallest care. And this is where we actually lived up to their expectation. I think the most important piece was keeping the teams connected and motivated, giving them that sense of purpose that this is a national requirement. The country needs this out of you. It is not about what your job, what your profession, what your salary is. This is what we must do for our fellow countrymen and for the country. A larger purpose had to be created to motivate the people to do, despite they being COVID positive and sitting at their homes, they were doing consultations for people. So what are the positives of COVID on home healthcare industry? I think this is an important takeaway slide. What happened in the first 6 months after COVID was virtually every hospital started talking about their home care services. This was a huge turn. This was a big change from what or how hospitals viewed home healthcare industry. They always thought that home healthcare is a way of taking away some revenue from the hospital. But I think mainstreaming of home healthcare has already happened. You see policymakers, clinicians, hospitals, business leaders, and more importantly, insurance players now coming to us and saying, how can you take care of these patients? Now imagine these patients with mild or moderate COVID in any hospital during the COVID wave would have spent at least 30,000 rupees a day. And we manage these cases at just mere 350 rupees to 500 rupees per day. And this is a tremendous cost saving for the patients, as well as making capacity available, not overwhelming the system with unwanted cases who could be managed at home. They must be managed at home. You will soon see a white paper coming on home healthcare industry. This is in the final stages of the draft, and this will definitely turn a lot of head as far as the policymakers are concerned. And I'm sure you will see NABH and other people taking cognizance of this, and you'll quickly start seeing guidelines for home healthcare coming in India through NABH, etc. You'll see more and more investments coming, more and more hospitals focusing on home healthcare, because they've realized that their business model, which is purely facility dependent, is very vulnerable in today's time when the patient is willing to access healthcare remotely and they would prefer it at their home. And the last point, from an emergency department perspective, I think there is a lot to learn for all the emergency departments. Your aim should not be to admit how many patients who come to the ER and get admitted to the hospital. You must work towards maturing your departments to taking back as many people from ER without admitting, with the support of home health care. So the mature EDs of tomorrow will have home health care integrated into it. So before the patient comes, home health care is there. If they come to the ER without the notice of a home health care, there is somebody from the home health care team along with the ER team and some specialist who assesses and says, well, this is just mild pneumonia, SATs are okay, breathing is okay, just chest X-ray is showing, does not have risk factors, we can manage it safely at home. That's the way the entire management of patient will change going forward. And I will urge the young leaders of emergency medicine to see on how they can integrate more and more home health care as a part of their department. Thank you very much.
Thank you, sir, for the wonderful presentation and as well as very, very futuristic and realistic insights on how to move forward. I think we are running out of time, but still we will have at least 3 minutes of questions. So if there is any questions from audience, please put it on chat box. Okay, I think there is no question at present, but I would like your comments on the future pandemics. How as an emergency physician we should move forward. I will start with Joshi sir first.
They are already moving forward, right?
Well, I think this video came like Omicron. Anyway, we will continue.
Yeah. So, Tamorish, to your question, I think pandemics like this, we just hope that they don't get repeated and they are once in a decade or once in a century kind of thing. But yes, first thing is to do an honest reflection on what we have learned out of these 3 waves. To me, the same principles of fundamentals of disaster management still always prevail, and that is effective triaging. If you look at it, whether it was wave 1, wave 2, or wave 3, 70 to 80% of the patients were mild COVID. In fact, all started as mild. All 100% started as mild. And then some of them ended up as moderate and a very small fraction ended as severe. But our entire focus was how do we manage those small fractions who are going to be needing the hospital stay. I think as an ecosystem, we need to find ways of keeping as many people away from burdening the already overwhelmed and highly expensive healthcare delivery system, which is hospital. And that will mean awareness, call centers, remote consultations, standard policies, protocols to ensure that there is a standard equitable care across, and it's not, as you know, there is very different forms in which COVID is managed. One thing that the government did good was to come up with guidelines on a very regular basis, and that's a very, very positive way of doing, at least that there was something which was coming on a regular basis. So I will stick to these 3 things, and before the next one comes, find how we can enhance our community healthcare delivery system, pre and post care. These are the important things. I will pause.
Thank you. Shalini, your thoughts?
I think after what Dr. Joshi said, there's not much I can say, but we are dealing with two spectrums, the two end of spectrums. One is at community care and another one at the medical care at the highest level possible, because I think it is drawing up every kind of resources in managing these patients, or managing the economy, managing the country, managing the medical world. Discipline, of course, which has to be brought in and also like learned, because we do not know whether this pandemic is gone or whether we're going to have it for a few more years. Just with Omicron, people thinking like, oh yeah, this is very mild and already everything has been blown into air. We don't know if this kind of mutates again and gets into another nasty one like a Delta. So we have seen the disasters, we have seen the way it has destroyed lives, and even the families attending funerals have been like totally 16, 17 of them have died. So I think as a medical community, it has become we have played a very big role. Now this healthcare has become such a big focus, from home care to preventive medicine up till like, the critical care medicine. We have to get prepared and prepare our juniors for kind of to things like this, which we do not know when it will end and when the next one will start. The way the biological warfare or whatever in the future we are going to face, we do not know, because ours is the generation which never saw a big calamity, big war. This kind of came as a huge shock to all of us, where we've taken the entire world for granted. It's masked us up, stole our identity, locked our seniors up, and also destroyed the education of the future. So I think no matter how much we prepare, it is less. We have to prepare on all grounds as possible. That's all I would like to say. Thank you.
Right, thank you for that. I can see Kiran waiting. Kiran, you are still very much active, working in front line. What are your thoughts?
Yeah, so as Mahesh Joshi sir told, we have to have proper triaging system, sir. So, as rightly pointed out Mahesh Joshi sir. Then second one is we have to improve the community healthcare sector. So these are the major things which should be where we focus on. So otherwise, nothing much, as Dr. Mahesh sir told and Dr. Shalin told. I agree with them, sir.
Right. Thank you for that, Kiran. Rajadurai and Saujana, are you still there? Okay, I think they have left. So thank you very much, all the speakers in this session. I learned a lot from your insights and experience. I hope the residents have learned a lot, and I hope your presentations are available for the residents. So once again, thank you very much, and we will now pass on to the next session.
Thank you.
Thank you, and all the best, guys. Stay safe.
Thank you, sir. Thank you.
Okay, our next session is on GI emergencies, and we have two faculties here. The first one is Dr. Satish Kailasham, who is going to speak on approach to acute severe pain abdomen in ED. Satish, everybody knows, he's the past president of the Society for Emergency Medicine in India, and he is director of emergency at Agarwal Group of Hospitals. A very, very dynamic, enthusiastic young physician, I'll say. And Satish, the stage is yours.
Thank you, Tamorish. I'll share the screen. Yeah, my topic is welcome to Semicon 2022 for the virtual conference. My topic is approach to pain abdomen in the ED. Right. This is where I work, Medicover Hospitals. I'm the director for emergency medicine for the group. It has 18 hospitals across in 12 cities, majorly Andhra Pradesh, Telangana, and Maharashtra, with 600 ICU beds and 142 emergency beds. Society for Emergency Medicine India, it is my lifetime affiliation, which was established in 1999 for training doctors, staff, nurses, technicians to provide quality emergency medical care to all the people in India. Why we are talking about pain abdomen? Because if you see the footfalls in the ED, the rural or urban area or multi-specialty hospital or a nursing home, the most common footfall is, one of the most common footfalls is abdominal pain. If you see the statistics from different hospitals, if you can see the Indian hospitals or in United States also, it is the registry of ambulance registry they have done in, they got the statistics from 2018. That is shows abdominal pain is the one of the most common presentation to the ED. It is the topmost, one of the top 10 presentations. If you see one of the number of cases how they present to the ED, if it is 20-year-old male patient coming with a pain abdomen in the right loin region, 25-year-old female coming with the pain abdomen in the left loin, 45-year-old male patient with the pain epigastric region, 55-year-old female pain in the right upper abdomen, 60-year-old male pain with the central abdomen, 70-year-old male patient pain in the lower abdomen. We'll discuss all these 6 cases once we are done with the session, okay? Fine. Types of abdominal pain, it's parietal, visceral, referral. If you see the parietal pain, it arises from the parietal peritoneum and is usually localized pain. Visceral pain arises from the viscera and it is usually diffuse and it is a non-specific pain. Referral pain, if you see if the patients come with epigastric pain, sometimes that is referred from inferior wall MI. If you exclude all these things, then you can diagnose as a psychological abdominal pain. This diagram will definitely help us in trying to find out the cause of the abdominal pain. Foregut structures, if it is upper abdominal pain, mainly related to the stomach and liver. Central abdominal pain, small bowel and appendix. The lower abdominal pain, colon and GU system. This is the famous mnemonic Socrates. He will tell all the diagnosis. If you properly ask all these questions to all the patients coming to the ED, we will definitely diagnose, have a most possible probable diagnosis before you start examination, before you ask for imaging, before you ask for labs, or before you call a surgeon. Site, as for site of the pain, it's the right, you know all the 4 quadrants and 9 abdominal regions, site of the pain, where exactly it is started. Onset, it is a gradual onset or it is sudden onset. Character of the pain, it's a dull pain, or it is a sharp pain, or it is a spasmodic pain or a colicky pain. Radiation of the pain, where the pain is coming front to back, radiating to back, or loin to groin radiation, or a groin to loin radiation. Associated symptoms, whether the patient has any other associated symptoms along with the pain, like nausea, vomiting, fever, burning urination, or hematuria, anything sort of that. That is associated symptoms. The time, any time duration of the pain or a time pattern of the pain. So where the patient had a pain in the morning, after urination or after eating food, whatever. And how much duration the pain was there. Is a colicky pain or not? Any exacerbating factors or elevating factors, whatever. So the pain has come down after eating, pain has come down after passing urine, whatever. So you should ask these questions to come to a main probable diagnosis. Yes, for severity score, we have to treat the patient according to the severity score, because you have give the visual angular scale to 1 to 10, 1 being the less pain, 10 being the worst. If it is more than 8, we have to give an IV analgesic to the patient, try him as a priority 1, and you have to give IV analgesic to the patient. So these questions are most important to diagnose, to come to a probable diagnosis before you starting examining patients. There are 4 more questions in this. There are 4 questions which will definitely will not miss any probable diagnosis, like in the year, like onset, sudden or gradual. If any patient coming with sudden onset of abdominal pain, definitely we should think of all these 5. Whether it be a perforation of a viscous, peptic ulcer, or a rupture ectopic, a rupture aortic aneurysm, or impaction of a stone, as in a renal colic. These 5 things you should have in your mind if the pain is sudden onset. Duration or recurrence of the pain. If the patient coming to the ER and the patient has history of recurrent problems, recurrent pain abdomen, you should be thinking of these 3: a peptic ulcer disease, a renal colic, the gallstone colic, and diverticulitis. For the females, it can be a meatus merge, endometriosis. Character or nature of the pain. Sharp, constant pain that is worsened by movement, that is moving towards peritonitis. The pain which is expressed by the patient is more, but we're unable to see those many physical findings. That is in case of pancreatitis and ischemic bowel disease. Pain due to inflammation of an organ tends to be gradually, and that results in guarding in examination. Pain due to obstruction tends to be intermittent. There's a colicky pain that comes in waves. As I said, radiation, that is the most common question we should ask, so that it will come to some diagnosis for us. So aortic angiogen rupture, a peptic ulcer disease, pancreatitis. You should ask any pain that is coming from the center of the abdomen or epigastric region that is going to the back. You should determine whether they look ill or in pain. Patients who appear comfortable and apparently well often are, whereas those who are anxious in obvious pain, pale and calming, often are not. So abdominal examination definitely plays a major role, but you should see whether the patient is sick or not. Most of the patients, they may be having a lesser pain, but they are more anxious, but who are calm, maybe losing the blood inside, they may be calm. So we should be very, very careful in triaging the patient. Coming to the elderly patients or patients with comorbidities like hypertension, diabetes, should have a proper protocol before you discharge them, because they have a low threshold for admission. They need to see each and every checklist before you discharge the patient. This is one of the famous diagram, everyone knows about it, to understand the structures in the 9 quadrants, 9 regions, so that you will come to some possible diagnosis or some diagnosis before you send for imaging, before you ask for a surgeon to come and see. Comes to the imaging, what are the imaging we should ask for a patient coming with abdomen pain? As I said, most important is history and clinical examination. More than clinical examination is the history. You should ask each and every point about the history. Coming to imaging, most of the hospitals have an ultrasound as a bedside or near to their ED to diagnose the cause for a pain abdomen. But the American College of Radiology has developed clinical guidelines, the appropriateness criteria based on the location of the abdominal pain, to help the physicians to choose the best imaging study. For right upper quadrant pain, patients coming with right upper quadrant pain, ultrasonography is the initial imaging test that should be ordered. For a right or left lower quadrant pain, you can go for CT scan. Conventional radiography, X-ray abdomen or X-ray chest, X-ray abdominal chest, has a limited diagnostic value in most of the patients coming with the abdominal pain to the ED. So they are the key recommendations. What I said, evidence is like consensus. See, evidence rating is C for all this thing. And one more thing is here is beta HCG. Like pregnancy test is should be considered before performing any imaging, and in all women that are in the childbearing age. These are some of the investigations. If you're thinking of acute pancreatitis, acute cholecystitis, or Crohn's disease, diverticulitis, those you can go for CT scan. But if you're thinking of a ruptured ectopic or a ovarian torsion, then you can go for an ultrasound abdomen. As I said, conventional X-ray and abdominal radiography has a limited value, but still, if you're thinking of a bowel obstruction or a perforative viscous, just definitely erect chest X-ray and erect chest and abdomen definitely helps. If you're unable to get the patient erect abdomen, still you can use the left lateral defibrillation for the free fluid and air fluid levels. What are the labs you should send to help in to aid in the diagnosis? Complete blood count, definitely it helps in diagnosis when there is a elevated WBC count, definitely the possibility of infection, but you should not rely on WBC and CRP in diagnosing or treating the case. Serum amylase and lipase definitely helps in, they are sensitive to the pancreatitis. Lipase has more value than the amylase. Urine analysis, if your patient is, you're thinking about renal stones or UTI, CE and pus cells and blood in the urine definitely helps us in diagnosing the UTI. Blood cultures, if you're thinking patient has a sepsis or infection in the abdomen, peritonitis, any infection, the ruptured viscera, whatever, then if you think patient is sick, you should take all the blood cultures and send the sepsis markers like ABG, CRP, lactate, coagulation profile before you start antibiotics and further management. Typing and cross matching definitely helps if you're thinking in a patient that has a aortic rupture, patient is sick, pale, you should start blood transfusion at the earliest. Coming to the clinical management, resuscitation, any patient coming to the ED, we have to have a proper triaging protocol. The pain more than 8 definitely has a triage 1 category. Of course, you can less than 8 still, less than 8 still you can have bedside triaging. If you think after your clinical history examination, if you want to upgrade, you can still upgrade. ABC is main, definitely. Fluid resuscitation is most important in pain abdomen because the patient will be having associated symptoms like nausea, vomiting, fever. You have to hydrate them very well. Pain management, morphine is the best analgesia to give. Most of the doctors are worried that if you give analgesia, that surgeon will not have much findings, but there is no evidence for that. You have to give analgesia before the surgeon sees. And antispasmodics, there is no evidence. You can antiemetics, yes, you can give. If you're thinking of a sepsis, definitely you should start a broad spectrum antibiotics, IV antibiotics before you start. If you take a culture, supportive management, NPO, Riles tube, and Foley's catheter. When to call a surgeon? This is the most important thing. If when to call a surgeon, surgical management has 4 options. For them, it's wait and see, wait and image, look and see, and open up. For example, wait and see, the patient has come with abdominal pain, but if you feel the pain has subsided dramatically after a oral analgesia or IV fluids, then it can be a gastroenteritis, whatever. Then you can serial examinations, of the patient definitely helps. And in these patients, you can avoid a lot of scannings and labs also. Wait and image. The same patient, if you think patient is not improving, he needs more scan, then observe for 6 to 8 hours, then you can go for a scan or CT or endoscopy. For especially childbearing years, if you see ultrasound is inadequate and patient history and labs are not correlating, then you have to go for diagnostic laparoscopy to find out the cause of pain abdomen. If patient is sick, there is a rupture, the trauma, there is a blood in the abdomen, is sick, you have a definite diagnosis with us with the CT scan, there is no other option, they had to open. So if you go back to our 6 patients, case 1, a 20-year, go back please, go back. 1 minute, go back. Yeah, 20-year-old male patient pain with right loin. Still, you can think, you should ask the patient, has any radiation right loin to groin, have associations like burning urination or not, any fever or not, nausea, vomiting. This patient, if you have clinically any guarding is there not, if doesn't have a guarding, if he has a symptoms of UTI, right loin to groin pain, then you can think of it can be UTI or a stone. If he has symptoms of fever, radiation of pain, or guarding, then you can think of right appendix. You should go for a CT scan. 25-year-old female pain left loin. You should think of all the childbearing age. First, you should think of beta HCG strip test first. Then you should go for any imaging later. You can ask the patient about the menstrual history. You should ask the patient about the UTI symptoms, any struggle of pregnancy, any severe pain or is a gradual pain, because sudden onset of severe pain, it can be a torsion also. So these patients definitely need a CT scan immediately once the beta HCG is ruled out. 45-year-old male patient pain epigastric. This patient requires a lot of 45 middle-aged patient, a lot of history taking because the patient has a previous episodes of pain or not, the patient has an alcoholic or not, the pain is radiating to back or the stable pain, whether the patient has any NSAIDs, patient has the relieving factors like bending onto the front or the food intake, any associated factors like vomitings and nausea. It can be a pancreatitis. You have to send ML as a lipase, and CT scan will definitely help us in the diagnosis of the patient. 55-year-old female patient pain with right upper abdomen. As I said, female of 40 to 50 years with a fatty, they're coming with right upper abdomen pain. Mostly it can be a cholecystitis or cholangitis. So most of the clinical history or examination along with ultrasound abdomen will definitely give us the possible diagnosis. 60-year-old male patient pain in the central abdomen. This patient should think of any vascular disease also, He has a CAD, hypertension, diabetic, and check the blood pressure properly and ask how is the pain. Maybe you may not have his findings that much, but he will be having a severe pain. So you should think of the worst diagnosis like rupture aortic aneurysm, then think of other diagnoses. Come to 70-year-old male patient coming with the pain, lower abdomen, most you should ask for symptoms like UTI, then think of the ultrasound abdomen or a CT scan to diagnose the cystitis or not. So Socrates definitely will help a lot, and proper clinical history and examination before you ask for any labs or imaging. These are my references. Bottom line is, go back. Any patient with abdominal pain that is discharged from the ED should have a clear advice when they have to return back. You should give a symptoms like when they have to come back. And geriatric patients and high-risk groups, definitely you should maintain a low threshold for admission. These are my references. Thank you, Scientific Committee and Organizing Committee, for giving the great opportunity for the Semicon 2022. Thank you very much.
Satish, thank you very much. A little bit of extra time, but what's pending with those 6 cases? And I would like to your presentation to be available to all residents so that they can go back and forth, because it's a very, very important topic.
Thank you.
And well presented. Thank you very much. We pass on to Abhishek. Abhishek, are you there? Are we presenting his video? Dr. Abhishek Chatterjee, are you there? Larry, should we skip and go to the next presentation?
Yes, sir. We'll skip this part and we'll go to the next session actually. And
okay, so
Abhishek is a little bit engaged with a critical case. So he will be coming back shortly actually. He has requested to postpone his presentation.
Okay, so what we do is now, we pass on to the next system, which is renal and GU emergency. But before that, since we are moving from one system, if there are any question on abdominal emergencies, we can take questions now. In chat box, Larry, is there any question?
Yeah, one I can see someone has raised hand, sir.
Yes. Please ask your question.
Can't see his name actually. It is VH58V5.
That hand is raised for a long time. I don't know whether.
Yes.
Yes. I think. Yeah.
Yes. Just a small discussion. Actually, this pain presentation in ED, it has a various angle. I remember a few days back, actually, we have seen a patient where a young lady presented with a pain abdomen. It is in the right, it is in the left iliac fossa, not exactly in the left iliac fossa. It is in the left flank and iliac fossa, that just junction area. And the pain was radiating down. So we had a suspicion and we went for an ultrasound, and it actually reveals that the patient had an adnexal mass which got, there was a torsion. So immediately we have done a small cut of MRI and we have taken that patient for OT. So that was a challenging actually presentation in ED, because that pain was there for quite some time for that female, and initially she thought, okay, yes, it might be a gas or something, and they were not very reluctant to come to the hospital, and they were taking only medicines for painkillers and all gas medicine. So those are the things actually we have to be very careful regarding.
Yeah, like I said, in emergency department, you should think of the worst diagnosis first.
Yeah.
If you're in a mind, it is there, it's in simple gastritis, think it's an ulcer. If you feel it's an ulcer, think of the rupture. If you think of a rupture, you think of more beyond that. It is going to that's what I learned in my residency or in my training. So think of the worst diagnosis first, then you work for towards the other diagnosis later.
True, sir. I just one more case I want to point out. During my very initial days when I joined in Narayana, we got an epigastric pain. And when we know that epigastric pain, it can be a cardiac origin or it can be an abdominal origin. Well, we got an ultrasound done with a tropi. So the initial ultrasound revealed patient is having cholecystitis. So we thought, okay, it might be. Then we got the tropi result also. It is quite high. And then the echo showed that it is an inferior wall MI as well. So it was very tricky, actually. But it's nice that, you encounter so many, different kind of patients.
Maybe if you do scanning ultrasound abdomen for that 40 to 50-year-old patients, I think you can find a lot of cholelithiasis. So it may be incidental finding that masked the inferior wall MI.
Yes. Thank you very much, sir.
Thank you very much.
Yes. So for the next session, actually, Tamorish sir.
Okay, let's pass on to the next session, which is renal and GU emergencies. We have 3 talks here, starting with Dr. Arif Matu. Arif, are you there?
Are you able to hear me? Yes, sir.
Yes, I can. And now I can see you. So welcome from India. You must be in Saudi right now.
Yes, sir. Thank you so much.
Okay, so Arif is going to speak on acute kidney injury. Over to you, Arif.
Thank you so much. Thank you, Semicon, for giving the opportunity to speak with all the residents. My talk today is acute kidney injury. This presentation will cover the background of acute kidney injury, definitions, pathophysiology, what are the risk factors, and the most important, how we manage these cases in the ER. So acute kidney injury, which was previously known as acute renal failure. The reason behind this, why it is not known as acute renal failure, because it's a wide spectrum of injury of the kidney, not only the failure of the kidney. So that's the reason which was changed. The most common causes which we have seen are reversible causes, which accounts for about 55 to 79% of the cases. Out of this, all 18% of all admission patients, which we call it as hospital acquired acute kidney injury, accounts about 18%. The mortality ranged from 7.3% to 19.6%, which is very high. And even if you discharge the patient and these patients, if they will not take a proper care, even after discharging and even after subsiding the symptoms of acute kidney injury, the 3-year mortality is very high, which is about 45 to 66%. So between 20 to 30% of cases of acute KI, which are preventive, and can be managed. If we'll save them properly, we can save about 12,000 lives each year, which is quite huge number. So let's go to the definition. They call it as acute kidney injury is the sudden or rapid deterioration of the renal function over hours or even days. There's a definition which we cannot change, which is for some things which are very important, which we should remember. So there increase in serum creatinine greater than 26.5, and somewhere it's mentioned only 26 millimoles per liter within 48 hours, or if it's presumed to change within, known as presumed to last 7 days, if it's changing, or there is a decrease in urine output, which is less than 0.5 ml per kg per hour for 6 hours, or if it is less than 300 ml in 12 hours, we call it as acute kidney injury. And if it's less than 100 ml in a day, that means in a 24 hours time, we call it as anuria. So knowing any disease, we should know simply the basic pathophysiology of things what we are dealing with. So the basic function of the kidney is glomerular filtration, tubular reabsorption, and secretions. So normal GFR, which is in early childhood, is around 120 ml per minute per 1.73 meters squared. This 1.73 meters squared is average surface area which is considered. And it has been proven that around 8 ml per minute per 1.73 meters squared, this GFR decreases after every decade. Means in 10 years, you will have this much. So as the age process goes on, the GFR decreases because this is a normal, normal phenomenon. So the most important thing, the driving force for glomerular filtration, we should all know, is the glomerular capillary pressure. And this glomerular capillary pressure again depends on renal blood flow, which has the kidney has the property of auto-regulation of this glomerular blood flow. So globally, or regional decrease in renal blood flow is the final common pathway for acute kidney injury. So the basic, the basic funda behind this is, when the renal blood flow will decrease, it will result in AKI. So we should be knowing the renal insults can be of 3 types, which is pre-renal, renal, or we call as intrinsic, or post-renal. Renal, we can say that, this is pre-renal, which happens, if you see on that picture small there, it is above the kidneys, beyond the kidneys. That means it is somewhere like there is hemorrhage, there is blood loss, or there is some sepsis, there is extravasation of the blood, there is edema and all other things, there is problem with your heart, there is problem in anything. So which will decrease the blood flow of the kidneys, ultimately will result in kidney failure or kidney injury rather than saying kidney failure. So which will cause, as we call it, as perirenal acute kidney injury. If there is some problem with the kidneys itself, like we are giving some patients some contrast materials, or there is acute tubular necrosis in the kidneys, which will ultimately affect the capillary blood flow to the kidneys, which will cause as intrinsic, or post-renal if there is some obstruction. Most common cause, especially in old ages where there are prostate problem previously, they will come with the rising creatinine immediately and with the all decreased urine output. We call it as post-renal. So acute kidney injury, there are so many classifications. The most common classifications which are used as rifle criteria, AKI and rifle, it's the name suggested it, risk, injury, failure, loss, and end stage renal failure. AKI is acute kidney injury network. KidGO, that is kidney disease improving global outcomes. These are the most common classifications which we use usually for these to classify these patients who have acute kidney injury. On that basis, we have, this is a picture taken from Tintinellis, which we have stages all these stages based on urine output and the creatinine level. So if a urine serum creatinine increase 1.5 times, we call, or the urine output is 0.5 ml, which we mentioned by definition, it's stage 1. If it is increased by 2 to 3 times, or the urine output is further decreased, it is called as stage 2, and then stage 3, which ultimately goes to the complete loss of kidney function, or as we call it as end stage, where the patient needs renal replacement therapy. So there are a lot of risk factors for adults, like age more than 65 years, previous history of chronic kidney disease, diabetes, heart failure, history of sepsis, using of some nephrotoxic drugs, which are NSAIDs, AC inhibitors, use of iodinated contrast agents within the past week, oliguria, liver disease. These are all the risk factors. Also, patient with these risk factors we should keep in mind, which we will deal when we are dealing with the management of these patients. So there are kids or young children who have the severe diarrhea, especially bloody diarrhea, some hematological malignancies, signs and symptoms of nephritis, or young age disability, cognitive impairment. We should keep these things in mind, that these are risk factors, these are risk patients, we have to deal with them. So signs and symptoms, which are very important. We should know only few people develop signs and symptoms until and unless they will not develop uremia. Once they will develop uremia, they will show nausea, vomiting, drowsiness, fatigue, evidence of dehydration. They will have reduced urine output, change in the color. They will have thirst. Ultimately, they may become have shortness of breath, confusion, drowsy, and you can go into uremic comas. So again, the signs and symptoms will be on the basis of pre-renal cause. As we mentioned, the patient will come with fever, vomiting, or there may be trauma. We will have, we will have keep in mind, these are something related with the high rising creatinine, which will show that these patients have pre-renal cause specific this. And if it is renal, we will have a patient with post-cardiac arrest. We can say this is ischemic AKI. If we have given some crystals, or my next colleague who is going to discuss with pigment-induced nephropathy, where we have rhabdomyolysis. So all these things you have to keep in mind while taking the history from the patient. And once you take the history from the patient, we should always do the physical examination. As previously we have seen in acute abdomen, we have mentioned that, only history taking is not enough. We have to do the examination. So same is the case with the renal system. We have to do the examination of the renal system, where we have to see whether the patient is having any, how's the volume status of this patient. We have to check the jugular venous distension, whether there's any lung auscultation to see whether there's any pulmonary edema features or not. We have to see whether there's any peripheral edema, mucous membrane to check whether he's suffering from dehydration, which we can check also by skin trigger. Any features of rashes, vasculitis, where we have differentials, whether it is nephrotic syndrome or not. We have to check whether there's any pelvic mass or abdominal distension to see whether the urinary bladder is distended, so that we can have, or there is something which will, some problem with the ureter or the urethra, that means post-renal cause of this acute renal failure. So managing AKI, it has a pharmacological management, relieving obstructions, referral when we have to give the referral, and information and support for the patient. So what can we do is we have to identify the patient, high-risk patients with AKI, especially in the ED. Once we have high-risk patients, which we have discussed in our previous slides, who are the high-risk patients, we have to correct metabolic effects if they have any. If there is ongoing renal injury, we have to stop that, and we have to prevent iatrogenic renal injuries. Patient who is dehydrated, we are not giving the fluids, will be iatrogenic. We are again making them more, or a patient who is known case of CKD, or a patient who has acute kidney injury, and then we are imposing dye or contrast material. So the aim is to correct metabolic effects, decrease ongoing injury, and prevent iatrogenic injuries. So reduce risk of medications which are very harmful for these patients. Then recognize, we have, there are some algorithms and e-alerts especially in the hospital, which are interlinked with each other, like we have here in KSA, we have the hospitals where suppose a patient
If
is
you have
high
1
risk.
minute.
Suppose we have patient who has high risk of AKIs. There are some alerts which are very important. Early recognition of deteriorating patients. Then again, how we respond, we have to see whether it is sepsis, hypovolemia, obstruction, urine analysis, and accordingly we will see whether we need fluids, we need to do the bowel scans, we have to check the urine analysis, and again change high risk medications. So patient information and support, we have to always guide the patients that these patients, they have the long-term effects, not to take these drugs. You have to inform your doctors you are suffering from this part happening with you. That is very important. So take home message, prevention, early identification, and early management are the key preventing an AKI, reducing mortality and length of stay, and improving our patient outcomes. That's it.
Okay, thank you, Arif, for the wonderful presentation. I'll now move on to rhabdomyolysis by Dr. Bhavesh Charwani. Dr. Bhavesh, are you there?
Very good afternoon. Yes, I am here, and allow me to share my screen.
Yeah, please.
Okay. So very good afternoon to all. Firstly, thank you, Dr. Larry, for giving me this opportunity. Dr. Tamorish and all SEMI team, Dr. Srinath, all for giving me this opportunity to talk on this platform. Yes, because of amount of time, I will have to rush through. My topic is rhabdomyolysis. The beautiful hospital that you see is SVP Hospital, where I work. Rhabdomyolysis is a syndrome marked by muscle necrosis, and that is resulting into liberation or release of toxic intracellular material into the circulation. And this material can be myoglobin, aldolase, transaminases, and potassium, and that all ultimately leads to complications that we see in rhabdomyolysis. Now, is it important to talk here in emergency conference about rhabdomyolysis? Yes. Although the data from India is not that available, but in USA, 24,000 footfalls in emergency department are because of rhabdomyolysis, and of which 10 to 20% of patients of ARF are having this rhabdomyolysis will have ARF. So the previous speaker has already talked on ARF lead to from the pigment-induced nephropathy. Yes, so what are the causes or etiological causes of this rhabdomyolysis? Well, it's a muscle injury. So we'll talk about trauma first. Trauma to the muscle and muscle compression. Trauma to the muscle can happen because of crush injury, maybe it's blunt, maybe it's stab injuries. We saw many cases of this kind of cases in earthquake, particularly in the very infamous earthquake of Gujarat, where we saw so many crush injuries because of the earthquake. Other causes of muscle injury are victim of restraint, torture, and child abuse. So always keep in mind, once you suspect a case of child abuse, surgical procedure of prolonged duration, or compartment syndrome, because compartment syndrome will lead to ischemia, and that may lead to rhabdomyolysis. Generally, we measure compartment pressure. If it is more than 30 mm of Hg, then we talk to our residents like that. Other causes of rhabdomyolysis apart from trauma, and maybe more important and more common in certain part of the world, is alcohol and drug abuse, like cocaine and caffeine and heroin. Other causes are medication-induced, like statin, SSRI, and narcotics, to name few, because many of these medicines we use very frequently. And statin is very commonly used in cardiology and other departments. And statin-induced nephropathy, this rhabdomyolysis is not that uncommon, maybe overlooked, and they say it is up to 0.4%. Many times patients are having combination medicines like statin with macrolides, maybe erythromycin, maybe having warfarin, digoxin. So this kind of dual therapies or dual statin itself, that all can lead to or increase the chances of rhabdomyolysis. These were the non-exertional rhabdomyolysis. If we come to the exertional myolysis, the causes of strenuous muscle exercise, those who are poorly conditioned, having less fluid intake, they are wearing very strict clothing or high ambient temperature or high humidity. All these cases can lead to rhabdomyolysis and heat stroke and seizure. There are many causes, but commonly the previously said topics are very common. Otherwise, genetic disorder, immunological disorder like dermatomyositis, polymyositis, genetic disorder of metabolism derangement, bacterial and viral infection are also not common, very, very much uncommon. Insect bite and snake bite, that always should be kept in mind in ED physician, because we come across many snake bite cases here in Gujarat and in, as we know, in South in Kerala. What causes this muscles to lyse? Actually, whenever there is muscle injury, there are injury to this sodium potassium pump and calcium exchangers, and that will lead to increase in the intracellular calcium, and that will lead to the cell death. Apart from that, calcium also activates phospholipase, and that leads to muscle disintegration. Eventually, all these events will lead to liberation of toxic intracellular content in the circulation, and that will lead to the complication. So, what are the clinical presentation? It is acute in onset and include myalgia, stiffness, weakness, low-grade fever, and dark urine. The classical triad of weakness, myalgia, and tea-colored urine, it is not that common, found in less than 10% of the patients, but this classical triad points definitely towards the rhabdomyolysis. We should always keep in mind and having high index of suspicion, because many times patient may not have classical symptoms, but they may have rhabdomyolysis underlying. Like you can see this classical color of urine, it's not dark color, but it's a tea colored, and it is because of pigments. Patient may have tachycardia, vomiting, abdominal pain in very severe cases. Patient may have swelling and tenderness of the involved muscles and hemorrhagic discoloration of the underlying skin. Not that common, but they are there. And last but not the least, as I have also put a red flag sign that it may be present without these classical signs and symptoms, but we have to keep in mind whenever we come across certain history. So history is very important in case of existential as well as non-existential rhabdomyolysis. We have to keep in mind and asking drug-induced and child abuse, maybe malignant neoleptic syndrome, heat stroke. These are the things you have to keep in mind while dealing with this kind of cases. In short, high index of suspicion is required. Otherwise, laboratory investigation, there are very good clinchers with us like CK, creatinine kinase, elevated level is most sensitive and reliable indicator of muscle injury. Although the level varies from laboratory to laboratory and from person to person, but once for that person, if the values are more than 5 times upper limit, then it is definitely a cause of concern and we should think of rhabdomyolysis. Now look at this graph. The CK level starts increasing after say a couple of hours, and then it goes in 24 hours, it is peak, and then it starts going down. Once it peaks, the downtrend is almost 30% per day. If the downtrend is not up to that, then you have to think that muscle injury is still going on. Other enzyme is myoglobin. It has got short half-life. It's cleared very fast from the plasma because of excretion and metabolism. So myoglobin may not be present once patient comes delayedly. But these are very two important clincher for your diagnosis. Other things are urine for myoglobinuria. Whenever there is damage to the muscle in form of more than 100 gram, this myoglobin will come into the urine as well as in the blood. So you have to keep in mind, and certain deep stick tests are there in our emergency department, but they cannot differentiate myoglobinuria versus hemoglobinuria or fresh blood. So in that kind of cases, this qualitative test has to be looked with the peripheral smear of this urine examination, peripheral urine examination. If this dipstick test is positive and the smear doesn't show any blood, then it is myoglobinuria. Apart from that, other laboratory investigation that all residents should send is to know the etiological causes as well as to know the complications. We have to keep in mind the complication while we sending the investigation, like we have to rule out DIC, we have to rule out any potassium, phosphorus, calcium, all the levels should be kept in mind and investigations should be sent. Now, important thing is that on the basis of CK, they have divided that into mild, moderate, and severe rhabdomyolysis. It is important because more than 5,000 CK level is definitely indication for fluid therapy. And more than 14,000 or maybe more than 40,000, there are more chances of acute renal injury. But in the gray area of 1,000 to 50,000, fluid therapy should be given or not. For that, there are many criteria. I will not go in detail because of amount of time, but it is there in the slides. So we have to definitely rule out other differential diagnoses like acute myopathies and certain things. Now coming to the treatment part, as an emergency physician, we are more interested in treatment part than all these previous things like etiologies. Yes, so what is the pre-hospital care? The victim of crush injury or accidental victim with prolonged extrication and a prolonged transport time should be rigorously hydrated on the way. Early and rigorous IV fluid extrication is most important treatment to prevent acute renal failure. Say once limb is extricated, IV saline should be started at 1 liter per hour. And after extrication, IV saline should be continued at the rate of 500 ml per hour, alternate with 5D, 10D or 50D in normal saline at the 1 liter per hour. So that is very important as a pre-hospital care. Otherwise, if pigment nephropathy has set in, chances of more complications are there and patient may end up in dialysis and or more morbid conditions. So, but important is avoid potassium and lactate containing solution, because all these muscle will liberate more potassium and that will lead to cardiac arrhythmias and life-threatening arrhythmias can take place. In ED, once patient arrives, what's your important role for all residents is to continue hydration and continue the fluid at the rate of 2.5 ml per kg per hour to maintain the urine output of 2 ml per kg per hour, at least 200 ml per hour. So here the output is 200 ml per hour. So continue fluid for 2.5 ml per hour for at least 72 hours. Put a urinary catheter because you want to precisely measure the urine output. Now serial measurements of urinary pH, electrolyte, creatinine kinase, and phosphorus, everything is important. Here, creatinine kinase will correlate with the severity of injury, but it will not correlate with the outcome. So it cannot prognosticate on basis of creatinine kinase. So don't do that mistake. However, there are no prospective control trials. They have demonstrated benefit of alkalinizing urine with bicarbonate. Like in my residency, we used to do forced alkaline diuresis or osmotic diuresis with mannitol. But all the prospective trials have said that's not that much of useful, or if you use, has to be very carefully done under experienced person. Because if you're going to do alkalinization, there are more chances of tetany, there are more chances of hypernatremia. So osmolarity has to be maintained. If you are giving mannitol, if patient is dehydrated, it is counterproductive. So mannitol or this alkalinization of urine are not that importantly proven. If you try, you have to be very cautious and experienced in that. So I was saying, like, these are the scoring system that can help you to give fluid in between the 1000 or 500 CK level. If CK level is more than 5000, you have to give fluid therapy rigorously. If it is less than 1000, no need. But in between to 5000, these are the scoring system that is there. It may not be that much of useful. We generally go as per our clinical experience in the patient's condition. So there's a couple of last slide, like say patient has come with this 5000 or more, give fluid and then correct the electrolyte imbalances. Complication you all have to keep in mind, like acute renal failure, anticipate with a rise of serum potassium and the creatinine level, metabolic derangement, disseminated intravascular coagulation can be there, have to rule out, or nerve injury because of mechanical complication, compartment syndrome. There can be proximal nerve involvement as well. So that is a morbid condition you have to keep in mind. Renal tubular obstruction because of precipitation of the pigments into the distal tubules is also a possibility. So keep in mind. And that was the reason that alkaline diuresis was used to not to have this coagulation, not to have this kind of obstructions. Now, many people think that, well, what is the role of calcium? Generally, calcium is initially, it goes intracellularly, so there are less calcium, but gradually, and apart from that, calcium and phosphorus bind to the necrosed muscles as well. So calcium may be low, but if it is not alarmingly low, don't give it. Likewise, in later part of management, calcium will be high. If it is again not very high, don't treat calcium, don't chase it. For hyperphosphatemia, again, initially there will be, deposition of calcium and phosphorus to the necrosed muscle, but if it is not alarmingly low, say less than 1, so don't give it. So as for hyperphosphatemia, hyperkalemia is very important because life-threatening condition. Now, how will you treat hyperkalemia? You have to treat with generally in other condition we give glucose and insulin drip. Here generally potassium binding resins are giving better result than the glucose insulin drip, so that should be the first priority. And if not, then dialysis should be at hand. And also avoid prostaglandin inhibitor because, as I said, it is chances that it may aggravate the renal tubular. Yeah, last slide. So these are the references, and again, thank you very much for giving me this opportunity, and I am open to questions. Thank you.
Thank you, Dr. Bhavesh. I like your presentation as well as your hospital. It's really very, very interesting and useful. We'll have the question and answers in the end. Now I'd like to invite Dr. Ankur Verma. Ankur, are you there?
Yes, I'm here.
Okay. Okay. So this is going to be another very, very important topic for residents. Torsion testis and torsion ovary both are very, very time-sensitive emergency. And over to you, Ankur.
I'll just share my screen. Thank you. I hope everybody can see my slides.
Yes, yes.
Yeah. So thank you so much. And I must commend SEMI West Bengal chapter on organizing this Semicon 2022. Very well done. And today I'll be talking about torsion testes and ovary. This is something which is very, very important, as these two are the most common pitfalls in emergency medicine. If you misdiagnosing them, it can be life-threatening as well as life-changing for the patients. So it's not going to be a very long presentation. I'll just get to the point and finish it off as quickly as possible so that you guys can go back home. Oh, you're already at home. So like we mentioned, Dr. Kole also mentioned that these two are very time-sensitive diagnosis, right? So it's been seen that testicular torsion has a greater than 90% salvage rate if it is operated within the first 6 hours of symptom onset. Now, after 6 hours, there is a time-dependent increase in the rate of testicular atrophy and orchicectomy, right? So in the causes, in the cases of failed salvage, 30% is because a diagnosis is missed and 13% is because of delay in the treatment. So it's very, very important that you diagnose quickly and then you push your patients to the OT as quickly as possible. If we look at the anatomy of the testes, so you have the testes, you have your epididymis, you have the tail, you have the spermatic cord, the cremaster, you have the tunica vaginalis, and the appendix of testes and of the epididymis. Now, what exactly is testicular torsion? It is the twisted spermatic cord, which leads to venous congestion, reduced flow in the testes, and then finally ischemia, right? So you have two types of testicular torsion, extravaginal and intravaginal. Now, the extravaginal torsion basically occurs in the perinatal period, and it occurs with the twisting of the entire tunica vaginalis. You know, it may also present as a vanishing testicle or painless swollen hemiscrotum. And intravaginal torsion is basically the twisting inside the tunica vaginalis, which occasionally is as a result of a congenital bell clapper deformity. Now, this deformity occurs when the testicle is not fully fused to the posterior scrotal wall, and this results in the testicle being suspended horizontally, which predisposes it to torsion. Now, usually it is said that testicular torsion happens in 2 peaks, in the first year of life and during puberty, but remember, it can actually happen in any age, right? Patients would usually present to you with acute onset of scrotal pain, a lot of nausea and vomiting. Now, in the setting of acute scrotal pain, systemic symptoms like nausea and vomiting actually make testicular torsion a more likely diagnosis, right? Some of the causes are basically minor trauma and testicular and during testicular growth, but a lot of patients have been seen to present with testicular torsion after a good night's sleep. So do not think a patient cannot have testicular torsion if they have not given you a history of minor trauma or any trauma as such. Now, multiple studies have shown that an abnormal cremasteric reflex and a high position of the testes is more commonly found in patients with testicular torsion. Now, obviously, everybody knows what a cremasteric reflex is, but it is basically defined as an ipsilateral elevation of the testicle after stroking of the medial thigh. Now, as residents, you all should know this, how to examine for testicular torsion, right? So if there is an absent cremasteric reflex, torsion is the most likely diagnosis. However, if it is present, that does not rule out testicular torsion. So again, it has a rule in probability than a rule out probability, right? Patients will usually have an anterior epididymis, might walk with a wide-based gait, and the history and the exam have to be correlated together to come to a clinical diagnosis of testicular torsion. So the TWIST score was published in 2016, which basically stands for Testicular Workup for Ischemia and Suspected Torsion. and where the history and physical presentation is very important. So you have points for testicular swelling, for a hard testicle, for an absent cremasteric reflex, nausea and vomiting, and a high riding testicle. And if you have a score of 7 points, that is 100% sensitive and specific for testicular torsion. So that is a good tool that can be used in your EDs for working up a testicular torsion. Now for diagnosis, everybody knows this, ultrasound is the diagnostic modality of choice when evaluating a painful scrotum, right? It has a sensitivity of above 96% and a specificity of 97%, a positive predictive value of 92% while having a negative predictive value of 99%. Now on ultrasound, when you do a bedside ultrasound, a grayscale would show a mildly heterogeneous left testis, as we can see over here, and it has reduced color flow and a bulky and congested epididymis and mild hydrocele. These are the findings that can be seen on an ultrasound. Now in this one, you have the left testes and the right testes over here. So in the left testes, there is high, if you can see the waveforms, there is high resistance flow in the left testes. And while in the right testes, you have a normal low resistance flow. So obviously in the left one, there is a reduction in the testicular blood flow. If you see this video, there is something called a whirlpool sign. So when you put your probe on the spermatic cord and there is a torsion, you can see that there is a whirlpool sign which comes on. So that is diagnostic of a testicular torsion. So your ED management would obviously entail appropriate analgesia. You might require procedural sedation and need to do manual detorsion. And then the patient needs to be sent for an orthopexy to the OR while involving the urologist. Right? Everybody knows how to do a manual detorsion. It is basically an open book technique where you twist or de-twist the testes from the medial towards the lateral side, just as you open a book. Even if you've done this, you need to get a Doppler done quickly and send the patient to the OR. If there is time being taken to do a Doppler, you do a manual detorsion and you push your patient towards the OR for the urologist to take care of it in the OR. Now, moving on to ovarian torsions, it is a gynecological emergency, as everybody knows, and it has an incidence rate of 3% in all gynec emergencies. Again, it is a pitfall. It needs to be diagnosed and it needs to be managed appropriately. Right? Most of the patients, they present with unilateral pelvic pain, and 1 in about 1,800 pregnancies can get complicated due to these adnexal torsions. Now, ovarian torsion is basically the twisting of the ovarian vascular pedicle, as seen over here, which causes obstruction to the venous outflow and the arterial inflow, and it is most often associated with a benign cyst or a tumor, which causes partial or complete rotation. So I am pretty sure everybody's heard the discussion that Dr. Larry had earlier, where they had a patient who had an ovarian torsion, came in with lower abdominal pain and was also diagnosed with a mass. So how to diagnose an ovarian torsion? Obviously, your clinical examination and your history is very important. Examination will have probably a lower abdominal tenderness, but not much as such. Ultrasound is the initial best modality. It is not the diagnostic tool of choice, but ultrasound and CT both have high rates of false negatives. Right? But what is usually seen in ultrasounds are that you might find an enlarged ovary, you might see a mass, you might see free fluid, or you might see a rotated pedicle. This holds true for CT scans also. Now, if you do an ultrasound, so in this you can see in the right ovary, you can't see the blood flow properly, while in the left ovary there is good blood flow. There's enlargement of the right ovary also in this one. If you see the video in this, there's an absence of color flow signals in this right ovary. It's not flowing properly. So Doppler is important. You can also get a CT scan done. Now, in this case, you can see that the right ovary is quite enlarged. It is heterogeneous in structure with a cystic mass peripherally located and has a lot of follicles also. Large cystic mass is also seen and a small amount of free fluid is found in the pelvis. So I'm pretty sure this is close to what Dr. Larry was discussing earlier. Obviously, you need a rapid evaluation in the ED for such patients. You need rapid diagnosis. You need to get an early gynecological consult. Of course, do not forget appropriate analgesia for such patients, as they might have a very, very high pain score. And they usually end up having a resection in the OT, or they can also do a detorsion surgery in the OT, depending on the clinical scenario and the age of the patient. So the final take-home points for testicular torsion and testicular and ovarian torsion are that you need to have a high index of suspicion. Do not forget your genitourinary exams. Do not delay your diagnosis. Shift the patient to the OT as soon as possible, and be the advocate for your patient. A lot of other specialties might delay treatment for this for patients of torsion and testicular torsion and ovarian torsion, but you need to push your patients as emergency physicians, and you need to be the advocate for your patient. Thank you so much. Do follow the Desi EM project on Spotify, Apple, and Google and Anchor. This is the first EM podcast from India, and I hope you guys enjoy listening to it. Thank you so much.
Thank you, Goel. We'll pass on to the question answer session. We had three very, very important topics as far as resident education is concerned: acute injury, rhabdomyolysis, and torsion testis and torsion ovary. Do you have any questions? Sorry, my video is disabled by the host. I can't switch on. There's something wrong. But there's a very important topics we are discussing. So any questions from chat box? Okay, so I think one of the things which came to my mind for Dr. Jarwani is often we see patients coming late and presenting with rhabdomyolysis from smaller setups, nursing homes and things like that. And suddenly they come to ER, and we realize that the patient is already started having rhabdomyolysis, especially post-burn and those kind of scenario. What as an emergency physician we should do?
Well, as in the slides was said, important thing is you have to see that hydration is maintained well and potassium is controlled, and CK level, if it is again rising, that means still necrosis is going on. So these three are parameters. These three are under control, then I think is not much worried.
Right. Okay, that's very helpful. Arif, you have shown some of the scores and scales to quantify acute kidney injury.
Yes, sir.
And there is always this battle between radiology and emergency medicine and acute kidney injury and need for contrast CT in emergency patients. What is your take? What is your advice for the residents?
For the residents, look for the scoring system. If you have patient with the high scores and you find that he's having acute kidney injury, again, if the life-saving or limb-saving, we need the contrast, we should proceed with that rather than delaying with this, because there are other modalities where we have, treatments which we can prevent for further injury of the kidney by giving extra IV fluids or other things. But limb-threatening or life-threatening, we should proceed with contrast materials. There's a good debate on other topic, which is a patient who is having on metformin and giving contrast materials. So on that also we have, there are now American Radiology Association, they have told that if the creatinine is less than 30, and at that point we have to stop the metformin, and then after that we have to wait for 48 hours, then on, so we can check the creatinine level. If it is more than 30, we can go ahead with the contrast, not to worry at all.
I'd just like to add to this discussion. So the dyes used these days in radiology usually do not cause contrast-induced nephropathy. And if you have a good nephro backup, we've had quite a few patients where we've given them contrast and under the NAC and fluid cover, and then planned for dialysis if required. So, I mean, a lot of CKD patients who come in who require contrast CTs, they usually get, dialyzed post the procedure. And we've also followed a lot of our patients who had acute kidney injuries and required contrast CTs, but their urea and creats were followed over the next few days, and they were absolutely stable. So there's a lot of studies which have come out that which actually say that contrast-induced nephropathy in today's date is now a myth. And you can safely
right.
do.
Yeah, I was coming to that NAC and fluid, but you mentioned it. That's very important for ER physicians. And the bottom line is that you don't delay an investigation which can change the outcome or which can change the decision. You have to go ahead and do it. And as Ankur said, we have to be always the advocate of patients. Ankur, I don't have any questions for you, but I would like you to speak a little bit about your new project, the CEM, and how it is helpful for the residents and all of us maybe.
So thank you. So yeah, this is a baby that I delivered in December 2021. I learned from some of the stalwarts of podcasting, emergency medicine podcasting, like Simon Carley, Rob Rogers, Scott Weingart. I'd worked with them in 2015 and learned a lot from them. And yeah, so once I was confident enough and thought that this is going to be a good thing, not just for the Indian emergency medicine specialty, but also for the Indian public who actually don't know what emergency medicine is all about and how to judiciously use the resources that we have. I thought might as well just jump into it and see how it goes. So yeah, I've started off. I do an episode every 2 weeks. It's available on Spotify, Apple, Google Podcasts, even on Anchor. I usually put in the resources also, and everybody can just follow it on Spotify. Ask your residents to follow it also. The more people we have, the more people will again join, and there'll be a lot of topics which will be discussed, which will also be interesting for the general public per se. So that'll be good, and I'll have a lot of guests, all of you. Slowly I'll be calling you all, and we'll do a lot of collabs for the CM project. So show it some love and follow it. Thank you.
Definitely.
It's a great project. Thank you, Ankur. Thank you, everyone, for all of your time. Sir, we'll go to the next session.
Yes, please. The next session is on infectious disease, I guess. Okay, I guess time for infectious disease, and we have two speakers, I guess, in this session. First, we have Dr. Rohini Malhotra. Dr. Rohini Malhotra is working as the head of emergency and quality care management at Gratian Hospital in Mohali, Chandigarh. And she is going to talk to us on triage rules for sepsis patients. Which one is the best? What to you, Dr. Rohini?
Yeah, good evening, sir. Good evening, organizing committee, scientific committee, my seniors, colleagues, and all the residents over there. So my topic of discussion is triage rules for sepsis patients. Which one is the best? So I'm going to discuss about the what is sepsis and history behind new definitions, epidemiology, high-risk patients, and warning signs of sepsis, triage rules for sepsis, the scoring system, and latest guidelines of sepsis, including COVID-19 sepsis. In 1991, ACCP and SSCM emphasizes that sepsis was an ongoing process, and SARS, sepsis, severe sepsis, septic shock, and mods began to use in clinical practice. Sepsis was defined as identification of two or 2 or more SIRS criteria in addition to known or suspected infection, while severe sepsis was defined as clinical sepsis accompanied by organ dysfunction, hypoperfusion, and hypotension. In 2001, Consensus Conference proposed a new term for sepsis, which was described as a clinical syndrome combined with organ injury. This conference did not make a corresponding division to the definition of sepsis, so similar characteristics of two definitions made a confusion of sense to diagnose sepsis by new diagnostic criteria and severe sepsis by the old diagnostic criteria. This high-level disagreement led to the question of updation of the definition of sepsis. So it was published in February 2016, which emphasizes on organ dysfunction, considers the fact that SIRS criteria may change depending on many factors in ICU, and SIRS has low sensitivity and specificity in discriminating sepsis and non-complicated infections. New definitions, the new recommendations defines sepsis as a life-threatening organ dysfunction due to dysregulated host response to infection. The new definitions reflects considerable advances made in pathophysiology, management, and epidemiology of sepsis. They offer more specificity. This table showing the difference between older definitions and newer definitions. In older definition, in sepsis 1, SIRS criteria were used, and in sepsis 2, diagnostic criteria for sepsis was infection documented or suspected and is for some of the following general parameters like fever, hypothermia, tachycardia, altered mental status, hyperglycemia, etc. So in newer definitions, in sepsis 3, quick SOFA was introduced. I'm going to discuss all these in detail later. So each year accounts to the Center for, each year according to the CDC, at least 1.7 million adults in the US develop sepsis and nearly 270,000 die as a result. The WHO finds that the efforts to tackle millions of deaths and disabilities due to sepsis is hampered by serious gaps in knowledge, particularly in low and middle income countries. Anyone affected by an infection, severe injury, or serious non-communicable disease can progress to sepsis, but few population is at high risk, including elderly patients more than 65 years of age, pregnant women, neonates, hospitalized patients in ICU, and patients with liver cirrhosis, cancer, kidney disease, autoimmune diseases, etc. So if in emergency, patient is coming and complaining of combination of the symptoms like fever with chills, extreme pain, discolored skin, I feel like I might die, and patient is complaining of shortness of breath and is confused, is seek immediate medical care. So triage to the emergency department is the most critical time in identifying of evolving severe sepsis and is the first part of differential diagnosis. The emergency department is a first line of defense in the fight against sepsis. So triaging is very important. 2 out of 3 and 56% of severely septic patients entered hospitals through the emergency department, and 35% mortality observed for severely septic patient identified in the emergency department. It is an acute medical emergency. It is as important as a case of polytrauma or any other cardiac or neurological emergency. By scoring system, it was introduced to predict organ dysfunction and mortality better. So code sepsis, it is designated, it is designed to facilitate early recognition of severe sepsis in emergency patients and then rapidly deliver a bundle of care, including drying a lactate level, obtaining blood cultures before antibiotics, and giving antibiotics within 1 hour and IV fluids within 1 hour. SIRS criteria, 4 SIRS criteria were defined, namely tachycardia, tachypnea, fever or hypothermia, leukocytosis, leukopenia or bandemia. Patient who met 2 or more of above criteria fulfilled the definition of SIRS. SIRS is non-specific and can be caused by ischemia, inflammation, or several insults combined. Thus, SIRS is not always related to infection. Then the introduction of SOFA was introduced, and it is a score system that assesses the performance of several organ system in the body, like respiratory, cardiovascular, liver, renal, coagulation, and neurological. According to sepsis 3, a new score above baseline in the presence of infection makes the diagnosis of sepsis. Who is using SOFA now? It has been recommended along with a less validated, more clinical tool called Quick SOFA for assessment of patients with sepsis. While the clinical utility of SOFA in daily practice is unproven, many states have included SOFA in their crisis standards of care plans as an element of triage framework. Advantage of using SOFA for triaging, it creates a standardized numeric score that is familiar to critical care physicians. Physicians can use it to compare patient status, and score has been shown to have a significant correlation with outcome in certain conditions. Of the scoring system available, SOFA achieves a good balance between easily available data and good prediction. So what are some challenges with using SOFA triage? It was developed to be used with the population, and though it is good at determining overall mortality, the score cannot predict individual mortality well. So SOFA score in primary respiratory failure are usually low and therefore will not assist in the triage process, as in COVID-19 sepsis. QSOFA score is a bedside prompt that may identify patients with suspected infections who are at greater risk with a poor outcome outside the ICU. It uses 3 criteria, assigning 1 point for low BP, respiratory rate, high respiratory rate, or altered mentation. The presence of 2 or more QSOFA points near the onset of infection was associated with a great risk of death or prolonged ICU stay. So Semur and colleagues tested the construct and criteria validity of QSOFA compared to other criteria near the onset of infection. They found that mortality increases among patients with suspected infection with each point. So there are many modified early warning scores and newly early warning scores. They were actually developed for nursing people, and it was developed by Royal College of Emergency Physicians. Spot sepsis it consists of a vital signs criteria like systolic BP, shock index, and triage concern for infection. Triage concern criteria is based on the patient's presenting complaints and past medical history. It does not require diagnostic testing. Many biomarkers are used for point of care testing in the diagnosis of sepsis, like procalcitonin, CRP, interleukins, and many CD4 markers. So what about lactate? It is a well-studied prognostic marker in patients with sepsis. During statistic model building, lactate was excluded from QSOFA. Again, Sumer and colleagues tested how serum lactate would improve QSOFA post-hoc using a variety of serum lactate thresholds. They found that the criteria validity was statistically improved comparing QSOFA plus lactate versus QSOFA alone, but actual changes in classification were minimal. So there is comparison of various screening tools for sepsis. So SIRS with high sensitivity but very low specificity, it can be expected to generate many false positivities. QSOFA is incorporated into sepsis 3 and it has better specificity than SIRS but sacrifices some sensitivity. So early warning scores incorporate into many hospitals as a part of rapid response system, but they require computation of a score at bedside, which may limit their feasibility. Many computerized algorithms use many parameters to enhance sensitivity and specificity of detecting patient at higher risk, but their complexity may require specialized informatics and support for practical implementation. Surviving Sepsis Campaign 2021 updates. It strongly recommends using a performance improvement program for sepsis, including sepsis screening for acutely ill, high-risk patients and SOP for treatment. It strongly recommends against using QSOFA compared with SIRS, NEWS, MUSE, or a single screening tool for sepsis or septic shock. It strongly recommends, if sepsis is definite or probable and sepsis is possible, administer antimicrobials immediately, ideally within 1 hour of recognition. It strongly recommends usually use of norepinephrine as first-line vasopressors and maintain a target MAP of 65 mm of mercury. So sepsis is always the result of an infection, be it from a wound or an illness. This is usually a bacterial infection, but can also be viral, such as COVID-19. So Surviving Sepsis campaign has updated previously released guidelines on the management of critically ill adults with COVID-19. In the newly 9 updates for treating severe or critical COVID patients, the panel strongly recommends using systemic corticosteroids and venous thromboprophylaxis, and strongly recommends against using hydroxychloroquine. In addition, the panel suggests using dexamethasone compared with other steroids and suggests against using plasma outside clinical trials. The SSC COVID-19 panel suggests using in remdesivir in non-ventilated patients with severe COVID-19 and suggests against starting remdesivir in patients with critical COVID-19 patients outside clinical trials. Because of insufficient evidence, the panel was not able to issue recommendations on the use of awake-prone positioning and empiric therapeutic anticoagulation. Thanks for the opportunity.
Thank you, Rohini. That was very useful. We will pass on to Dr. Lakshmi. Now, I think this is going to be the last talk of today, and then we'll have questions and discussions. She's going to talk on early management of suspected sepsis in emergency department. Dr. Lakshmi, are you there?
Yes, I'm there. Just
Dr. Kole, Dr. Abhishek is ready actually. Post Dr. Lakshmi Sri, after Dr. Lakshmi Sri.
Okay,
Dr.
fine, he can.
Okay,
No
we'll
issues.
bring Abhishek back after Lakshmi.
Yes, yes, yes.
No, I'm trying to share. Can you go ahead with his thing otherwise?
Dr. Lakshmi, actually there is some technical issues. They're getting in contact with you. Okay.
Okay.
They'll be in touch.
Hello.
Hello, ma'am. Okay, can I start? Okay. Yeah, is it good to go? Am I good to go?
Yes, you are audible, doctor.
So sorry, there was some technical glitch. So yeah, hello everyone. It's good to have me on this platform. Thank you, SEMI West Bengal, for this. And a very good evening to all the delegates and faculty members and to all the resident doctors out there. So today, my topic is early management of suspected sepsis in ED. So yes, sepsis is a global burden because sepsis is a syndromic response to infection and is frequently a common pathway to death from many infectious disease worldwide. The global burden of sepsis is difficult to ascertain, although a recent scientific publication estimated that in 2017, there were almost about 50 million cases and 11 million sepsis-related deaths worldwide, which about accounted for 20% of all global deaths. Significant regional disparities in sepsis do exist, and it's approximately about 85% of sepsis cases and sepsis-related deaths worldwide occurred in low and middle income countries. Sepsis can be the clinical manifestation of infectious acquired both in community setting as well as in healthcare setting as well. The definition of sepsis, which was clearly emphasized earlier by Dr. Rohini earlier in her presentation, it has evolved basically. The definition of sepsis has evolved over the years with terms such as SARS, sepsis, severe sepsis, and septic shock. In 2016, the Sepsis 3 Committee 8 issued the following definitions, such as sepsis is a life-threatening condition caused by a dysregulated host response to infection and resulting in organ dysfunction. Whereas septic shock, it is circulatory, cellular, and metabolic abnormalities in septic presenting as fluid refractory hypotension requiring vasopressor support with associated tissue hypoperfusion. And the classification of severe sepsis was eliminated eventually, and therefore multiple definitions created a lot of confusion. So therefore the Sepsis 3 also derived a bedside assessment tool for sepsis screening in patients with infection who are not in intensive care units. That is called the Q-SOFA and the SOFA score. SOFA is an objective scoring system to determine major organ dysfunction based on oxygen, platelet count, Glasgow Coma Scale, bilirubin and creatinine level, and the mean arterial pressure. Whereas the Q-SOFA score, it has 1 point for each of 3 criteria, that is respiratory rate more than 22 breaths per minute, altered mental status, and the systolic blood pressure less than 100 mmHg. A Q-SOFA score of more than 2 is suggestive of sepsis. And sepsis recommends that for a Q-SOFA score less than 2, the full SOFA score, including the lab results, should be used. The initial management of sepsis. Well, the first thing is suspecting sepsis is the first major step towards early recognition and diagnosis. Identifying and not underestimating the signs and symptoms, along with the detection of some biomarkers such as C-reactive protein and procalcitonin, are crucial elements for early diagnosis of sepsis. Stabilizing respiration by supplemental oxygen should be monitored continuously with pulse oximetry. Intubation and mechanical ventilation, which may be required to support the increased work of breathing that typically accompanies sepsis. The venous access should be established as soon as possible the patient comes to the ED, while a peripheral access may be sufficient in some patients, particularly for the initial resuscitation to start your IV fluids and antibiotics. But most of the patients, however, land up with a central line. The initial investigations, the brief history and examination, as well as the lab and microbiological cultures and imaging studies, they're often obtained simultaneously as the airway is secured. Then quickly obtain the blood labs, preferably within 45 minutes of presentation of the patient to the ED, but should not delay the administration of IV fluids and antibiotics. Complete blood counts with differentials, LFTs, coagulation studies, including D-dimer levels. Results from these studies may support the diagnosis, indicate the severity of sepsis, and provide baseline to follow the therapeutic response. Serum lactate. Well, a serum lactate more than 2 millimole per liter or greater, it indicates the severity of sepsis, and it is used to see if the septic patient is responding to your therapy or not. Peripheral blood cultures, yes, you need to obtain them along with urine analysis, and microbiological cultures from a suspected source should be collected. Drawing blood from cultures through an indwelling or a central intravascular catheter should be avoided whenever possible, since ports are frequently colonized with skin flora, thereby increasing the likelihood of false positive blood culture. Procalcitonin, while the diagnostic value of procalcitonin in patients with sepsis is poorly supported by evidence, but its value in de-escalating the antibiotic therapy is well established in septic patients. Well, the cornerstone of initial resuscitation is the rapid restoration of perfusion and the early administration of antibiotics. Empiric antibiotic therapy is targeted as the suspected organisms and sites of infection and preferably administered within the first hour. Tissue perfusion is predominantly achieved by the aggressive administration of IV fluids, usually which are crystalloid. It is given at the rate of 30 ml per kg, started by within 1 hour of the patient's entry into the ED. The EGDT goals, the components of the protocol usually include the early administration of the fluids and antibiotics using the following targets to measure the response. That is the central venous oxyhemoglobin saturation, that is SCVO2, which should be more than 70%, central venous pressure, which is 8 to 12 mmHg, mean arterial pressure more than 65 mmHg, and urine output more than 0.5 ml per kg per hour. Intravenous fluid, yes, within the first 3 hours, the patients in sepsis or with septic shock, they require rapid fluid resuscitation, which is about 30 ml per kg, which was already discussed. And the choice of fluid, it is evidence from randomized trials and meta-analysis have found that there is no convincing difference between using albumin solutions and crystalloid solutions. But in general, in everyday day-to-day practice, we generally use a balanced crystalloid solution or normal saline instead of albumin. And identification of suspected source, like an additional diagnostic testings or interventions, may be required to identify the anatomic site of infection, especially in closed compartment. The needs to be drained or debrided. And timing, once a presumed diagnosis of sepsis or septic shock has been made, optimal doses of appropriate intravenous antibiotic should be initiated, preferably within 1 hour of presentation. Now, choosing a regimen, the choice of antimicrobials can be complex and should consider the patient history, the comorbids, immune defects, clinical context, and the presence of any invasive devices, gram staining data, and local preservance, and of course, your hospital policy. And antimicrobials should be tailored according to each individual. Coverage should be directed against both gram-positive and gram-negative, and if required, against fungi, especially in immunodeficient patients, but rarely against any viruses. However, when the organism is unknown, the clinician or the emergency physician should be mindful of other potential pathogens with risk factors are present and consider the following, especially if you are treating an MRSA organism. There's a growing recognition that MRSA is a cause of sepsis, not only in hospitalized patients, but also in community, and having indwelling catheters or indwelling methods for some reason. And in such cases, IV vancomycin adjusted to renal function is ideal, particularly in those with septic or septic shock. And if Pseudomonas is an unlikely pathogen, you can combine vancomycin with one of the following. It could be a 3rd generation or a 4th generation cephalosporin, a beta-lactam inhibitor, or a carbapenem is indicated. Alternatively, if Pseudomonas is a likely pathogen, combining vancomycin with any of the anti-pseudomonal cephalosporin or carbapenem, anti-pseudomonal beta-lactamase, or aminoglycoside is also recommended. For non-pseudomonal gram-negative organisms such as E. coli and Klebsiella, which are also very common among the population and patients with suspected gram-negative pathogen, use of a single agent efficacy and the least possible toxicity, except in patients who are either neutropenic, is recommended. For invasive fungal infections like Candida or Aspergillus, or if the neutropenia is present, and antifungals such as echinocardin or varicozole can be used accordingly. After fluid and empiric antibiotics have been administered, the therapeutic response should be assessed frequently. For this, clinical, hemodynamic, and lab parameters are suggested. Clinical, all patients should be followed clinical for improved mean arterial pressure, urine output, heart rate, respiratory rate, skin color, temperature, pulse oximetry, and mental status, which can easily be done bedside. Among these, MAP of more than 65 mmHg and urine output more than 0.5 ml per kg per hour are the most important and the common targets which we usually see in patients. And for hemodynamic parameters, static or dynamic predictors of fluid responsiveness should be employed in order to determine. In static, we traditionally see, in addition to the MAP, we see the CVC measurements which are used to determine whether the fluid responsive is there or not. The CVP at the target of 8 to 12 and SCVO2 more than 70%. In dynamic, we have a couple of parameters such as respiratory changes in the vena cava diameter, radial artery pulse pressure, aortic blood flow, peak velocity, and left ventricular outflow. These are the parameters which can easily be measured. Now, coming to the lactate clearance, although the optimal frequency of measuring serum lactate is unknown, but serum lactate, which is usually measured every 6 hours in patients with sepsis until the lactate value has clearly fallen, is recommended. The lactate clearance and interval change in lactate over the first 12 hours of resus has been evaluated as a potential marker for effective resuscitation. Intravenous vasopressors are useful in patients who remain hypertensive despite giving the fluid challenge, or people or patients who develop cardiogenic pulmonary edema. Norepinephrine is the drug, although guidelines suggest additional agents such as vasopressin or epinephrine can be used. However, the initial choice of vasopressin in patients with sepsis is often individualized and determined by additional factors such as if the patient is in cardiac failure or having any arrhythmias or organic ischemia. Additional therapies such as glucocorticoid, inotropic agents, or red blood RBC transfusions are not routinely warranted in patients with sepsis or septic shock, but the use of these therapies may be useful in refractory cases of septic shock or in special circumstances. The other supportive therapies such as blood product infusion, nutrition, stress ulcer prophylaxis, neuromuscular blocking agents, venous thromboembolism prophylaxis, intensive insulin therapy, external cooling or antipyretic measures, mechanical ventilation, all these therapies are additional supportive therapies which can be addressed after the initial resuscitation. Well, to summarize, for patients with sepsis-induced hypoperfusion or septic shock, kg of IV fluid should be given within the first 3 hours of resuscitation. Administering antibiotic is ideally within the 1 hour of recognition, and there is insufficient evidence to make a recommendation on the use of restrictive versus liberal fluid strategies in the first 24 hours of resuscitation in patients with sepsis and septic shock who still have signs of hypoperfusion and volume depletion after the initial resuscitation. For adults with sepsis-induced hypoxemic respiratory failure, the use of high-flow nasal oxygen over non-invasive ventilation is suggested. And for patients in septic shock, using IV vitamin C is not recommended. And for adults with sepsis or septic shock, the families offering written and verbal sepsis education prior to hospital discharge and the following setup is very important. Well, thank you.
Thank you, Lakshmi. That was a very good and up to the point presentation. Before we move on to pancreatitis, let's discuss a few things if there are any question on the infection. So we had two presentations. One is triage rule for sepsis and one is early management of sepsis. Do you have any questions? Okay, if not, then I have a small query with Lakshmi about the antibiotic timings. You know, it keeps this, there is a lot of, you know, push and pull on antibiotic timings. And often many people complain that, you know, although there is a guideline in busy departments, there is a delay in antibiotic, there is a delay in choosing antibiotic and things like that. So how to overcome this problem?
I think for this common problem, which I think every emergency physician working in any hospital setup has faced, the first important thing is to have a antibiotic policy according to your hospital guidelines or according to your hospital policy, so that any patient with suspected sepsis or confirmed sepsis arrives at the ER. So we have an antibiotic policy as well as a sepsis protocol in hand. So I think as the heads are working in any senior positions, I think that's an important thing. So we do not have to always fight to give the antibiotic within the first hour. So if everything is written on the paper and do we have a policy in hand, I think that should help and suffice the thing.
Right, right. I think it's helpful. And Rohini, you spoke about the triage guidelines, triage rules. Now, can we do something in the pre-hospital setting before the patient comes to the emergency department? Can we teach our paramedics a little bit of sepsis triage and bringing the patient as soon as possible?
Yeah, sir, I think the scores like Muse News, which was updated by UK membership of College of Physicians, were good to use as pre-hospital at pre-hospital settings, because those scales are basically mainly on vital signs, and we can also use quick SOFA rule as a screening tool in pre-hospital settings also, because we can at least we can check with the vitals and predict the sepsis process and mortality further.
Okay, thank you. That's very helpful. So thank you both for presenting this. And we move on to the last speaker, actually, who was busy due to his clinical responsibilities. So can we bring back Abhishek? Larry, can you bring back Abhishek?
Yes, sir. He will be live with.
I can see him now. Yes. So Abhishek Chatterjee, Dr. Abhishek Chatterjee is at National Hospital in Durgapur in West Bengal. He is heading the emergency department as well as he is the medical superintendent, also the secretary of the SEMI West Bengal chapter. and he's going to speak on pancreatitis, the recent guideline.
See my slides. I'm unable to see my slides. Please share my slides. Yeah, it's not visible. Next slide, please. Hi, everybody. Am I audible?
Yes.
Yeah. So I'll be just going through the pancreatitis new guidelines. Some policy statements are there. That just I'll go through those statements. So please change the next slide, please. Next slide. Next slide, please. Yeah, the presenting features, like in the pancreatitis, patient will be coming to us with severe abdomen pain. To be precise, it will be like a shooting pain, and the patient will also have symptoms like nausea, vomiting. Patient will be tachycardic with low grade fever. There may be guarding, and patient may also have low bowel sound, or may present with jaundice. Next slide, please. Although most of the patient with pancreatitis will be presenting with the mild form of the disease, but from 20 to 30% may come with severe form. Often it will be associated with single or multiple organ failure and may require intensive care. Next slide. The infected pancreatic and pancreatic necrosis may occur in the 20 to 40% of the patient. They may come with severe acute pancreatitis with worsening organ dysfunctions. Next slide. It is an inflammatory condition, most commonly caused by the bile stone or excessive use of alcohol. The disease may take the mild course, where the moderate fluid resuscitation, management of pain, and dietary changes may clinically improve their course of treatment. Next slide. Next slide, please. In the next slide, please. Yeah, coming to the classification. One of the classification is the to mark the pancreatitis is the Atlanta cross classification, where the peripancreatic collections associated with necrosis are acute necrosis collection, that is ANC, and walled off necrosis. The acute necrotic collections is a collection seen during the first 4 weeks and containing a variable amount of fluid and necrotic tissue, which involves the pancreatic parenchyma or peripancreatic tissues. And walled off necrosis is mature encapsulated collection of the pancreatic or the pancreatic peripancreatic necrosis with well-defined enhancing inflammatory wall. The maturation from the symptoms to the maturity of those pancreatitis usually takes 4 weeks or more. Next slide, please. severe acute pancreatitis have changed the clinical practice at present. Early internal feeding, like changing the diet habits and prophylactic antibiotics, avoiding initial surgeries in the initial day, and with the patient with sterile necrosis have and go conservative approach to the necrosis have and with delayed intervention have made the treatment a change bit. Next slide, please. Now, the grading the recommendations. This is by the Goel et al. Here they have done some grading. This is the grading scale done by management of the guideline for the management of severe acute pancreatitis. Next slide, please. Now, some vision statements are there regarding grading. That is, severe acute pancreatitis is associated with persistent organ failure and with organ failure having a high mortality. Both new classification system, that is the Atlanta classification and determine, both of them will be clear with infected necrosis have highest risk of death, and patient with organ failure should be admitted. Am I audible?
Yes, sir.
Next slide, please. Yeah. So this is the definition of the severity acute pancreas as per the Atlanta classification. There will be mild acute pancreatitis with no organ failure and no local systemic complications. With moderately severe pancreatitis, there might be a transient organ failure after us, and there may be local or symptomatic complication without any persistent organ failure. And for severe pancreatitis, there may be persistent or single or multiple organ failure after 48 hours. And the determined based classification, mild, there will be no organ or pancreatic necrosis. In moderate, in moderate pancreatitis, there may be a transient organ failure with sterile pancreatic necrosis, and severe, there will be persistent organ failure with infection. Next slide, please. Yeah. Regarding imaging statements on admission, we should always go for ultrasound before performing and find the etiology of the acute pancreatitis. We have to go find out the biliary pancreatitis cause, and if there is any doubt, we have to go for CT, which provides good evidence and absence or presence of pancreatitis. With all presence of the with severe for determining should be assessed with contrast and MRCP to focus for occult common. Next slide, please. Early CT scan may not show the necrotic areas of the and will not modify the clinical management in the first weeks. However, in the later weeks, CT can be considered, especially to rule out the secondary perforation peritonitis or mesenteric ischemia. Next slide, please. Next slide, please. This is a modified Balthazar scoring system, grading system of the acute pancreatitis. The CT grade is from A to E, and the necrosis, percentage of necrosis we can determine here. It's from less than 30% to more than 50%. And there is a CT severity index, which denotes from 0 to 10. It shows about the mortality and morbidity of the patient. Next slide, please. Next slide, please. So in MRI, it's more preferred to see CT in the patient with allergies to iodinized contrast. And if there is any patient is having renal impairment, they should go for unenhanced MRI. Next slide, please. Coming to the statements of regarding the diagnostics laboratory parameters, the cutoff value of the serum amylase and lipase is normally defined to be 3 times of the upper limit. C-reactive protein levels more than 150 milligram per liter on the 3rd day. Hematocrit more than 44% represent the independent risk factors of the pancreatic necrosis. Urea more than 20 milligram per deciliter. It is an independent predictor of mortality. Procalcitonin is the most sensitive laboratory test for detecting pancreatic infection. And low serum values appear to be the strong negative predictors of infected necrosis. And in absence of gallstone or significant history of alcohol use, serum triglyceride. Next slide, please. Statement regarding the idiopathic pancreatitis, biliary etiology should be ruled out with 2 ultrasound examination if the patient needs MRCP or endoscopic ultrasound to prevent recurrent pancreatitis. Next slide, please. So the risk score statement, there is no gold standard prognostic score for predicting severe acute pancreatitis. Probably a bedside index of severity like Bishop score is one of the most accurate and applicable in every score is available. And regarding the death and the organ failure, Apache 2 score can be taken as to rule out acute pancreatitis. Next slide, please. So this is the Bishop score. In Bishop score, 1 point for each criteria. That BUN level more than 8.9, impaired mental status, systemic inflammatory response system is present, age more than 60 years, and pleural effusion on radiography. All considered 1 points each in Bishop score. Next slide, please. There is one more criteria, Ranson's criteria. At presentation, patient may be more than 55, WBC count more than 16, blood glucose more than 200, LDH more than 350, and at 48 hours, hematocrit fall by more than 10%, BUN increases more than 5, despite fluid resuscitation, serum calcium less than 8, base deficit more than 4. This is the Ranson's criteria. Next slide, please. There is other Apache 2 scoring. Here also, as it suggests that scored less than 8. Next slide, please. Next slide, please. Like follow-up imaging, the statements are in severe acute pancreatitis, the CT severity index more than 3. A follow-up CT scan indicated 7 to 10 days from the initial CT scan. And in addition, CT scan are recommended only if the clinical status deteriorates or fails to continue show of any improvement. Next slide, please. Regarding prophylactic antibiotics, routine prophylactic antibiotics are no longer recommended for all patients with acute pancreatitis. Next slide, please. Antibiotics are, however, recommended to treat infect severe pancreatitis, but here the diagnosis is challenging due to the clinical pictures that cannot be distinguished from the other infections. So empirical antibiotic is given. Next slides. Types of antibiotics, routine prophylactic administration here they have said that in patients with infected necrosis, the spectrum of empirical antibiotics regimen should include both gram anaerobic and aerobic gram negative and positive microorganisms. In routine prophylactic, they have encouraged to add antifungal. Sorry, the antifungal is not recommended here. Next slide, please. Next slide. Next slide. Next slide. Next slide. Fluid resuscitation statement. Early fluid resuscitation is indicated to optimize the tissue perfusion target without waiting for any hemodynamic worsening. It should be guided by frequent reassessment of the hypodynamic status, since overfluid is known to have a decremental effect, and isotonic crystalloids are preferred fluid to treat acute pancreatitis. Next slide. Pain control. There is no evidence or recommendation of any restriction of pain medications, but we have to avoid NSAIDs if the patient is having any kidney injuries. And epidural analgesia is an alternative to can be used for pain management. Next slide. Next slide. Regarding mechanical ventilator, it can be used. It should be used when the high flow oxygen and other airway adjuncts fails, and both non-invasive and intensive technique can be used, but invasive ventilator is mandatory when bronchial secretions clearance start to be ineffective or the patient is tiring in the predict. And lung protective strategy should be used when invasive ventilator is needed. Next slide, please. Like for statement, increase if there is any intra-abdominal pressure like compartment, early surgeon, gastrosurgeon can be called. Next slide. Next slide, please. Statement indications for emergent ERCP. Routine ERCP with acute gallstone pancreatitis is not indicated. ERCP in patient with acute gallstone pancreatitis and cholangitis is indicated here. With acute gallstone pancreatitis with common bile duct obstruction is indicated, and the ERCP is also in patients with predicted severe acute gallstone pancreatitis without cholangitis or common bile duct obstruction cannot be recommended at this time. Next slide, please. Next slide. Timing of surgery. Postponing surgical intervention for more than 4 weeks after the onset of disease result in the less mortality. Next slide, please. Laparoscopic cholecystectomy during index admission is recommended for mild acute gallstone pancreatitis. When ERCP and sphincterectomy are performed during the index admission, the risk of recurrent pancreatitis is diminished. Next slide. For the statement regarding dressing changes, open abdomen re-exploration should be conducted not later than 24 to 48 hours after the index or any subsequent operation. Next slide, please. Thank you.
Well, that was a very long presentation, but a very, very important topic. Now, is there any question left on acute pancreatitis?
Well, if not, then I think I would ask Abhishek. What about chronic pancreatitis patient coming back to emergency again and again and complaining pain? How do we approach these group of patients?
So this type of patients, like I said, that chronic, definitely we have to rule out if the patient is not having any renal disorders and all, we have to again diagnose with MRI or CCTs. If the patient is not having any renal problem, then if there is no renal problem, then we can go for CCT, and or if the patient is having any renal problem, we go for MRI. After finding that the patient is having any necrosis, and regarding the going to the stores, and then if we find the patient need we will recommend the MRCP for this patient, and if patients require a surgery, then we can go for a surgery for chronic patients.
Okay, I got it. So I think your presentation will be available for the residents because some of them may not be attending this. So make sure that all the presentations are available to all the residents. So that brings to end of the sessions, which I had to moderate. I had a great pleasure of learning since morning as an audience, as a speaker, as a moderator. It has been a wonderful day, and I hand over to the organizers now.
Yes, sir. Thank you very much, sir, for your help, sir. And I thank everyone who has attended today patiently, actually, because we are exceeding the time limits. Anyway, thank you all the faculties for delivering the lecture, and thank you all delegates who have attended, and thank you Tamorish sir for taking out time from your busy schedule. And well, we say goodbye for today, and we'll see you all tomorrow around sharp at 9 o'clock. Thank you.
Thank you.